Everyone, so let's start with the upper limb. Okay, so we are gonna do the anatomy marathon now. Okay, and we are starting with the upper limb. So let's discuss the axilla. We are gonna move fast, very fast. Okay, so the shoulder dislocation is the most common dislocation. Talking about the axilla, okay, it is bound by the humerus and coracobrachialis forming the lateral wall. Okay, and the ribs and the serratus anterior forming the medial wall. Okay, and anterior wall formed by pectoralis major and pectoralis minor, and the scapula and the subscapularis muscle forming the posterior wall. Okay, and we have the content, the axillary sheath which is made up of a deep fascia, and the contents is axillary artery and vein, cords of brachial plexus, and lymph nodes of axilla. Axillary artery has first part, proximal part, deep part, and a distal part. Okay, divided by a pectoralis minor muscle. Okay, so this is the first part, giving one branch, that is a superior thoracic artery. Okay, second part is giving another two branches like a thoracoacromion trunk, which is dividing into another four branches, your APCD branches, acromion, pectoral, clavicular, and your deltoid branches. Okay, and your second part is giving another artery which is called as your lateral thoracic artery, which is the main artery of the breast. Okay, and the third part is giving three branches, that is a subscapular artery. Okay, which is giving another branch, which is a circumflex scapular artery. Subscapular artery is the largest branch of your axillary artery. Okay, and the third part is also giving a posterior circumflex humeral artery and anterior circumflex humeral artery. Okay, understood. So, and let's talk about the scapular anastomosis, which is present in a dorsal aspect of the scapula between the first part of subclavian and the third part of axillary artery. Let's say your second part of axillary artery is occluded. If the second part is occluded, okay, then there will be collateral circulation that will be established by the scapular anastomosis, so that blood flow is not affected. Okay, so this is a clinical correlation. Okay, so how it is formed? The third part of axillary will give a branch, that is subscapular artery. Okay, at the inferior angle of your scapula. Okay, and then you have your suprascapular artery that will give a thyrocervical trunk, and this thyrocervical trunk has will the first part of the subclavian will also give a transverse cervical artery. This deep branch of the transverse cervical artery, which is called as a dorsal scapular artery, anastomosis with the subscapular artery. Okay, and another branch which is given by your first part of subclavian is the suprascapular artery. Suprascapular artery anastomosis with one of the branches of a dorsal scapular artery. So there is a one point anastomosis here. Okay, another anastomosis point here, and another anastomosis here, but we have four anastomosing points. Okay, so what happens is that your suprascapular artery also gives a acromion branch of suprascapular artery, which comes in front of the acromion process, and your PCH, posterior circumflex humeral artery, which will arise from here. Your PCH will go around here. Okay, it will also give a branch to the acromion process that will called as your acromion branch of PCH. This acromion branch of suprascapular and acromion branch of PCH will now anastomose and form your another point of anastomosis. Okay, so we have four anastomosing points. Okay, so we're done with the axilla. Let's move on to the next topic. Okay, so we have our scapular spaces now. So this is the spine of the scapula. We are seeing the dorsal aspect of the scapula. Okay, so we have three spaces. Okay, this is the teres minor muscle, this is the teres major muscle, and this is the long head of your triceps. Okay, three spaces are formed. One is the upper triangular space, this one. Okay, the content of upper triangular space is your circumflex scapular artery. Okay, and then you have the quadrangular space, which the content is your PCH, or posterior circumflex humeral artery, and your axillary nerve along with it. And then you have a lower triangular space by which radial nerve will arise, and a profunda brachii artery. Okay, profunda means deep. Okay, and talking about the anterior compartment of arm, we have three muscles: your coracobrachialis, your brachialis, and your biceps brachii. This is your biceps brachii. Okay, this is your brachialis. This biceps brachii has been cut now. Okay, we'll talk more about the muscles in the osteology part. Okay, so coracobrachialis origin is from coracoid process. You can know from the name coracobrachialis. Origin is from coracoid process and inserts into the medial surface of the shaft of the humerus. Okay, and it will do flexion and adduction at the shoulder joint. And nerve supplies a musculocutaneous nerve supplies your coracobrachialis. It also pierces your coracobrachialis like this. Have I drawn here? Okay, Yes, the coracobrachialis is pierced. Okay, the coracobrachialis is pierced by a musculocutaneous nerve, which will go and supply your lateral aspect of the skin of your which will continue as a lateral cutaneous nerve of your forearm. Okay, we'll talk more about the muscles in that. Talking about composite muscles, what are the composite muscles which have two nerve supplies? In upper limb, we have pectoralis major and pectoralis minor, which are supplied by the medial lateral pectoral nerve. The brachialis, which is the medial half is supplied by a musculocutaneous nerve, lateral half by a radial nerve. So brachialis is also a composite muscle. And then we have flexor digitorum profundus, medial half by ulnar nerve, lateral half by anterior interosseous nerve. Okay, and your flexor pollicis brevis also, which is superficial head is supplied by the median nerve, deep head by deep branch of ulnar nerve. Okay, so this four muscles, their pectoralis major, pectoralis minor, brachialis. Okay, other flexor digitorum profundus and flexor pollicis brevis, which are called as composite muscles having two nerve supplies. Okay, so this completes our scapular spaces and anterior compartment. Let's move on. So now we are talking about the most important, brachial plexus. So brachial plexus is a network of nerves. It is a network of nerves that is supplying the upper limb. Okay, so it arises from the ventral primary rami of C5 to T1 segment. Okay, like the spinal cord, it has a dorsal root and a ventral root. Okay, and this dorsal root and ventral root combine to give the spinal nerve. The spinal nerve has a dorsal ramus or a posterior ramus and a ventral ramus or your anterior ramus, and all the plexuses are formed from the ventral ramus. Okay, so they arise from the ventral primary rami of C5 to T1 segments. Okay, and if C4 is contributed, then we call it prefixed, and if T2 is present, we call it postfixed. Okay, that is occasional contribution. So C5 and C6 join, C7 is separate, C8 and T1 join. Okay, this form this chord, and this one, three are formed. Okay, these are your root part. Okay, you can remember root, trunk, division, chords and branches. Right, to drink cold beer. Okay, so root, you have one branch arising from your C5, that is called as your dorsal scapular nerve, or the nerve to rhomboids, which will supply levator scapulae, rhomboideus minor and rhomboideus major. Okay, and another nerve which will arise from here like this, from C5, C6 and C7. Okay, a long nerve which will call as a long thoracic nerve. This will supply your serratus anterior. Serratus anterior is called as a boxer's muscle. Okay, it is the main muscle for overhead abduction, the strongest protractor of arm. Okay, just remember this. Then we have completed our roots. Let's move on to the trunks. Okay, so we have the upper trunk, middle trunk and the lower trunk. Okay, the root value of upper trunk will be C5, C6, you can see from here. Okay, and from middle trunk is a C7 and your lower trunk is a C8, T1. Okay, you know the root values. Okay, from the upper trunk there are no branches from middle trunk and lower trunk. From the upper trunk there arises third branch and the fourth one. Okay, the three is your suprascapular nerve, which will supply your supraspinatus, infraspinatus. Okay, and 4 is your nerve to subclavius. 4, this one, your 4, this is called as a nerve to subclavius. Okay, which will supply your subclavius muscle. Okay, and let's talk about this. Okay, we have the divisions. Okay, this dorsal division is there and the dorsal division is there. Okay, you can think of like this, that this is contributing to the middle part, this is also contributing to the middle part, but only one contribution to is going on to the upper part. Okay, so you can this is a dorsal division and a ventral division, that is going back. Okay, divisions, no branches are from your divisions. Okay, then your lateral cord is there, posterior cord is there and medial cord is there. Now we come to cords. Lateral cord root value will be C5, C6, C7. All the branches of the lateral cord will have root values C5, C6, C7. Okay, and your posterior cord C5 to T1, all you can see all the contributions here. Okay, C5 to T1 is the posterior cord and medial cord is C8 and T1 only. C8 and T1, these are forming the medial cord. Okay, so what are the branches from the lateral cord, posterior cord and medial cord? Let's see. So from the branches, lateral cord, LML branches. L means lateral pectoral nerve. From root value C5, C6, C7. This supplies your pectoralis major. This lateral pectoral nerve also pierces your clavipectoral fascia. We'll discuss. This musculocutaneous nerve has the root value C5, C6, C7. Okay, it supplies the biceps brachii, brachialis and coracobrachialis as well as the skin of the forearm. Okay, and L is again your lateral root of median nerve, that is your root value C5, C6, C7, C5, C6, C7. Okay, understood? So all of this have root value C5, C6, C7. Okay, you have to remember this branches. Okay, then about posterior cord, you can remember lunar. Your lower subscapular nerve, which will supply your subscapularis as well as your teres major. This upper subscapular nerve, which will supply only your subscapularis, and nerve to latissimus dorsi. Latissimus dorsi is the broadest muscle. This nerve to latissimus dorsi is called as a thoracodorsal nerve. Okay, and root value will be C6, C7, C8. Just remember. Okay, your posterior cord has all the root values like from C5 to T1, but this nerve to latissimus dorsi, this has the root value C6, C7, C8. This is an exceptional root value C6, C7, C8. Okay, and this axillary nerve, okay, it will supply deltoid and teres minor, okay, and this also continues at the upper lateral cutaneous nerve of arm. Okay, this upper lateral cutaneous nerve of arm. Okay, and if there is damage to it, will have a regimen Bath sign. That is a loss of sensation over upper lateral part of arm. Okay, and radial nerve C5 to T1. Just remember the root value of radial nerve C5 to T1. This is most commonly asked. Okay, and medial cord, the trick is M4U, 4 M's and 1 U. M is a medial root of median nerve, Okay, M is your medial pectoral nerve. Medial pectoral nerve supplies your pectoralis major and pectoralis minor. So you can see that pectoralis major is supplied by median pectoral nerve as well as your lateral pectoral nerve, which is supplied by pectoralis major, and your pectoralis minor is supplied by the medial pectoral nerve only. Okay, and you have medial cutaneous nerve of forearm, arm, and medial cutaneous nerve of forearm, and the ulnar nerve has root value C7, C8, T1, T1. Okay, so there is C7 contribution also in addition to your C8 and T1. You have C7 contribution also. So medial cord has C8, T1, but this is again an exception. Ulnar nerve has C7 to T1, C7, C8 and T1. Okay, understood? And brachial plexus comes to the axilla via the cervico-axillary canal. Okay, and if we talk about the axillary artery with relation to a brachial plexus, okay, this is the first part, second part and third part, which will be going like this. The first part will remain in the in the place of the trunks. Okay, and the second part in the portion of your divisions, and third part in the part of your cords. Okay, like the cords and there. Okay, so relation of the first part, what will be the relations? Okay, your lateral relation will be middle and your upper trunk. Okay, this first part lies in the place of your trunks. Okay, so middle and your upper trunk. Okay, and the medial relation will be your axillary vein. Will be passing along with its medial relation is axillary vein. Okay, and second part you can have lateral relation, that is your lateral cord. Okay, and a medial relation will be a medial cord. Posterior relation will be posterior to this, which will be your posterior cord. Okay, you can write all the branches from lateral, medial and posterior cord. And from the third part, again your lateral relation with the branches of the lateral cord. You can write the branches here also. Okay, and medial relation will be your branches of the medial cord, and posterior relation will be your branches of the posterior cord. Okay, and the sheath enclosing axillary artery and the brachial plexus is your axillary sheath. Okay, which is derived from the prevertebral fascia of the neck. We'll discuss in head and neck. Okay, and root trunk division, these are your supraclavicular parts, while cords and nerves, these are your infraclavicular parts. Okay, so you can see an important diagram here. Okay, here is the subclavian artery is divided into three parts by your scalenus anterior muscle. Okay, this is the first rib, and when it crosses the first rib, it is called as your axillary artery. When it crosses the first rib, so first rib is one of the checkpoints when it changes its name. Okay, and these checkpoints are important, and then it divides into your divided by three parts into your pectoralis minor. We know this. Okay, first part, second part and third part. Okay, and when it hits your teres major, this is another checkpoint. When it hits your teres major, it is called as a brachial artery. Okay, it is called as a brachial artery. So brachial artery is formed at the level of the lower border of your teres major. Okay, understood? So this completes your brachial plexus. Let's discuss the injuries of the brachial plexus. So we have the Erb's palsy, which is called as your Erb-Duchenne paralysis. Okay, there is the injury to the upper trunk injury is there. Root value involved will be C5 and C6. Okay, you have your C5 and C6 upper trunk injury. Okay, What will the cause? Like impact on the upper part of the soldier, like birth defects, congenital birth defects, or the forceps delivery. Forceps delivery. We have an earth point, like meeting point of C5, C6, okay, and your that dorsal scapular nerve, okay, and not your dorsal scapular, your suprascapular nerve, and your nerve to subclavius again, and anterior division and the posterior division. Okay, the 6 nerves will combine to form your earth point. We will see here in earth palsy what will happen. Axillary nerve will be affected, your musculocutaneous nerve will be affected majorly. Your axillary nerve has a root value of C5 and C6, okay, axillary nerve C5 and C6, okay. It supplies your deltoid muscle, so deltoid muscle won't be able to abduct, okay, abduction won't be there, okay. So the shoulder will be adducted, and if deltoid is also deltoid is injured, the musculocutaneous nerve root value is C5, C6, C7, okay, which supplies the biceps, brachialis and coracobrachialis, okay. So biceps and brachialis are like affected, okay, and biceps and coracobrachialis, this is supplied with the C7. As there is no effect of C7 up, C7 is not involved, so coracobrachialis muscle is spared, okay, and biceps and brachialis are supinated, so supination won't be occur, so there will be extended elbow and a pronated forearm, okay, the forearm will be pronated, okay, and due to supraspinatus, infraspinatus, teres minor, okay, this all will be affected, due to which there will be lateral rotation of the shoulder, loss of lateral rotation of the shoulder. So arm will be medially rotated. So you can see the arm like this, which is called as a policeman tip hand or a waiter's tip hand. Okay. Talking about a clump-case palsy. Clump-case palsy is the injury to the lower trunk where the root values affected will be C8 and T1. C8 is your like C8 and T1, your median nerve and your ulnar nerve, both will be affected, okay, which were supplying the intrinsic muscle of the hand, like your dorsal interossei, your palmar interossei, and your lumbricals, okay. These muscles are the work of metacarpophalangeal joint flexion and interphalangeal joint extension, ICP extension and MCP flexion, okay. So due to injury there will be extension at MCP, okay, the metacarpophalangeal joint will be extended like this, and there will be flexion of an interphalangeal joint. So if I am drawing the metacarpophalangeal joint like this, there will be extension, and flexion of an interphalangeal joint. So a finger will be like this and finger will be like this, so you will form a claw like this, are you understanding? You will form a claw. So claw hand will be there, and Horner's syndrome due to T1 involvement, where it gone, okay, yes, due to T1 involvement you will have your Horner's syndrome, due to which the sympathetic supply to the face is lost and anhydrosis will occur. We will read about Horner's syndrome later. There will be ptosis, meiosis, anhydrosis, anophthalmos, and loss of ciliospinal reflex. This all symptoms will be there. Ptosis means drooping eyelids, meiosis means constricting pupil, and anhydrosis means loss of sweating on the face. Okay. Causes of clump-case palsy, you can write about sudden abduction due to lower trunk injury will occur. Okay, like the pulling of arm, excessive pulling of arm of a baby, difficult breech delivery in which the baby comes like the normal occipital delivery is not occurring, okay, and abnormal insertion of scalene muscles may also cause your clump-case palsy, or it is also called as a clump-case degenerative palsy, okay. Then winging of scapula, the damage to muscle, that is serratus anterior is damaged. Okay, serratus anterior muscle is damaged in the winging of scapula. The medial border of the scapula will elevate away from the thoracic wall, causing a characteristic winging appearance. Okay, and loss of pulling and pushing action will occur. Okay, which will pushing action will be lost. Okay, so if the patient pushes the wall, okay, the medial surface of the scapula will be protruded out. Okay. And if the paralysis of serratus anterior muscle is there, so there is of course winging of scapula and inability to raise arm above head, that is overhead abduction is lost. Okay, and a swimmer's palsy is important. That is inability to carry arm forward in your swimming strokes, and a boxer's palsy. Okay, this is also called a boxer's palsy. The crutch paralysis will read in the radial nerve. Okay, so this completes the brachial plexus. Let's move on to the next. Okay, so let's discuss the elbow anastomosis. There is an anastomosis formed in the elbow. Okay, so here the brachial artery comes, it gives a branch like a profunda brachial artery. We'll discuss this. The brachial artery will come and divide into your radial artery and your ulnar artery, Okay, so talking about this a profunda brachial artery will be given out by the brachial artery, okay, which will divide into anterior descending branch and the posterior descending branch of profunda brachial artery. anterior descending branch, posterior descending branch. Okay, and another two branches, that is your superior ulnar collateral artery and your inferior ulnar collateral artery. Okay, in the lateral side there will be anterior descending branch of PBA, posterior descending branch of PBA, and the medial epicondylar side. Okay, you can have an inferior ulnar collateral artery which will come to the front, and the superior ulnar collateral artery which will go back. Okay, will go behind the medial epicondyle. Okay, and in radial artery and ulnar artery, two branches of radial artery and ulnar artery. The ulnar artery gives up anterior ulnar recurrent artery which fuses with your superior ulnar collateral. This anterior ulnar recurrent fuses with your superior ulnar collateral artery, and it also gives a posterior ulnar collateral, posterior ulnar recurrent artery. Okay, which fuses with the inferior ulnar collateral artery, which fuses with the inferior ulnar collateral artery. Okay, and it also gives a common interosseous artery, okay, which divides into anterior interosseous and posterior interosseous. A branch of the posterior interosseous artery, okay, which is called as a recurrent interosseous artery, which will fuse recurrent interosseous artery, this radial recurrent, not the radial recurrent, this recurrent, yes, recurrent interosseous artery, this recurrent interosseous artery. Okay, this will fuse with the anterior descending branch, anterior descending branch of your profunda brachii artery, anterior descending branch of your profunda brachii artery. Okay, and the posterior descending branch of profunda brachii artery like this, to the posterior descending branch of profunda brachii artery, which will fuse with the recurrent that artery. Okay, I told it mistake like that. Okay, this recurrent interosseous artery will fuse with the posterior descending branch of profunda brachii. Okay, and this radial recurrent, another branch from your radial artery, radial recurrent artery. Okay, which will fuse with the anterior descending branch of your profunda brachii artery. Okay, so this completes your elbow anastomosis. Okay, this completes your elbow anastomosis. Let's move on to the next. So let's talk about a cubital fossa. So cubital fossa, the lateral boundary is a brachioradialis. Okay, brachioradialis. The medial border of brachioradialis forms the lateral boundary. Okay, and the lateral border and the medial border pronated teres. Okay, the medial border with pronated teres will form your medial boundary. Okay, so it will be formed by your pronated teres and the brachioradialis forming your lateral boundary, pronated teres forming the medial boundary, and the base is the line joining the two epicondyles of the humerus, and the apex will be the culmination of your brachioradialis and pronated teres, the intersection. Okay, this is your cubital fossa. You can see in the surface anatomy. Okay, and another thing is that your median cubital vein, we'll discuss it here. It is chosen for a venous puncture or a venipuncture, okay, or a blood collection, like a venous blood is collected from here. You must have seen, okay, because this median cubital vein is present over the bicipital aponeurosis. Okay, so there is no puncture, no danger of puncture of a brachial artery. Brachial artery lies just below it. Okay, so there is no danger of a puncture of the brachial artery because it is present over the bicipital aponeurosis. Okay, the bicipital aponeurosis will protect it from the danger. Okay, and this MCV is also fixed over the bicipital aponeurosis, okay, by perforating veins. So it is firm and immovable and palpable. Okay, talking about the roof of the cubital fossa, roof is formed by your cephalic vein, in the lateral side cephalic vein, and a basilic vein in the medial side, The line joining cephalic and basilic vein are called as a median cubital vein. Okay, and this is a cubital fossa. The nerve that will be running with the cephalic vein is called as a lateral cutaneous nerve of arm, which is the continuation of the musculocutaneous nerve. Okay, and the nerve that will be running with the basilic vein will be your medial cutaneous nerve of forearm. Okay, which will be the branch of a middle cord of a brachial plexus. You must have read the medial cutaneous nerve of forearm. Okay, you have read, okay, which is a continuation of a middle cord of a brachial plexus. Okay, the floor is formed by two muscles, that is a brachialis and a supinator. What are the contents? From medial to lateral side, we have your MBBS contents. Okay, MBBS contents. So medially you have your median nerve first, and B is for your brachial artery. Okay, B is again for your biceps tendon, and S is for the superficial branch of radial nerve, Okay, so this is your MBBS contents of your cubital fossa. Okay, and this deep head of pronated is a special point. This deep head of pronated is this will separate your ulnar artery and median nerve. Separated by your deep head of pronated teres. Okay, What are the contents of cubital fossa? We saw now. Okay, from the medial to lateral side. Let's go from the medial side to the lateral side. Okay, so this is the medial side. It is first the median nerve. First the median nerve. Okay, then your brachial artery. Then your brachial artery was there. Okay, so it's dividing into a radial and ulnar artery in this this cubital fossa only. Okay, this is a tendon of your biceps brachii muscle. Tendon of biceps brachii, and then again is a superficial branch of radial nerve. Superficial branch of radial nerve. So this is forming a cubital fossa. Let's move on to the next concept. So now let's discuss about the clavipectoral fascia and the pectoral region. Okay, pectoralis major is inserted into humerus. When it contracts, there will be adduction and medial rotation of the arm. Okay, talking about the clavipectoral fascia, the muscles enclosed within the clavipectoral fascia is subclavius and pectoralis minor, not a pectoralis major. Pectoralis major is enclosed in the pectoral fascia, but clavipectoral fascia encloses your subclavius and pectoralis minor. Okay, and there is a suspensory ligament of axilla, which is the continuation of your clavipectoral fascia. Just looking at a sagittal structure of your axilla, this is a clavicle. Okay, and the muscle that is attaching from the clavicle, it is your pectoralis major. Okay, this is enclosed by pectoral fascia, not a clavipectoral fascia. This muscle below the clavicle is your subclavius. The subclavius is enclosed by this green structure. Just look, this is your clavipectoral fascia. This is a clavipectoral fascia which also encloses your pectoralis minor muscle, the subclavius and the pectoralis minor muscle. Okay, and the structures piercing, and it continues at the suspensory ligament of axilla. Continues as the suspensory ligament of axilla, and the structures that will be piercing the clavipectoral fascia. B is for a cephalic vein. Okay, artery, a vein, a nerve, and some lymphatics. V is the cephalic vein which will cross it. Okay, and A is the thoracoacromion artery. Thoracoacromion artery we have read about thoracoacromion artery in the second part of your axillary artery. Okay, and nerve is a lateral pectoral nerve. Lateral pectoral nerve will be running, which will supply your pectoralis major, which will supply your pectoralis major. Okay, and L is for lymphatics. And structures piercing clavipectoral fascia, cephalic vein, thoracoacromion artery, lateral pectoral nerve, supplying pectoralis major, and some lymphatics. Okay, talking about surface anatomy of the pectoral region. Okay, so surface anatomy is here. You have depression called as a deltopectoral triangle. Okay, and you have you can see your muscles. This is a jugular notch. This is a jugular notch present over here. Okay, and the anterior axillary fold present over here, posterior axillary fold present over here. Okay, and you have the jugular notch, jugular interclavicular suprasternal notch between the medial ends of clavicle and superior border of your sternum. The medial ends of the clavicle and superior border of sternum, about 5 cm difference. Okay, then the sternal angle is there, angle of Lewis, which is the landmark for the second rib. We'll read about it later. Talking about a deltopectoral triangle is short concept. Okay, this is superiorly bound by a clavicle, okay, anteriorly by the laterally by the anterior fibers of deltoid, and medially by the pectoralis major, So this, you can see the deltopectoral triangle. Here. Okay, so it is superiorly bound by a clavicle. The clavicle is binding superiorly. Okay, laterally by your anterior fibers of deltoid. Okay, this anterior fibers of deltoid which are binding it laterally, and your pectoralis major. This is the pectoralis major, you can see, which is binding it. This is binding it medially. Okay, and about cutaneous nerves of the pectoral region. Okay, so you have this nerve like supraclavicular nerves. Okay, and a nerve is intercostobrachial nerve, and some perforating branches of internal thoracic artery will be there. Okay, along with the nerves. Okay, and the nerves are called as the anterior cutaneous nerves, which will arise from the T2 to T6 segment. Okay, and some lateral cutaneous nerves which will accompany your lateral cutaneous branches of posterior intercostal arteries. Okay, so this completes the clavipectoral fascia and pectoral region. Okay, so let's go on to the next concept. Okay, so let's talk about the breast. Okay, it is a very important topic, and it is a long question also. So it is a modified sweat gland, and about the situation, it is present in the superficial fascia except the tail of the breast, which is your axillary tail of spans. Okay, which extends into the deep fascia. Okay, and it pierces the deep fascia by foramen of Langer. This is the foramen of Langer by which the axillary tail of spans pierces the deep fascia. Okay, and vertically it extends from the second rib to the sixth rib, and horizontally from the lateral border of the sternum to the mid axillary line. This mid axillary line. Okay, and this axillary tail of spans has the highest chance of breast tumors. Okay, and about the relations, superficial relations, skin and superficial fascia, and about the deep relations, let's talk about the deep relations. Okay, so deeply we have a pectoral fascia. Pectoral fascia, I told it surrounds the pectoralis major muscle. So pectoral fascia, pectoralis major. Then this serratus anterior muscle also. Serratus anterior is also present. Okay, and an external oblique muscle that are of abdomen, serratus anterior and external oblique. Okay, and a retromammary space. Okay, which is the space between your breast and the pectoral fascia. Okay, and in the retromammary space, your implants, prosthetics are put in the space by the surgeons. Okay, and it allows the free movement of breast on the pectoral fascia, and it's traversed by lymph nodes and blood vessels, so it is a vascular space. Okay, and about the structure, it comprises of a skin, okay, stroma and the parenchyma. Okay, about in the skin we have nipple present in the fourth intercostal space. Okay, in mostly males, since in females the size differs. Okay, and it contains some smooth muscles and richly innervated by sensory nerves and pierced by 10 to 15 lactiferous ducts. Talking about the areola, it is the dark pigmented region. Okay, and contains a large number of modified sebaceous glands, okay, which secrete the sebum and prevent the cracking of nipples and during the lactation period. Okay, and it enlarged and darkened during the pregnancy, which are called as your tubercles of Montgomery. Okay, so you can see some projections which are called as your tubercles of Montgomery. Okay, then talking about the parenchyma, we have the fatty stroma, okay, and the fibrous stroma and the glandular part. Okay, fatty stroma is present between the septum and the glands and distributed all over except the nipple and the areola. Fibrous stroma is comprising of your suspensory ligament of Cooper, okay, which hold the breast firm. Okay, and the glandular part has 10 to 15 lobes, okay, arranged in a radial fashion. Okay, and near its terminal end, this ducts also dilate to form lactiferous sinuses. Okay, so you can see the suspensory ligament of Cooper here. Okay, and your lactiferous sinuses that are opening in the nipple. Okay, and about the blood supply of the breast, it first there's the clavicle and this is a sternum. Okay, so the first blood, that is your subclavian artery will give internal thoracic artery. Internal thoracic artery comes down and gives perforating branches to supply the breast. Okay, then your another artery is the superior thoracic artery, which is also a branch of a subclavian artery, okay, which also supplies the breast. And your axillary artery, okay, axillary artery, you have the pectoral branch of the second part of the axillary, that is thoracoacromion artery, okay, which will supply the breast. And also from the second part is a lateral thoracic artery, okay, which will also supply it. And branches from intercostal arteries are also given. Okay, and then afterwards let's talk about the lymphatic drainage. Lymphatic drainage is very important. Okay, so different groups of lymph nodes, okay, which are called as axillary lymph nodes. Okay, so we have 5 pairs of axillary lymph nodes. Okay, first is the central group. Okay, central group is present here between the anterior axillary fold and the posterior axillary fold, the central group of lymph nodes. Okay, we have the anterior group of lymph nodes over the anterior axillary fold and the apical group of lymph nodes in the infraclavicular region. Okay, and the supraclavicular lymph nodes also are present, but these are not axillary lymph nodes. Okay, and we have the lateral group which are present in your medial aspect of your arm. Okay, and your posterior group which is present on the posterior axillary fold. Okay, so how is the lymph drainage? So let's say this is a breast. Okay, and 5% lymph is drained into your intercostal lymph nodes, 5% of lymph. Okay, and if it is your sternum present, then the parasternal group of lymph nodes receive about 20% of lymph. Okay, and around in the areola part we have a plexus of Sappi, and from this plexus of Sappi the lymph goes into the anterior group of lymph nodes. About 70% lymph goes into anterior group of lymph nodes. Okay, and also from the axillary tail of spans also it goes into anterior group of lymph nodes, about 70%. Okay, and from this part, distal part of your axillary tail of spans, it goes to the posterior group. Okay, so lymph is going into the anterior group from the fibrous part, whole muscular part. Okay, and from in plexus of Sappi, anterior group, okay, and the axillary tail up spans to the posterior group, and this axillary anterior group and the posterior group, these are draining into a central group of lymph nodes, and the central group is giving to the apical group of lymph nodes. So basically the lymph is going into the apical group, okay, and this parasternal group of lymph nodes, these are being drained in 20% of lymph, okay. And about lymphatic drainage of the skin except the nipple and areola, we talked about the nipple and areola here, okay, and after lymphatic drainage of the skin of the breast, okay, then we can divide the skin in this fashion, okay. The from the uppermost part, the apical part, okay, these are going to infraclavicular and the supraclavicular lymph nodes, infraclavicular and supraclavicular lymph nodes, okay, and of this quadrant, it is going to the parasternal lymph nodes, okay, and from both of the quadrants, this can cross the midline also by your parasternal lymph nodes, okay. These quadrants are drained by parasternal lymph nodes which are present on the medial side, okay, the medial quadrants, and from this quadrant the lymph is going into the axillary lymph node, okay. So your breast pathologies become bilateral because there is a parasternal lymph nodes which can transmit the lymph from this to this part, okay. So it can cross via the lymph. So tumors can cross bilaterally and form bilaterally, okay. And this from this from this inner quadrant, inferior quadrant of the breast, okay, it can drain to the subperitoneal lymphatic plexus also, okay, which can drain into hepatic lymph nodes, okay. So if there is in breast pathology which can come to the subperitoneal lymphatic plexus, which can drain into hepatic lymph nodes, and they can cause obstructive jaundice. And if from this subperitoneal lymphatic plexus it goes transperitoneally to the ovary, it can form a Krukenberg's tumor, okay. This Krukenberg's tumor is the secondary tumor of ovary due to the breast pathology, okay. So the lymphatics of the inner lower quadrant of the breast can cross the diaphragm and can reach the liver and the ovary, okay. This is called as the inner lower quadrant, okay. So breast pathologies from this can go here. Clinical anatomy is a breast cancer, that is a carcinoma of the breast, okay. 60% of carcinoma occurs in the upper lateral quadrant. So this upper lateral quadrant is the most prone area. 60% of carcinomas occur in this quadrant, okay. Talking about this is most common type of cancer in the females, usually arise from the epithelial cells of the lactiferous ducts, okay. So in this, what are the clinical presentations? The breast is fixed and immobile with the retraction of the skin, okay. Retraction of the skin will occur due to infiltration of suspensory ligament. The suspensory ligament will get fibrosed, okay, and try to infiltrate due to there will be immobility and retraction of the skin, okay. And the nipples are also retract due to fibrosis of your lactiferous ducts, okay. And there is a pudgy orange appearance due to obstruction of your superficial lymphatics. The cause is important, due to the obstruction of your superficial lymphatics, okay. So you can see the pudgy orange appearance here, okay. Orange skin will be there and scaly skin will be there, and retracted nipple due to your blockage of your superficial lymphatics, okay. And this breast abscess must be drained by radial incision, not by circular incision, because it can cause the cutting across a number of lactiferous ducts, okay. And infection can spread into neighboring compartments only, okay. So you have to cut it radially, okay. You should not cut it in circular fashion, okay, not by circular incision, okay. You should not cut by this circular incisions. It must be cut radially like this, okay. Understood? So this was about your breast, okay. Let's now move to the next concept. Let's now discuss the shoulder joint. Shoulder joint is a long question also. Ball and socket type synovial joint. Articulations are the pear-shaped glenoid cavity and the head of the humerus, okay. You have the glenoid cavity here and the head of the humerus will articulate here. The glenoid cavity is your shallow, okay. It is shallow, okay. So it is made deeper by the fibrocartilage ring, which is called as the glenoidal labrum, which will deepen the cavity, okay. Talking about the capsule of the shoulder joint, the capsule, okay. First, any joint you are describing, just describe the capsule first. So capsule attaches to the anatomical neck of the humerus, to the margin of the glenoid cavity, and to the anatomical neck of the humerus, okay. And capsule is supported by a rotator cuff muscles, okay. Then after you talking about a synovial lining, it lines the inner surface of the capsule except on the articular surfaces. So it lines the inner surface of capsule except on the articular surfaces. Articular surfaces where your glenoid cavity and the head of humerus, except these two surfaces, it lines everywhere inside the capsule. Okay, and the synovial lining also extends as a sheath around the long head of biceps. Okay, this is called as your bursa around your long head of biceps, or your bicipital bursa on biceps bursa. Okay, which is present in a bicipital groove. Okay, this is a bursa. Bursa is generally a extension of your synovial linings. Okay, and you have a subscapular bursa also. You have a subscapular bursa also. Okay, which is deep to the subscapularis muscle. Okay, so you can see the capsule here. You can take a screenshot if you want. Okay. Then talking about ligaments, there are three ligaments: glenohumeral ligament, upper band, middle band, lower band; transverse humeral ligament, which is attached between the greater and lesser tubercles of humerus; and coracohumeral ligament between the coracoid process to the greater tubercle. Just see, here is the humerus, okay, and here is a glenoid cavity. So you have glenohumeral ligaments which are connecting the glenoid cavity to the humerus, okay, and coracohumeral ligament that is connecting the coracoid process to the greater tubercle, okay, and between the tubercles, like the greater tubercle and lesser tubercle, the transverse humeral ligament, and this is stabilizing. This is holding the long head of your biceps. Okay. What are the additional secondary supports besides the ligament? You have the coracoacromial arch, the secondary support of your shoulder joint. So this is a coracoacromial arch, which is also called as the coracoacromial ligament. Okay. Between the acromion process and the coracoid process, there is a ligament which is called as a coracoacromial arch, and a musculotendinous cuff or your rotator cuff. Okay, rotator cuff muscles, we will see these are your infraspinatus, your teres minor, okay, subscapularis, and your supraspinatus. Okay, talking about your shoulder joint, this is the diagram you have to draw in your exam. Okay, so this is the pear-shaped glenoid cavity to which the long head of biceps is attached. Okay, and this is a capsule. Okay, this is a capsule, and the muscles are present around the capsule like this. Okay, so first you have the teres minor, infraspinatus, supraspinatus, and subscapularis. Okay, you have a teres minor, infraspinatus, supraspinatus, and your subscapularis. Okay, this is the diagram. Okay, and here you have the posterior fibers of deltoid, and here you have the anterior fibers of deltoid. Okay, and acromion process and coracoid process, you have to draw this diagram, and beneath the acromion process you have a subacromial or a subdeltoid bursa, okay, which is present, and the floor is formed as the long head of triceps. Okay, here you have axillary nerve going through and a posterior circumflex humeral artery going through. Okay, these were your constituents of your lower triangular space we read today. Okay, talking about rotator cuff muscles, these are supraspinatus, subscapularis, infraspinatus, and teres minor. Okay, superior relation, you can just easily write. You can write your acromion process, you can write your coracoid process, coracoacromial arch, subacromial or subdeltoid bursa, and your supraspinatus also. Okay, these are your anterior relations, and inferior relations you can write long head of triceps, your axillary nerve, and your posterior circumflex humeral artery. These three are your inferior relations. Okay, and anterior relations you can easily write. You can write your subscapularis, you can write your anterior fibers of your deltoid. Okay, this you can write in your anterior relations. Okay, and there are some muscles attached to your coracoid process. These are also anterior relations. Okay, muscles from the coracoid process that are coracobrachialis and short head of biceps, you can write in anterior relations also. Okay, and posterior relations you can easily write your infraspinatus, your teres minor, you can write your posterior fibers of deltoid. Okay, so these are your posterior relations. Talking about the nerve supply, axillary and subscapular nerves are supplying the shoulder joint, axillary and subscapular nerves. Okay, talking about this, and movement, what are the movements of the shoulder joint? So flexion is done by your clavicular fibers of your deltoid. Okay, flexion is done by clavicular fibers of pectoralis major. Okay, clavicular fibers of pectoralis major and your deltoid, anterior fibers of deltoid. These are doing a flexion. Accessory muscles which are helping is the biceps and coracobrachialis, which are helping in the flexion. Extension is done by the posterior fibers of deltoid, the posterior muscles generally. Okay, and the latissimus dorsi also. And accessory muscles is your triceps and teres major, which is helping in your extension. Abduction is done by a supraspinatus. 0 to 15 degree abduction is done by supraspinatus. Okay, 15 to 90 degree is done by middle fibers of deltoid. and 9 overhead abduction, you know, is the function of the serratus anterior and also held by your trapezius. Okay, and adduction is done by the pectoralis major. The sternocostal fibers do the adduction. Okay, the pectoralis major, the clavicular fibers do the flexion, and the sternocostal fibers do the adduction. Okay, and the latissimus dorsi also, and subscapularis and teres major, this also help in the adduction. Medial rotation, subscapularis and pectoralis major, subscapularis and pectoralis major, this help in the medial rotation. Okay, yeah, you can easily correlate. Okay, you have a subscapularis which can which come to the front and run horizontally. Okay, which will, when contract, will cause a medial rotation. You can visualize in 3D. There are many diagrams. You can follow Axillan's anatomy to visualize these movements easily. It is given very nicely there. Okay, and the accessory muscles which are helping is the latissimus dorsi, teres major, and anterior fibers of deltoid. Talking about external rotation, this is done by a posterior fibers of deltoid again, and your infraspinatus, the muscles which are back, these are doing a external rotation. Teres minor will help it. And then the applied anatomy, shoulder dislocation is commonly occurring in the inferior direction, often called as your anterior inferior dislocation in the surgical terms. Anterior inferior dislocation, the patient will come with arm close to his body and by his side. Okay, and why this anterior, this will dislocate anteriorly, because there is strong pulling by shoulder adductors and flexors. Okay, so this is normal shoulder joint, and this is your dislocated shoulder joint. That's anterior inferior dislocation of your shoulder joint. You can see it is out of your glenoid cavity. This is a glenoid cavity, and the shoulder, the humerus head is out. Okay, dislocated shoulder. After shoulder joint, let's move on to our next concept. Talking about an elbow joint, or it is also called as a humero-ulnar joint. Okay, it is also a type of hinge joint. You can get a short note on elbow joint, not a long question. Articulation is the trochlea and capitulum. Okay, and the capitular notch of trochlea. Okay, you have your trochlea and capitulum, and your trochlear notch of ulna. Okay, so if we have a schematic diagram here, okay, this is a humerus, okay, and you have a radial fossa over it and the coronoid fossa over it. Okay, and you have your radius and ulna here. Okay, and this is the coronoid process of ulna. And annular ligament is present over the radius. So this is the capsule which will incorporate your radial fossa as well as your coronoid fossa. Okay, in the humerus. Okay, this is the capsule, and if you see posteriorly, then this will look something like this. This will be a humerus. Okay, the ulna will be in this side and radius will be in this side. The olecranon of your radius, okay, will articulate to the olecranon fossa of your humerus. Okay, and the capsule will just go by the that articulation points. Okay, so this capsule is in this shape. Okay, you can just visualize the capsule. Okay, and about the ligaments, okay, we have your lateral ligament, which is also called as a radial collateral ligament. Okay, so it is attached to a lateral epicondyle, and it is going to your annular ligament of the radius. Okay, lateral epicondyle of a humerus to the annular ligament of your radius. Okay, this is a radial collateral ligament. It has many bands arranged in radial fashion. Okay, and about this, look at this. This is a radial collateral ligament. The bands are going like this. Okay, the bands are going like this. Okay, and about the medial ligament is called as the ulnar collateral ligament. As you can see, your lateral is radius, so it is called as radial collateral, and the medial part is the ulna, so it is called as a medial collateral ligament. Okay, so this is the medial epicondyle, of the humerus, and from this medial epicondyle, the posterior band will be. This is the posterior band, this will be the anterior band, and oblique band in between. Okay, this will form your ulnar collateral ligament. Okay, after this, nerve supply is the median, ulnar, radial, and all your musculocutaneous nerves. Okay, median nerve, ulnar nerve, radial nerve, and your musculocutaneous nerves. These all nerves supply your shoulder joint. Okay, talking about the anterior relations. You just imagine. Okay, anteriorly, what must be present anteriorly to shoulder joint? All your relations of a cubital fossa, right? Because cubital fossa is just in front of your shoulder joint. Okay, so you can write all the components of a cubital fossa. Okay, all things you know. Okay, posteriorly you have your triceps brachii muscle, of course. Okay, laterally you have your common extensor tendon. Okay, and your supinator muscle. Laterally you have your supinator muscle, and medially you have your ulnar nerve. Medially. Okay, Flexion is caused by brachialis, biceps, and a brachioradialis. This BBB muscles cause your flexion, and extension is by triceps and your anconeus. Okay. Clinical anatomy: dislocation of shoulder joint is most common in posterior direction. Okay, if this is a shoulder joint, the dislocation direction is this posterior dislocation most common. Okay, because it is mostly associated with the fracture of a coronoid process. Mainly the coronoid process is fractured. Okay, what is pulled elbow? Pulled elbow is that in children, your annular ligament is not yet developed. Okay, due to this, the head of radius will come out of the annular ligament. The head of radius will come out of the annular ligament. Okay, this is most common in kids because the annular ligament is loose in case of kids. Okay, so this is the pulled elbow. Okay, so talking about forearm. Forearm has an anterior compartment and a posterior compartment, and anterior compartment has flexor muscles while posterior compartment has extensor muscles. Okay, anterior compartment is divided into superficial group and deep group. What are the superficial muscles? So first is the pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris, and flexor digitorum superficialis, and FDS, flexor digitorum superficialis. In some books, it is in an intermediate group. Okay, there is a separate group, that is intermediate group, where this is included, but we are including it into superficial group only. And deep group, we have flexor digitorum profundus, FDP, flexor pollicis longus, and the pronator quadratus, FDP, FPL, and the pronator quadratus. Okay, this is the deepest. Okay, so talking about the superficial muscles. Okay, and just see this atlas images. Okay, so first of all, you have your pronator teres. Here you have pronator teres forming your boundary of a cubital fossa. Okay, forming a medial boundary of a cubital fossa. Then you have flexor carpi radialis. Okay, you have the palmaris longus, is long shiny tendon of palmaris longus which is dividing. Okay, and flexor carpi ulnaris, FCU. Okay, and this is going to the carpals. And palmaris longus is extending as a palmar aponeurosis. Okay, palmaris longus extends as the palmar aponeurosis. Okay. And talking to the pronator teres, it has superficial head and a deep head. Okay, origin is a medial supracondylar ridge, and inserting into the lateral to the shaft of the radius. Okay, and the flexor digitorum superficialis. Okay, if you remove these muscles, you can get the flexor digitorum superficialis. We put it in your superficial group only. Okay, but it is lying a little bit deep. So it is this bag like shaped muscle. Okay, and you have the tendons also of flexor digitorum superficialis. You have the tendons of flexor digitorum superficialis. Okay, and it goes towards the digits. Okay, it goes towards the digits and splits and attaches to the middle phalanx. Okay, the attachment of FDS is to the middle phalanx. Okay, so ulnar nerve and ulnar artery go beneath it. We'll see also in the ulnar nerve course. Okay, so this is let's discuss about the deep muscles of the anterior compartment. Okay, so I have a flexor pollicis longus, FPL is there, and which is the tendon of FPL is attaching to the thumb. Okay, and you have the flexor digitorum profundus, which has also tendons. Okay, okay, that are going here, and here. Okay, these are the here and here. Okay, these are your FPL tendons. Okay, and FDP tendons. Okay, flexor digitorum profundus tendons. Okay, and this flexor digitorum profundus tendons are just like inserting. Okay, into this are lying deep, and over the FDP tendons, over the flexor digitorum profundus tendons, we have our flexor pollicis, your flexor digitorum superficialis tendons. Okay, and pronator quadratus, the quadrangular muscle, and the deepest muscle. Okay, back of the forearm, we have superficial muscles and deep muscles like that. Superficially, we have a brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris. Okay, brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris. Okay, so minimi means you're going to the your little finger. Okay, and deep muscles, we have a supinator muscles. Okay, you have extensor indicis, we have extensor pollicis longus, extensor pollicis brevis, and abductor pollicis longus. Okay, these all are your deep muscles, supinator, your extensor indicis, extensor pollicis longus, extensor pollicis brevis, and your abductor pollicis longus. So you have to mug up a bit, okay, just remember a bit. Let's talk about the muscles. Okay, let's talk about the muscles. This is a superficial view of superficial muscles of the forearm. Okay, so first one is a ECRL, extensor carpi radialis longus. Okay, extensor carpi radialis longus, then extensor carpi radialis brevis. Okay, and talking about this is a brachioradialis. This is a brachioradialis. Okay, is it labeled? Maybe okay, brachioradialis is this point. Okay, sorry, this is the brachioradialis, this is the lateral part, right? What I am saying, this is the lateral part, thumb is there. Okay, so brachioradialis, where brachioradialis very less seen in this part. Okay, brachioradialis, then your extensor carpi radialis longus, extensor carpi radialis brevis. Okay, then your extensor digitorum has also 4 tendons. Okay, extensor digitorum has also 4 tendons. And again, your extensor digiti minima is there, which is going to your little finger, and extensor carpi ulnaris is there also. Extensor carpi ulnaris is there, okay, which will go in the ulnar side. Okay, and the attachment of extensor carpi radialis brevis is to the second metacarpal. The attachment of extensor carpi radialis longus is to the third metacarpal. Understood? After that, let's discuss some other muscle. Like you have the supinator here, you have the superficial head of the supinator muscle here, okay, which comes from behind, covers the lateral side of the radius. Okay, supinator is a deep muscle of your posterior compartment of forearm. Okay, and you have the abductor pollicis longus here, okay, and the extensor indicis is present here. We saw your supinator. Then afterwards we had a extensor indicis, so it's going to the index finger. The tendon is going to the index finger. Your extensor pollicis longus, going to the thumb. Okay, it comes from your ulna. And then extensor pollicis brevis, this is a short muscle. Okay, small muscle. Longus is long and your brevis is small. Okay, and then your abductor pollicis longus is again going towards the thumb. Okay, talking about supination and pronation. So axis for supination and pronation. Okay, it passes from the head of the radius to the articular disc of your inferior radioulnar joint. Okay, from your head of the radius, to the inferior radioulnar joint. This is the axis. Okay, and the head of the radius rotates within the annular ligament. Okay, in pronation, so what happens in pronation is that in your pronation, okay, lower end of the ulna goes posterior laterally. The ulna goes posterior laterally. Okay, posterior laterally, so that pronation will occur, the prone position will occur. Okay, so this hand will be like going like this. Okay, this will go posterior laterally. So axis will change. The strength of the movement supination is more stronger than your pronation because it is helping in the screwing movement. Okay, and the muscles for pronation is a pronator quadratus and a pronator teres. Pronator quadratus is the main muscle for pronation. Pronator teres is a helping muscle. Okay, and the muscle for supination, you have supinator with elbow extended. When the elbow is extended, it's a supinator, and supination is also done by the biceps brachii when the elbow is flexed. Okay, Volkmann's ischemic contracture. This is the fibrosis of your forearm muscles, majorly the flexors. Okay, flexors are fibrosed, causing a Volkmann's ischemic contracture. Okay, and the most common cause is the injury to the brachial artery in the supracondylar fractures of humerus. This is the cause of your Volkmann ischemic contracture. Okay, this completes the forearm. Let's move on to the next concept. So now we are discussing our anatomical snuff box. Okay, so what are the boundaries of anatomical snuff box? So have the lateral boundary, that is the adductor pollicis longus and extensor pollicis brevis, your APL tendon and your EPB tendon. Your APL tendon, EPB tendon are forming the lateral boundary. Okay, and the EPL tendon, extensor pollicis longus tendon, EPL tendon is forming a medial boundary. Okay, and the content is the radial artery of your anatomical snuff box. Okay, and floor is from the bony projections of a scaphoid, trapezium, base of first metacarpal. You can see here. Okay, these are forming by your scaphoid. This is a scaphoid. Okay, and this is a trapezium, and the base of a first metacarpal is also forming the floor of your anatomical snuff box. And ECRL and ECRB tendons, your extensor carpi radialis longus, extensor carpi radialis brevis, these tendons are also forming the floor of your anatomical snuff box. Okay. And roof, against anything you have the roof, you write skin and superficial fascia. Okay. And all the lateral content of your cubital fossa also, like a cephalic vein was there, and superficial branch of radial nerve. Okay. Cephalic vein and the superficial branch of radial nerve, these are forming your roof of your anatomical snuff box, and content is a radial artery. Okay. Talking about extensor retinaculum, we have a flexor retinaculum and extensor retinaculum in both your upper limb as well as your lower limb. So we are now learning about upper limb. Okay, so we are discussing the extensor retinaculum of your upper limb. Okay. First thing, so you are making a fist and you are cutting a transverse section of this. So the plane will pass like this, and you will be seeing inside this. Okay, so you will see about six components of your extensor retinaculum. Okay, 6 components of your extensor retinaculum. So you have this orientation in mind. Okay, from your anatomical snuff box discussion, you have APL and EPB tendons here, APL and EPB tendons, and EPL tendon also. Okay, and ECRL and ECRB were forming a floor of your anatomical snuff box. Okay. The EPL will be the first component. Okay, the second component is ECRL and ECRB, and the third component will be your APL and EPB tendons. Okay, so you can easily write the first, second, and third component. Your first component will have your extensor pollicis brevis and abductor pollicis longus. Okay, APL and EPB tendons. Okay, so you just make a shape of the radius like this and ulna. Okay, and you have to just make the components. Okay, and divide it into 6 parts. Okay, so EPL and APB, EPB and APL, these tendons are forming a first component. Second component ECRB and ECRL. The third one is the extensor pollicis longus. Okay, you can easily write up to this. Okay, after that, the fourth component is made up of by extensor digitorum and extensor indicis. You remember extensor digitorum and extensor indicis. So extensor digitorum was a muscle of a superficial component of the back of the forearm, and extensor indicis is the muscle of the deep component. So it is extensor digitorum is lying superficially and indicis is lying a bit deep. Okay, this is the fourth compartment. And you have 2 other things in the fourth compartment, that is the posterior interosseous nerve and your anterior interosseous artery. Posterior interosseous nerve and anterior interosseous artery. Okay, this anterior interosseous artery, you remember it was there in your elbow anastomosis. You go and revise. Okay, and the fifth component will have extensor digiti minimi tendon, and extensor carpi ulnaris will be present in your sixth component, compartment. Okay, understood? So this completes all your compartments and your extensor retinaculum. Okay, let's now move on to the next topic, that is your flexor retinaculum. Okay, so discussing about flexor retinaculum. Okay, so flexor retinaculum, what are the articular surfaces, like to what it is attached? Okay, so we have your hook of hamate, bone. Okay, these are your carpal bones. Okay, and you have many carpal bones, like the scaphoid is there, lunate is there, triquistrum, pisiform. Okay, capitate, hamate, trapezium, and trapezoid. Okay, so we have our hook of hamate. Okay, this projection of hamate, hook of hamate. Okay, and the pisiform bone, hook of hamate and the pisiform bone. Okay, pisiform bone, a ligament is there between the hook of hamate and the pisiform, which is called as a pisiform hamate ligament. The crest of trapezium and the tubercle of scaphoid. Okay, to which this flexor retinaculum is attached. Okay, and what are the contents? Okay, what are the structures that are passing? The palmaris tendons, the palmaris longus tendons, this pass superficial to the flexor retinaculum. Okay, the ulnar nerve passes superficial to the flexor retinaculum, and the palmar cutaneous branch of ulnar nerve which supplies the skin of hypothenar eminence. Okay, also passes superficially. The ulnar artery also passes superficial to the flexor retinaculum. Okay, and the radial nerve, superficial branch of radial nerve, this passes superficial, not the whole radial nerve. The superficial branch of radial nerve passes superficially, and the median nerve passes deeply. So there is a superficial branch of median nerve also, which is called as the palmar branch of median nerve. Okay, it supplies the skin over the thinner eminence. Okay, this is a palmar branch of median nerve which passes superficially. Okay, so the importance of flexor retinaculum to provide passageway for the long tendons of your palmaris longus. Okay, so these are your lateral attachments, these are your medial attachments. Okay, you can just write about the attachments. Okay, after attachments, let's discuss. Okay, what is the transverse section. Okay, if you take the transverse section, this diagram is very important to draw this diagram in your exam. Okay, so we have this bones, we have this carpal bones here, we have the carpal bones present over here, and this is the flexor retinaculum. Okay, so what are the contents that are present inside the flexor retinaculum? Okay, so we have the FPL tendon, the flexor pollicis longus tendon. Okay, and surrounded by a radial bursa. FPL tendon is enclosed by a radial bursa, and then FDP tendons, flexor digitorum pollicis tendons. Okay, flexor digitorum pollicis tendons, which are enclosed by your ulnar bursa, and the flexor digitorum superficialis tendons also. Okay, flexor digitorum superficialis tendons. These both tendons are enclosed by your ulnar bursa. Okay, and then we in the flexor retinaculum we have a deep slip of flexor retinaculum and have a superficial slip, and the superficial slip is called as a volar carpal ligament. Superficial slip is called as a volar carpal ligament, which contains your ulnar nerve as well as your ulnar artery. The superficial slip contains your ulnar nerve as well as your ulnar artery. Okay, and this deep slip has your FCR tendon. Okay, FCR tendon. This deep slip has a flexor carpi radialis tendon, and median nerve is present just below the flexor retinaculum. So if there is compression of a median nerve, we suffer from carpal tunnel syndrome. As it happens in case of ulnar bursitis. If this ulnar bursa is inflamed, okay, if this is inflamed, this will compress this median nerve inside the flexor retinaculum and will produce a carpal tunnel syndrome. Don't be confused with the cubital tunnel syndrome. Likewise, in lower limb we have a tarsal tunnel syndrome, obviously. Okay, so if you can identify the structures, just take a screenshot. Okay, and try to identify the structures. I have discussed all the structures. You can take a screenshot and identify. So this finishes your flexor retinaculum. Let's now talk about the next concept, which is your muscles of hand. Okay, so in hand we have about 20 muscles. We have about 20 muscles in our hand. Okay, 20 muscles. So 4 thinner muscles, 4 hypothinner muscles. Okay, 4 lumbricals and 8 interossei. Okay, palmar interossei and dorsal interossei. Thinner eminence, you know, this thumb and the palm. The eminence of the palm, which is just below the thumb, is a thinner eminence, and the eminence of middle finger is called as your little finger is called as a hypothinner eminence. Okay, thinner muscles we have adductor pollicis brevis, flexor pollicis brevis, opponens pollicis, and your adductor pollicis. Okay, we have abductor pollicis brevis, flexor pollicis brevis, opponens pollicis between these both upper 2 muscles, and your adductor pollicis. So adductor pollicis is a thinner muscle. It is a thinner muscle, but it is not of thinner eminence. Okay, it is not present in a thinner eminence, but it is a thinner muscle. Okay, then about hypothinner muscles, we have the abductor digiti minimi, flexor digiti minimi, opponens digiti minimi, and palmaris brevis, which is the only subcutaneous muscle that comprises of your hypothinner eminence. Okay, and these thinner muscles are supplied by your median nerve, except your adductor pollicis, which is supplied by your ulnar nerve. Adductor pollicis is supplied by your ulnar nerve. Okay, and hypothinner muscles are all supplied by your ulnar nerve. Okay, and this adductor pollicis is the last muscle to be supplied by your ulnar nerve. Okay, we'll see when we discuss ulnar nerve. So medial to lateral, and from medial to lateral side, this is our skeleton of your hand. You can see this is our skeleton of your hand like this. Okay, so I have drawn all the carpal bones here. Okay, the pisiform bone, the scaphoid, the lunate, tricostrum, pisiform, hamate, capitate. Okay, and the trapezoid and the trapezium. Okay, all these bones I have drawn, and your flexor retinaculum will be there like this. Okay, so what will be the attachments of these muscles? Okay, the abductor pollicis brevis, a muscle of your thinner eminence. Okay, this will go from the trapezium. To the proximal phalanx, to the proximal phalanx. Okay, and flexor pollicis brevis will go laterally, a bit laterally, and to the same proximal phalanx of the thumb. Okay, and the opponens pollicis will just start from your trapezium and will just end to the proximal part of your metacarpal bone. Okay, the proximal part of your metacarpal bone. Okay, let's talk about adductor pollicis. So adductor pollicis has two heads. There's a transverse head and oblique head. So oblique head arises from capitate and trapezium. It arises from a capitate and you can say index finger. Okay, metacarpal of the index finger and the capitate. Okay, you can say, or your trapezium you can also say. So it arises like this, oblique head, and attaches to the same proximal phalanx. Okay, and the transverse head, okay, arises from the distal part of the metacarpal of the middle finger. Okay, and will go to attach to the proximal phalanx. Between the transverse and the oblique head, we have our radial artery present. Okay, so radial artery is present over here. Okay, and talking about your different things like your hypothenar muscles. Okay, your opponens digiti minimi. Okay, this starts from a hamate. Okay, this starts from a hamate and attaches to the proximal part of your metacarpal of a little finger. Okay, and from your hamate and pisiform, between the hamate and pisiform, okay, both muscles, your flexor digiti minimi and your abductor digiti minimi. Okay, this both will start and will also enter insert into your proximal phalanx of the little finger. Okay, understood? So these were all your muscles about thenar and hypothenar muscles. Talking about lumbricals, we have 4 lumbricals which originate and insert in tendons only. Okay, which originate and insert in tendons only, not in bones. Your L1 and L2 lumbricals are called as unipinnate. These are unipinnate like this. They're unipinnate. Okay, and this L3 and L4, these are bipinnate lumbricals like this. Okay, they're shaped like this. Okay. So L3 and L4 are bipinnate. Unipinnate, L1 and L2 are supplied by median nerve, while the L3 and L4 are supplied by your ulnar nerve. Okay, so you can remember like this, that 1 and 2 come first. Okay, 1 and 2 will come first. Okay, and in alphabet also M will come first, then U. Okay, and L3 and L4 means come later, that is your ulnar nerve. Okay, understood? So drawing about this CA drawing. Okay, CA diagram. So here you have the tendons. You have the tendons of FDP, flexor digitorum profundus tendons. Okay, from which your L1 lumbricals will start. Okay, and will enter into the dorsal digital expansion of your extensor digitorum tendons. Okay, the extensor digitorum will form tendons and have dorsal digital expansions. Okay, they have expansions in the like digits. Okay, it will insert into the dorsal digital expansion. Okay, talking about L2 lumbrical, which is also unipinnate, also attaches to the between the index finger and your middle finger. It attaches between the web space. Okay, and L3 lumbrical is bipinnate and it attaches to the third web space. Okay, between your middle finger and your ring finger. Okay, the L3 lumbrical, which is bipinnate, and L4 lumbrical attaches to the last web space, that is between your ring finger and your little finger. Okay, and function is a flexion at MCP joint. Okay, they will cause a flexion at MCP joint, extension at IP joint. So they are basically trying to keep the hand like this. Okay, if there is defect to this lumbricals, you will have your claw hand. Okay, you will have your claw hand as it occurs in your Klumpke's palsy. Talking about interossei muscles, you have 8 interossei, 4 palmar, 4 dorsal. Okay, and just remember, median nerve is called as a laborous nerve. Median nerve is also called as a laborous nerve. Okay, just remember. And this palmar and dorsal interossei are all supplied by the ulnar nerve. Ulnar nerve is responsible for fine movements during playing instruments like your keyboard. Okay, you are playing the piano, so ulnar nerve is used for it is fine nerve of hand. Okay, it is the main nerve of hand. Ulnar nerve is the main nerve of hand also. Okay, it is also called as a musician's nerve. Talking about the palmar and dorsal interossei, so just remember PAD and DAB, PAD and DAB. Okay, so PAD means your palmar interossei. P is the palmar interossei which will do adduction. Okay, and D is the dorsal interossei which will do abduction. Palmar interossei will do adduction and dorsal interossei will do abduction. Okay, and palmar interossei are unipinnate while the dorsal interossei are bipinnate. Dorsal interossei are bipinnate. Okay, and the axis is the middle finger. Middle finger is the axis for adduction and abduction. Adduction and abduction. Middle finger is your axis. About the palmar interossei, how they are inserted. Okay, so this is the P1 palmar interossei. Okay, which gets attached to the same proximal phalanx of your thumb. Okay, P2 also same. And in the middle finger, we don't have any palmar interossei. So palmar interossei is absent in the middle finger. Okay, which is the axis finger. And P3 gets attached to the proximal digit of your proximal phalanx of your ring finger. Okay, and P4 is attached to the proximal phalanx of your little finger. Okay, so these are your attachments of your palmar interossei, and there is no palmar interossei in middle finger. So if middle finger is also lost, there are the palmar interossei muscles are not affected at all. Okay, and palmar interossei have the function of adduction means taking the fingers towards the axis. Okay, and about the dorsal interossei, the axis is again the middle finger. Okay, dorsal interossei are bipinnate. So first dorsal interossei between this metacarpals of your thumb and your index finger, and between your index finger and your ring finger, middle finger, you have the dorsal interossei 2. Okay, D2, which is attached to your proximal phalanx of the middle finger. Then you have dorsal interossei 3, which is also attached to the middle finger. Okay, so middle finger has two dorsal interossei attachments. Okay, two dorsal interossei. It has two dorsal interossei attachments. And D4 is your dorsal interossei 4. Okay, and it is attached to the ring finger. It is attached to the proximal phalanx of your ring finger. Okay, so insertions are absent where here there is no insertion in your little finger, and in the thumb also there is no insertion at all. Okay, this completes your muscles of hand. Okay, now let's move on to the next concept. Let's talk about some spaces in hand. In hand we have some spaces created. Okay, some spaces are there in your hand. So let's talk about, we have the thinner space, we have mid palmar space, we have the pulp space, and the forearm space of Perona. The thinner, mid palmar, pulp space, and forearm space of Perona. Okay, so here we have the tendons of FDS and FTP, which is enclosed by the radial bursa. So the ulnar bursa looks like this, and the radial bursa which is enclosing the tendon of FPL, your flexor pollicis longus. Okay, and these are covered separately by bursa. Okay, so these three fingers are safe to prick, because if you prick in your little finger or your thumb, okay, the infection can travel to the limb. Okay, it can travel to the upper limb back. Okay, it can travel back to the upper limb. Okay, then we have a diagram here. We are taking the TS of the hand at the level of shaft of the metacarpal. This diagram is very important. This can come in your exam, and you have to draw this diagram in your nerves also. You will see that this diagram will be applicable. This diagram will be helpful. Okay, so what we have drawn is that first draw your phalanges, your 1, 2, 3, 4, and 5. Okay, and to which your palmar interossei are attached. Okay, your palmar interossei are there. Okay, 1, 2, and there is no palmar interossei in 3, 4, and 5. Okay, and the dorsal interossei are there, bipinnate dorsal interossei are there in this fashion. Okay, and to this third, another thing attached is your transverse head of adductor pollicis, which is also attached. Okay, and this one is a hypothenor eminence at the fifth. Above the fifth is the hypothenor eminence, and above one is a thinner eminence. Okay, and the medial septum covers all this. Okay, and intermediate septum goes like this to the third finger. Okay, to the third finger, and your lateral septum is covering this thinner eminence. Okay, so we have median septum, we have your intermediate septum, and your lateral septum present. Okay, and here you have the tendons. Okay, this circle ones that are blank circles are tendons of FDS. These are tendons of FDS, flexor digitorum superficialis, and this block green ones are the tendons of FDP. Okay, flexor digitorum profundus. Okay, And to this FDP tendons, we have the attachment of lumbricals L3, L4, L1 and L2. L1 and L2 are unipinnate, and these are supplied by which nerve? Median nerve. And this L3 and L4 are bipinnate and supplied by your ulnar nerve. Understood? So we have a space created here which is called as a mid-palmar space, okay, and a space created here which is called as a thenar space. Mid-palmar space and your thenar space is there. Okay, so this diagram I have explained. So thenar space communicates to the fascial sheath of the L1 lumbrical. So L1 lumbrical and the thenar space you can see are continuous. Okay, so infection in thenar space can be drained by putting an incision on the first web space. Okay, first web space incision will pierce the sheath of your L1 lumbrical, will pierce the sheath of your L1 lumbrical, and you can drain any infection from your thenar space. Okay, and the mid palmar space communicates the fascial sheath of L2, L3 and L4. Okay, L2, L3 and L4. This is L4, not L3. Okay, L2, L3 and L4. Okay, this this communicates to the mid palmar space. So any infection in the mid palmar space can be drained by incision on third and fourth web spaces. Okay, third and fourth web spaces. Understood the clinical aspects. And mid palmar space also communicates proximally to the forearm space of Parona. Forearm space of Parona. This is a fascia between the FDP, FPL. This between the FDP, FPL and the pronator quadratus. Okay, so forearm space of Parona is a space between your FDP, FPL and your pronator quadratus. Okay. Next we have the pulp space of fingers. Okay, pulp space of fingers are there. Okay, so let's say here is a finger. These are your pulp spaces created. Pulp spaces are created like this. Okay, and these have connective tissue septum. Okay, let's say this is a distal phalanx and this is a proximal phalanx. Okay, so pulp spaces are connected by created by connective tissue septum. Okay, connective tissue septum, and there is a digital artery. Digital artery will come here. Okay, and supply the uppermost part, the condylar part of your distal phalanx. Okay, and the whole bone of the distal phalanx, and also gives a branch to the base or the epiphysis of your distal phalanx. Okay, and this branch to the epiphysis, this doesn't it is not included in your pulp space. Okay, and pulp space infection like a Whitlow or Phelan, these are pulp space infections. Okay, in which there will be avascular necrosis of distal 4/5 of terminal phalanx. Okay, there will be avascular necrosis of distal 4/5 of your terminal phalanx. So this will be avascularly necrosed. Okay, why distal 4/5? Because there will be no effect on the proximal part of your distal phalanx. Okay, because this is not within your pulp space. Okay, understood. So let's discuss about the course of arteries in your hand. Okay, so radial artery will come. Radial artery, this is seen in your this part is seen in your anatomical snuff box. Okay, and your superficial branch of radial artery comes here. Superficial branch comes here. Okay, superficial branch will come here like this. Okay, and your ulnar artery, there is a deep branch. Deep branch goes like this, and a superficial branch of your ulnar artery comes like this. Okay, the superficial branch of ulnar artery is there, and your of a radial artery, this is your superficial branch of radial artery there. The superficial branch of radial artery is the content of your you just know that it is the content of your cubital fossa. Okay, and it completes the superficial palmar arch, which is formed by a superficial branch of your ulnar artery and superficial branch of your radial artery. Okay, and this it also gives a deep branch of ulnar artery. Okay, which communicates with your which also communicates with the deep deep branch of a radial artery, also deep branch of a radial artery, as it pierces the first dorsal interossei and comes. Okay, and completes this deep palmar arch. Okay, and this deep palmar arch also gives a branch to the princeps pollicis artery, to the thumb, which is called as a princeps pollicis artery, and also to the index finger, which is called as a radialis indicis artery. Okay, and from the superficial palmar arch, or the deep or the superficial branch of your ulnar artery. Okay, this common branches are given. This common branches, this common branch. Okay, which will divide into two proper branches each. Okay, and again it will also give the superficial branch of your ulnar artery. superficial palmar arch will also give another branch which is a proper branch, which is a direct proper branch. Okay, so this is your arterial arrangement in case of your hand. Okay, so let's now move to the next concept, that is of nerves. Okay, we'll discuss all three nerves. So let's talk about the radial nerve. Radial nerve, root value is C5 to T1, all the root values of your brachial plexus. Okay, it starts from the posterior cord of your brachial plexus, we know this. Okay, it goes into lower triangular space of your scapula. We know this also, lower triangular space. The content is your radial nerve only. Okay, and your moves around the spiral groove of the humerus. So humerus has a spiral groove, via which your radial nerve moves. Okay, and it comes to the lateral aspect of arm. Okay, pierces the lateral intermuscular septum, descends in front of the septum, pierces it and descends in front of the septum, reaches the front of your lateral epicondyle. Okay, reaches the front of your lateral epicondyle and divides into superficial branch and a posterior interosseous nerve. Okay, so superficial branch of radial nerve. Okay, it leaves the cubital fossa by passing deep to your brachioradialis. Okay, so superficial branch of radial nerve, you know, is the content of your cubital fossa only. Okay, and this leaves the cubital fossa by passing deep to brachioradialis. We also saw in brachioradialis that your radial artery and your radial nerve were passing, okay, deep to the brachioradialis. Okay, then it appears at the roof of the snuff box. We also saw, okay, that it is also a content of a snuff box. Okay, your snuff box, that is radial artery is there. Okay, but radial nerve is the roof of the snuff box. Okay, and it also supplies the skin. It supplies the skin on the lateral 3/2 of the dorsum of the hand and fingers. Okay, except the nail beds. It supplies the skin on the lateral 3/2 of the dorsum of hand and fingers. Okay, if I just show you, okay, this is the lateral 3/2 of the dorsum of the hand and fingers. Okay, supplied by the superficial branch of radial nerve. Okay, this nail beds won't be supplied. This nail beds will be supplied by the median nerve. Okay, it supplies the dorsum of the lateral 3/2 of the hand. Okay, and about the posterior interosseous nerve, what about this? This posterior interosseous nerve passes between the lamina of a supinator muscle. Okay, it runs behind the interosseous membrane. Okay, from radius to ulna there is an interosseous membrane. It runs behind the interosseous membrane and supplies the extensor compartment of your forearm. Okay, so what is the course of radial nerve? In axilla it gives one branch to the triceps. Okay, which supplies the longitudinal and your medial head of your triceps. Okay, and then the long head and the medial head of the triceps. Okay, and then it comes in the radial groove. Okay, in the spiral groove. Okay, it gives another branch to the triceps and anconeus when suppose medial and the lateral head. So medial head is supplied 2 times. Okay, in the triceps. Okay, and the anconeus too. So afterwards, then it pierces the lateral intermuscular septum, descends in front of it. Okay, gives 2 branches to the brachioradialis and to the ECRL, the extensor carpi radialis longus. Okay, and then comes in front of your lateral epicondyle. Okay, and divides into superficial branch and your deep branch. And this not the deep branch, the posterior interosseous nerve. This posterior interosseous nerve, this passes between the laminae of a supinator muscle. Laminae of the supinator muscle. This is supinator muscle. Okay, and this posterior interosseous nerve will supply all the extensors, okay, ECRL, your ECRB, EPL, EPB, EI, EDM, and extensor digitorum. If you forget all this, remember extensor digitorum will be supplied by the posterior interosseous nerve. Okay, and the superficial branch of radial nerve will supply the dorsum, the lateral 3/2 of the dorsum of the hand. Okay, and except the nail beds. Okay, so what is crutch palsy? Crutch palsy, radial nerve injury occurs at axilla. Okay, let's assume this point is injured. Okay, this point is injured. Okay, so you will have crutch palsy. Due to paralysis of triceps, the whole paralysis of triceps will occur. And triceps is the major extensor, you know. Triceps is the major extensor. So there will be flexed elbow. The elbow will be flexed. Okay, the elbow will be flexed. The wrists will be flexed because wrist drop. Why? Because due to paralysis of a major extensor of the wrist. Why? This if this is injured here, okay, there will be no transmission here, and all these muscles will fail. All this muscle will be paralyzed. okay, all these muscles will be paralyzed, okay, like your this one also, your extensor muscles also, okay. So your wrist will be flexed, okay, wrist extensors will be damaged, so this will be flexed, and your digits will be flexed due to paralysis of extensor digitorum. That's why I told extensor digitorum is important to be remembered by the posterior interossei nerve, okay. So there's flexed elbow, flexed wrist, flexed digit, which is and the digit flexion is called as a finger drop, okay. And there will be sensory loss over lateral 3/2 of the dorsum of the hand, lateral 3/2 of the dorsum of the hand. Talking about Saturday night palsy, or also called as the honeymoon palsy, it is due to sleeping over someone's arm, okay. And Saturday at night, because people usually get drunk, can sleep in an armchair on Saturdays, like after getting much drunk. Next day is Sunday, so they're enjoying their life, okay. But this is very harmful. Drinking is very harmful for your health, okay. So we are deviating from the topic also, so let's discuss, okay. And this edge of the OT table in operation patients can also cause this too, okay. If you just lay the patient over the OT table and the edge of the table is over their axilla, okay, so there is Saturday night palsy, okay. There is Saturday night palsy, like there is that error. The problem is at your spiral group of the humerus, okay. So in Saturday night palsy, the damage is at the spiral group of the humerus. The triceps will be partly paralyzed. Why partly paralyzed? Because in axilla the branch is present, okay. The axilla is not involved, okay. There is weakness in elbow extension, of course, okay, but there is an innervation to the long head of your triceps, okay, long head and medial head, okay. And your again your lateral head will not work, and medial head will just work little bit, okay. Actually partly paralyzed, okay. Triceps partly paralyzed, but wrist drop, finger drop, and sensory loss will occur, because below this level all the nerves have been damaged, okay. Talking about Saturday night palsy is done, okay. Effects we have discussed, okay. And third nerve is your fractures, okay. C level. So what is the level? Okay, C. This is the fracture of a lateral epicondyle, okay. This can result due to fractures, okay. In this, your triceps, anconeus, and ECRL also is spared, okay. So wrist drop will also not occur, okay. Patient will feel weakness in wrist extension, but wrist drop will not occur, okay. And finger drop will be present due to extensor digitorum involvement, and sensory loss will occur as usual, okay. And if there is fracture of the head of the radius, fracture, so radius must be present here like this. So if there is head of the fracture of the radius, okay, and at the point D, okay, at the point D, then what will happen? Only finger drop will occur, due to involvement of your extensor digitorum, okay. And the superficial branch of radial nerve is also spared, okay. So there will be no sensory loss also, okay. So that completes your radial nerve. Let's move on to the next nerve, okay. So now we are talking about the median nerve, okay. Median nerve, the root value is C5 to T1, also called as the eye of the hand, okay. This is also called as the labrador's nerve and all, okay. So first, initially it is lateral to the axillary artery, but in due course of time it crosses to the medial side, okay, and becomes medial to the brachial artery in the cubital fossa. You must have observed, okay. The median nerve is the medial most content of your cubital fossa, okay. And after coming medial to the brachial artery and cubital fossa, okay, it will just go like this between the heads of the pronator teres, okay. It will go between the heads of the pronator teres, okay, and divide into a anterior interosseous branch, anterior interosseous nerve will give out a anterior interosseous nerve, which will supply lateral half of your FDP, flexor digitorum profundus, okay. And lateral half is supplied by your anterior interosseous nerve, which is a branch of your median nerve, okay. And this main branch will continue downwards, okay. It will give branches to the FCR, FDS, and palmaris longus, flexor carpi radialis, flexor digitorum superficialis, and your palmaris longus, okay. It will go down, and it will pass deep to the flexor retinaculum, okay, and divide into lateral branch and medial branch, okay. And the part that will pass superficially is the palmar cutaneous branch of the median nerve, and this is the flexor retinaculum is present here. What is the course? So it originates from a medial cord and the lateral cord, both from medial cord and the lateral cord. It descends in arms lateral to the brachial artery. It descends in arms lateral to the brachial artery, but crosses from lateral to medial side of the brachial artery, becomes the medialmost content of your cubital fossa, leaves the cubital fossa between two heads of the pronator teres. It passes deep to the flexor digitorum superficialis, okay, FDS. It passes deep to the FDS, you know this, okay, and gives up to your supplies the superficial flexors also, okay, like your that superficial flexors we are talking about, like FCR, FDS, and your palmaris longus, okay, supplies them also. And then the median nerve emerges lateral to the tendon of FDS. It emerges lateral to the tendon of FDS, that is in beneath your flexor retinaculum, okay, pipes in proximal to the flexor retinaculum, and it passes deep to the flexor retinaculum, okay, and this anterior interossei nerve, this supplies the deep muscles of the anterior compartment of forearm, which comprises of your FDP, okay, flexor digitorum profundus, and your flexor pollicis longus and your pronator quadratus. All three are the deep muscles of the anterior compartment of the forearm, okay. In hand, it has a medial branch and a lateral branch. Let's see the course of median nerve in hand. So medial branch, basically it supplies a L2 lumbrical. Median division supplies a L2 lumbrical and also gives the branches to the digits. This lateral division will give digital branch, will supply our L1 lumbrical, okay, and then it will give your innervation to your flexor pollicis brevis and abductor pollicis brevis and your opponens pollicis, okay, which all three muscles are your muscles of your thinner eminence, okay. So lateral division basically gives innervation to the thinner eminence muscles, and medial and also to L1 lumbrical, and median division to the L2 lumbrical only, okay. Talking about clinical anatomy, if this is injured, there is a higher injury, and if this is in this at this level it is injured in the flexor retinaculum, there is a lower injury, okay. If there is higher injury, just in case of your supracondylar fractures or a pronator teres syndrome is there, or a Struthus ligament is there, okay. In these cases, your opponens pollicis muscle will be involved, okay. This opponens pollicis, if there is higher injury means all the whole course will be disturbed, okay. So opponens pollicis, due to this ape thumb deformity will be there, the unopposable thumb will be present, okay, ape thumb deformity, okay. And talking about this Struthus ligament, what is Struthus ligament? The additional head of coracobrachialis is extending up to the median epicondyle, okay, medial epicondyle, and median nerve can sometimes pass deep to it, okay. So if this occurs, then Struthus syndrome can lead to a higher injury of your median nerve, okay. And FDS is also paralyzed because FDS is supplied, look at this, okay, this FDS, just let me show you. This FDS is supplied by your this main branch which was going there, okay. FCR, FDS, and palmaris longus are supplied by this, okay. So FDS is supplied, so FDS is paralyzed, and lateral half of FDP is also paralyzed, okay. So patient cannot flex his index finger, okay. So we have the pointing finger test, okay. So ask the patient to make a fist and he can't flex his index finger, and this pointing index finger during making fist will indicate a higher median nerve injury, and the lower injury, example for a carpal tunnel syndrome of median nerve is a lower injury at the flexor retinaculum. So if you can get a short note on carpal tunnel syndrome, you can write these effects, okay. Here opponens pollicis is paralyzed, okay. So there will be unopposable thumb, ape thumb will be there, okay. And FDS and FDP will be like no effect will be there, and palmar cutaneous branch, this will not be affected as it passes superficial to the flexor retinaculum, and the median nerve is compressed beneath the flexor retinaculum, okay. So the palmar cutaneous branch will be spared, the digital branch will also be affected, okay. But there is no pointing index finger will not be present over here, okay, understood. So this is your exact course of your median nerve. Let's move on to the next nerve. Let's talk about the ulnar nerve. Ulnar nerve, the root value is C7, C8 and T1. This is an exceptional root value. So it starts from the medial cord of your brachial plexus, continues medial to the brachial artery. Okay, continues medially to the brachial artery, pierces the medial intermuscular septum and reaches behind the medial epicondyle. Okay, and passes between two heads of flexor carpi ulnaris. Two heads of flexor carpi ulnaris. Okay, and it descends in between the FDS and FDP, medial to the ulnar artery, okay, and passes superficial to the flexor retinaculum. Passes superficially, we saw it has small superficial branch and a deep branch. Okay, the superficial branch supplies the palmaris brevis, and this deep branch will give supply to many of the structures. Okay, as ulnar nerve is the main nerve of hand, it will supply. Your deep branch will supply your all the muscles of your thinner eminence, all the thinner eminence muscles. Your L3 and L4 lumbricals, we saw that L1 and L2 are supplied by your median nerve, while the L3 and L4 lumbricals are supplied by the ulnar nerve. Okay, ulnar nerve, and it also supplies all the palmar and dorsal interossei. It supplies all the palmar and dorsal interossei, and also to the adductor pollicis. It supplies the adductor pollicis also. Okay, adductor pollicis also. Okay, so adductor pollicis is the graveyard of ulnar nerve, because it is the last muscle to be supplied by the ulnar nerve. Okay, understood. It also sometimes gives a branch to the flexor pollicis brevis, the deep head of the flexor pollicis brevis also, FPB deep head. Okay, so this is also a concept here. Then clinical anatomy, we are talking cubital tunnel syndrome. So there is a cubital tunnel formation. So this is the humerus and lateral epicondyle, medial epicondyle. So this nerve comes. Okay, this ulnar nerve comes and passes between the two heads of FCU. Okay, if it's visible or not, I don't know. This FCU passes between the two heads of the FCU. Okay, and this passing will form a tunnel like structure, which is called as a cubital tunnel. We'll talk about cubital tunnel syndrome now. Okay, and this will come down. Okay, passing medially to your ulnar artery. It passes medially to your ulnar artery. Okay, so it passes medially to the ulnar artery, and afterwards medial to ulnar artery, and afterwards it divides into deep branch and superficial branch, and gives a supply to the FDP medial half. Okay, the lateral half was supplied by your median nerve, while the medial half is supplied by your ulnar nerve. Understood? Your FDP, I am talking about your flexor digitorum profundus. Okay, understood? So cubital tunnel syndrome, there is a compression of your ulnar nerve between the two heads of flexor carpi ulnaris, due to which the paralysis of medial half of FDP will occur. Okay, all the hypothinner muscles will be paralyzed. Okay, there will be loss of hypothinner eminence. All the interossei will be paralyzed. Adductor pollicis will be paralyzed. L3 and 4 lumbricals will be paralyzed. So there will be clawing of your medial two digits. Okay, so this was about your ulnar nerve. Let's now discuss some clinicals of your upper limb. Okay, before finishing the chapter. Okay, so guys, these are the clinicals of your upper limb, very important clinicals. Okay, most important feature of your human hand is your opposition of the thumb. Okay, humans are evolved like that, opposition. The point of bony contact between upper limb and chest is the sternoclavicular joint. Okay, largest representation in brain is of your hand. Okay, of upper limb. Most important digit is your thumb. Most easily dislocated joint is the shoulder joint. Most commonly fractured bone is the clavicle. Most commonly fractured bone in hand is the scaphoid. Scaphoid fractures are very common. Okay, most common peripheral neuropathy is of median nerve compression at the wrist, that is called as a carpal tunnel syndrome. Okay, fracture of clavicle is the most commonly fractured bone. Clavicle is the most commonly fractured bone in the body. Okay, and generally fractures between its lateral one third and medial 2/3. Okay, due to blows or indirect forces. Okay, like if a person falls on outstretched hand, its clavicle will be fractured. Okay, in this the lateral fragment is drawn medially. Okay, and the medial fragment is slightly elevated. Okay, so characteristic appearance will be a man or woman supporting a sagging upper limb with his opposite hand. Okay, in clinical case question, this statement is given and you will get confused about which you will just write like shoulder joint is dislocated or so, but this is this characteristic feature: a man or woman supporting a sagging upper limb with the opposite hand. This is a feature of your fracture of your clavicle. Okay, why fracture occurs at this point? Because the weakest site is the curvature at the point at which the curvatures of the clavicle meet, and there is the transmission of forces through the coracoclavicular ligament. Okay, understood. So what nerves are compressed if the fracture of humerus occurs? Okay, if there is the fracture of your surgical neck of a humerus, okay, surgical neck, so axillary nerve will be damaged. If there is fracture in the radial group of the humerus, fracture of the radial group of the neck of the humerus or the shaft of the humerus, then the radial nerve will be affected. And if there is the fracture of your epicondyle, medial epicondyle, okay, then ulnar nerve will be affected. Okay, median nerve is the most commonly injured nerve in the supracondylar fracture of your humerus. Okay, median nerve is the most common involved nerve in supracondylar fracture of the humerus. Just revise these facts. Okay. Then we have some congenital abnormalities of your clavicle, that is your clavicular diastosis. That is a clinical condition when the medial and lateral parts of clavicle remain separate due to non-union of two primary center of ossification. Due to non-union, the medial and lateral parts of clavicle will remain separate. Okay, and cleidocranial diastosis, this is a clinical condition characterized by partial complete absence of clavicle, and there will be skeletal abnormalities also. This is called as a cleidocranial diastosis. Understood. And about a Sprengel's deformity of the scapula, which is called as a congenitally high scapula. Okay, the scapula develops in the neck region rather than a shoulder region. It develops in the neck region. Okay, and this generally in intrauterine life it is developed in the shoulder in your neck region also. Then it migrates downwards, but there is no descent. Okay, which will lead to a Sprengel's deformity. Okay, in this the scapula is hypoplastic and situated in the neck region. Okay, talking about some fractures like a Colles fracture. Colles fracture is a fracture of the distal end of the radius while distal fragment is displaced backwards and upwards. Okay, so the fracture occurs 2.5 cm proximal to the wrist. Okay, 2.5 cm proximal to the wrist. Okay, so Colles fracture is the fracture of the distal end of the radius. This distal end is fractured, and the displaced fragment, distal fragment, is displaced posteriorly. Okay, so you can see here. This is the Colles fracture, and the posterior in this there is the backward displacement. You can note the backward displacement in your radiograph also. So I am covering the radiological anatomy side by side. So just pay attention to the clinicals. And the Smith fracture is the opposite of a Colles fracture. There is the same fracture of your distal end of your radius, where distal fragment is displaced anteriorly. Okay. So in Smith's fracture, talking about the Smith's fracture, there is the hand, okay, and there is the anterior displacement of the distal fragment, okay, like this occurs in this direction. Okay, this was occurring in that direction, this occurs in this direction. Okay, so Colles fracture and Smith's fracture. Okay, and fracture of the styloid process of the radius, where the styloid process of the radius fractures, this is called a Chaffor's fracture. Okay, Chaffor's fracture. And we have a Medial deformity. Medial deformity is a congenital abnormality of the radius. Okay, congenital abnormality of the radius, where anterior bowing of the distal end of the radius will be caused due to abnormal growth of distal epiphysis. This is called as the Medial deformity. Look at this. In this Medial deformity, this type of presentation will be there. The patient will come like this type. Okay, there will be congenital abnormality with radius. Okay, there will be anterior bowing of the distal end of the radius. This protrudes through the skin. Okay, this is called as the Medial deformity. Okay, understood. So afterwards we have ulnar deformations, like upper third of the shaft of the ulna. Okay, the fracture is that upper third of the shaft of the ulna. Upper third means your elbow joint is there, then this is the upper third is fractured. This is called as the Montagia fractures. Okay, this is the Montagia fractures. Okay, and if there is the fracture of the lower third of the shaft of the radius, the lower third is fractured near your fingers, near your that wrist joint. Okay, if this is fractured, this is called as a lower third is fractured. This is called as a Galeazzi fracture. So Montagia fracture and Galeazzi fracture, this is there. Okay, if there is a fracture of the shaft of the ulna, shaft of the ulna, like a night watchman reflexly raises his forearm toward of the blow of the stick. Okay, so they may give you a case like a watchman is there who is and there have been 2 consecutive nights in which robbers have been coming, okay, due to which he is running before them and all. Okay, so one day he suffers pain, okay, and he comes to the x-ray ward, and this is your x-ray. They will give your x-ray and will ask to diagnose it. Okay, it is called as a nightstick fracture. Okay, this is a nightstick fracture, which is a fracture of the shaft of the ulna. Okay, and a scaphoid fracture is the fracture of scaphoid is the most common fracture of the carpus, the most common fracture, and fracture usually occurs due to fall on the outstretched hand. Okay, and clinical presentation, the tenderness in anatomical box. So these statements are important. The tenderness, the patient present with tenderness in the anatomical box. So just your mind will go to your scaphoid fracture. Okay, this is a radiograph of the scaphoid fracture. Ossification age of carpal bones is used to determine the bone age of the child. Okay, so this is of medical legal importance. Okay, we have the Bennett fracture. Okay, Bennett fracture is the oblique fracture of the base of the first metacarpal. This is fractured. The first metacarpal base is fractured in the Bennett fracture. Okay, just B for Bennett, B for base of first metacarpal. Boxer's fracture, this is the fracture of the neck of the metacarpal and neck of the fifth metacarpal. Okay, like your little finger. Okay, that metacarpal of the little finger. Okay, this is fractured in the boxer's fracture. Generally your boxers have their punching. Okay, and due to this also these fractures are caused. Or most commonly fractured bone is a clavicle. I have told you. Commonest site of fractured clavicle is the junction of lateral 1/3 and your medial 2/3. Okay, strongest ligament of upper limb is the coracoclavicular ligament. Thickest border of scapula is the lateral border of scapula. Commonest fracture of humerus is the supracondylar fracture. Okay, most commonly injured nerve in a supracondylar fracture is the median nerve. We discussed this point also. Most common site of fracture of radius is the fracture of distal end of the radius 2.5 cm proximal to the wrist. That is a Colles fracture. Colles fracture is the most common site of the fracture of the radius. Okay, and talking about most commonly fractured carpal bone is a scaphoid. Most commonly dislocated carpal bone is a lunate. Okay, largest carpal bone is the capitate, you know this. Okay, and the first carpal to ossify is also a capitate. Okay, and the shortest and the stoutest metacarpal is the first metacarpal. All the metacarpals epiphysis the distal end except the first metacarpal. First metacarpal has the epiphysis at the proximal end. This is important. Okay, understood. So this is there, and after this paralysis of serratus anterior, you know this. Okay, injury to the long thoracic nerve will cause a winging of the scapula. Metastasis of breast cancer to the brain. How the breast cancer travels to the brain? What is the procedure of route? Cancer cells from the breast will go into posterior intercostal veins, and okay, and they will join the vertebral venous plexus. Okay, and they will join the intracranial dural venous sinuses, and they can transfer to the brain. This is important. Metastasis of breast cancer to the brain also occurs. Okay, and about the carcinoma of the breast is a painless heart lump. You know all this, fibrosis and all. Okay, and Crukenberg's tumor, you know. You have studied. Okay, and the breast self examination, you can just read, you can take a screenshot and read. Okay, I'm not explaining more. Done. Okay, and developmental anomalies of the breast, let's discuss this. So polythalia is the supernumerary nipples. Okay, which are like extra nipples in the female, polythalia. Okay, retracted nipples or inverted nipples. Okay, in which the nipples fail to develop from your ectodermal pit. Okay, in this condition the suckling of infant can take place and nipple is prone to infections. Well, polymastia is the development of more than one breast along the milk line. Polymastia, more breast development. Okay, and gynecomastia is development of breast in males. Most important structure of pectoral region is the breast. Largest muscle of your pectoral region is the pectoralis major muscle. Key muscle is the pectoralis minor muscle. Key muscle. Okay, just remember this fact. Key muscle pectoral region is the pectoralis minor. Okay, and most of the limb from the breast drain to anterior axillary lymph nodes. You know this. Subareolar plexus of your sape. It is present deep to the areola, okay, into anterior axillary lymph nodes. Rotus lymph nodes are interpectoral lymph nodes. Just remember it. Most common site of breast cancer is the upper and outer quadrant. Upper and the outer quadrant. Upper and the outer quadrant. Okay. You know about the scapular anastomosis. You know about your axillary abscess. You know about the axillary abscess. Okay. Generally it is an abscess from arising from an axillary lymph nodes, okay, and it can grow the considerable size, and patient will feel pain, okay, and axillary abscess is drained by giving incision to the floor of axilla. Why to the floor of axilla? Only because it is the most dependent part midway between the anterior and posterior axillary folds, okay, understood. And what are the structures? Okay, what are the structures at risk in axillary abscess? Okay, so we have intercostal branchial nerves. Long thoracic nerve is also at risk. Your thoracodorsal nerve and your thoracodorsal artery, these structures are at risk. You know about your Erb's palsy and Klumpke's palsy. Okay, so you can see the causes of Erb's palsy and Klumpke's palsy. You can see the causes, and you know about the chemical features also. Okay, most dependent part of axilla is the floor of axilla. Okay, and the largest branch of brachial plexus is the radial nerve. You know this. Kunz nerve. What is Kunz nerve? The communicating branch between T1 and T2 nerves. Okay, it is called as the Kunz nerve. Your cervicoaxillary canal is that through which the brachial plexus enter the axilla from the neck. Okay. Another thing is, if latissimus dorsi is conditioned, like if it is given voltage, electrical current, okay, it can function as a cardiac muscle, and it is used as an auto transplant to repair a surgically removed portion of heart. Okay, so it can be useful as a graft. Okay, then we have another thing to discuss, that is a triangle of auscultation. Okay, and triangle of auscultation is used mainly by the doctors, okay, to auscultate, and your stethoscope is placed over here, okay, and the lower lobe of lung can be auscultated by putting the stethoscope in this region. You can auscultate the lower lobe of the lung. Okay, you might have seen in a doctor's chamber, the doctors usually ask the patient to turn around, and he puts the stethoscope over the triangle of auscultation specifically. Okay, triangle of auscultation to auscultate the lower lobe of the lung. Okay, this is called as a triangle of auscultation. What are the components which are forming a triangle of auscultation? Okay, so I am enumerating the components that are forming it. Okay, like your medial border of scapula. Okay, the medial border of scapula is there, and the superior horizontal border of latissimus dorsi is there. Latissimus dorsi muscle, look at this, latissimus dorsi is there in this border. Inferior lateral border is of your trapezius muscle, okay, and your medial border of your scapula, and floor is by 6th, 7th and the 6th intercostal space. Understood? Okay, and then afterwards, let's talk about some facts. Only muscle that suspends the pectoral girdle from the cranium is the trapezius. Widest muscle is the latissimus dorsi. Climbing muscle is the latissimus dorsi and pectoralis major. Okay, largest cutaneous nerve on the back of the shoulder is the T2 nerve. Okay, all the rotator cuff muscles are rotators of humerus except the supraspinatus. Okay, tendon most commonly torn in a rotator cuff is the tendon of supraspinatus, most commonly injured. Okay, it is also called the most commonly injured muscle. Okay, best site for hearing lung sound is called triangle of auscultation. Okay, then we have the frozen shoulder. What is frozen shoulder? It's a clinical condition characterized by pain and uniform limitation of all movements of shoulder joint. It occurs due to shrinkage of the joint capsule. The joint capsule shrinks. In more than 40 to 60 age old people, which causes a frozen shoulder or adhesive capsulitis. Okay, talking about your rotator cuff disorders. Okay, rotator cuff disorders. There is the pain in most of the people, there is the pain during a 60 to 120 degree of abduction. 60 to 120 degree of abduction, this is called as a painful arc syndrome. Pain on 60 to 120 degree of abduction. This rotator cuff disorders usually occur in males after 50 years of age. Okay, 50 years of age. And what is Dobarn's sign? What is Dobarn's sign? Okay, like a pain to palpitation over the greater tuberosity of humerus when arm is like if you are just holding the arm like this, okay, there is very much pain occurs. And if you overhead, you abduct the arm, if the arm is fully abducted, okay, then there is no pain. Okay, this is called as a positive Dobarn's sign. Okay, so pain due to a subacromial bursitis is elicited when deltoid is your Dobarn's sign. Okay, you can diagnose the pain is due to a subacromial bursitis if you see a positive Dobarn's sign. Okay, understood? And after this, what we have to discuss is shoulder separation. Acromioclavicular joint dislocations, commonly shoulder separation, you know this. Okay, and you know about the primary articulation of the shoulder girdle is a glenohumeral joint. Most freely movable joint is also a glenohumeral joint. Most commonly dislocated joint in the body, not in upper limb, in the body, is the shoulder joint only. Okay, and commonest dislocation of shoulder joint is called as the inferior dislocation. Largest synovial bursa is the subacromial or subdeltoid bursa. Okay, for IV injection withdrawing of blood, median cubital vein is used. For hemodialysis and renal failure, okay, cephalic vein is used. And for cardiac catheterization, your basilic vein is used. Okay, so these are important. Okay, inflammation of lymphatic vessels or lymphangitis. Lymphedema is obstruction of the lymph vessels. Most prominent superficial vein is the medial cubital vein. Most preferred vein for cardiac catheterization is the basilic vein. Okay, commonest pattern of superficial veins is H-shaped. You must have observed the H-shaped. Okay, this is your cephalic vein, this is the basilic vein, and this is a median cubital vein. H-shaped structure is formed there. Okay, and longest superficial vein of the upper limb is the cephalic vein, longest. Okay, you know about the biceps reflex, it is tested in your physiology and all. Okay, and you know about your brachial pulse. Brachial pulse is common effect in the cubital fossa median to the tendon of biceps. Okay, it is easily palpable. Okay, so you use the palpatory method there. Okay, and brachial pulse, it's easily felt, so it is used for recording your blood pressure. Okay, so this completes our whole upper limb. Along with our clinicals. Okay, we discussed a lot of clinicals. You can add as much as clinicals you want. Okay, so now let's start with our next chapter. Okay, so guys, now we are revising our genetics. Okay, medical genetics of anatomy. It is also in your CBME curriculum. So genes are your hereditary unit, segments of DNA. Okay, and there are about 50,000 to 1 lakh genes per cell. Okay, inheritance is the transfer of characteristics from your parents to the children. Okay, gene contains your deoxyribose sugar, nitrogenous base, your phosphate group, you know all this. Genes have exons and introns, you know all this. Okay, types of genes, you have dominant genes which can express, recessive genes don't express, like AA, heterozygous, capital A, small a will express, your capital A homozygous will express, but your small a homozygous, okay, will not express. Okay, because it is a recessive gene. Okay, we can have regulatory genes, we can have structural genes like your lac-operon, present lac-operon, can have operator genes. Okay, we can have codominant genes like your AB, which can express concurrently, which can express continuously. Okay, and then you can have heterogeneous recessive genes, it's a carrier gene. Okay, like AA, it is a carrier gene. Okay, and we have sex linked genes like your X chromosome or your Y chromosome linked genes, and sex limited genes like your alopecia gene. Alopecia gene only expresses in male. Okay, it doesn't express in your females. Okay, these are your sex limited gene. And about alleles like hair color, we have black and gray. Okay, these are your traits, and the genes that are coding for this black and gray or hair color gene is your alleles. So alternate forms of genes are called as alleles. Two alleles are identical, so they are called homozygous. If two alleles are different, they are called as heterozygous. Okay, talking about genotype, we have homozygous dominant, homozygous recessive, and heterozygous. Okay, and this homozygous dominant and your heterozygous, these are often of your same phenotype, and this homozygous recessive, this is of your another phenotype. Okay, talking about bar body is a sex chromatin. Okay, which is identified by bar and bitram. In females, XX is there. Okay, one X chromosome is a inactivated X chromosome. Okay, during the second week of gestation, it is inactivated and attached to the nuclear membrane of somatic cells. Okay, and this inactivated X is called as a bar body. Okay, how can you calculate the number of bar bodies? So just do number of X chromosomes minus 1. Like a normal female has 2 minus 1 is 1 bar body. Turner syndrome XO genotype is there, XO genotype. So 1 minus 1 is 0 bar body. Klinefelter syndrome XXY is there. So 2 minus 1 1 bar body, and multi-X female like 3X is there. 3 minus 1 is 2 bar body. Okay. So cells with bar bodies are chromatin positive, and cells without bar bodies are chromatin negative. Okay, bar body is darkly stained, plano-convex, and 1 μm in diameter. Okay, so you can easily write a short note on bar body if it comes. Then about Lyon's hypothesis. Lyon's hypothesis states the number of bar body is n minus 1, where n is the number of X chromosomes. So you can state your Lyon's hypothesis. Talking about chromosomes, you can you have to if you have to write a short note on chromosomes, just write the characteristics first. It is darkly stained rod-like structures, okay, present in the nucleus of a cell and formed by condensation of a chromatin. Okay, chromatin condenses to form a chromosome. Okay, so this is a structure. This is a short arm which is called as a P arm, and a long arm is called as a Q arm. Okay, and primary constriction called as centromere. Secondary constrictions are present as satellites. Okay, satellites have the secondary constrictions. Okay, and to this centromere, two discs like structures are like fixed, which are called as a kinetochores. Okay, and about the types based on the position of centromere. So a metacentric chromosome, that is your arm ratio, P by Q ratio is 1. Okay, you know about the P and Q. Okay, this short arm is called a P arm, this long arm is called as a Q arm. Okay, so P by Q same length, okay, equal to 1. Submetacentric, the centromere, okay, it is shifted. Okay, the centromere is just like shifted a little bit to the apical part. Okay, so P by Q, of course the ratio will come less than 1. Acrocentric will be like equal to 0 because this is very less, and telocentric, about this is all 0 only. Okay, P by Q is 0 by Q equal to 0. Okay, PQ ratio is 0 in case of your telocentric chromosome. Understood? And let's talk about karyotyping. Karyotyping is a chromosomal pattern study. It is your chromosomal pattern study. It is called as a karyotyping. Okay, like pair 1, from pair 1 to pair 22 are arranged in from longest to the shortest, in 7 groups. Okay, and importance is in the determination of sex in the ambiguity conditions and chromosomal aberrations. Okay, so talking about this karyotype in normal human male. Okay, this 1, 2 and 3, these are long metacentric chromosome. Okay, and 4, 5 or 6, these are all long but submetacentric chromosome, long submetacentric. Okay, starting from 6 to 12, these are submetacentric and medium sized. Okay, and this 13, 14, 15, these are also medium sized but acrocentric, and 16, 17, 18, these are short and submetacentric, 19, 20 are short and metacentric. Okay, and 21, 22 are very short and acrocentric, Okay, chromosomal aberrations, you can get a short note on this. You can have structural aberrations or numerical aberrations. Okay, structural or numerical aberrations. Okay, structurally you have deletion, micro deletion and translocation. Like deletion of 5th chromosome, short arm of the 5th chromosome deleted, it will lead to a Cradock-Chat syndrome or a cat's cry syndrome. Okay, if there is micro deletion, Prader-Willi syndrome will be there. There is translocation, then leukemias will be there, like chronic myelogenous leukemia. Okay, and you can have numerical aberration like aneuploidy or a polyploidy. Aneuploidy is the addition or deletion of only one chromosome, like a trisomy 2n plus 1 condition, or a monosomy 2n minus 1 condition. And in the polyploidy, there is addition or deletion of a set of a chromosome. Okay, like the ploidy also changes. Okay, in aneuploidy, ploidy doesn't change. In polyploidy, ploidy changes, like a triploidy, tetraploidy. This all are polyploidy. Okay, set of chromosomes are added. Okay, or deleted. Talking about translocation, this is structural aberration. Okay, we can have reciprocal translocation or Robertson in translocation. Talking about reciprocal translocation, okay, there is no gain or loss of any gene, and breakage of 2 non-homologous chromosomes will occur, and the centrosomes are even spared. Okay, so like this breaks and goes there, and this comes here. Okay, this is called as your reciprocal translocation. Robertson translocation, okay, which involves two acrocentric chromosomes or different homologous groups, two acrocentric chromosomes of different homologous groups, like your 14 and 21. Okay, these parts are exchanged, okay, and this is called as a 14q 14q arrow, 21q, okay, Robertsonian translocation. We can get syndromes. You can have Cat-Scratch syndrome, you can get sort of Down syndrome, or your Klinefelter, or your Turner, okay, or your Marfan. Okay, 5 syndromes are there in your anatomy. Okay, Cri-du-Chat syndrome, which is a Cat-Scratch syndrome, which is structural chromosomal abnormality. Okay, deletion of the terminal portion of the short arm chromosome number 5 will occur. Okay, clinical feature is the shrill cry, microcephaly, that is small brain, round face, oblique palpebral fissure, okay, saddle shaped nose, mental retardation, graying of a hair. Okay, so this is the Cri-du-Chat syndrome. And talking about Down syndrome is the most common numerical abnormality of chromosomes, described by Langdon Down in 1886. Frequency is 650 to 700 per live births. It is called as a trisomy 21. That is, the genotype will be 47XX plus 21. Okay, or here 47XY plus 21, based on if the patient is a male or female. Risk factors is that if mothers more than 35 years are there, okay, and they produce babies, then this will cause Down syndromes in the babies. Okay, what are the clinical features? Your mongoloid face, that is a round face with oblique palpebral fissure and an upward slanting. Okay, we have flat nasal bridge, low set ears, open mouth and thick tongue, single palm crease, which is called as a simian crease, okay, short stature, and fifth digit is curved inwards, which is called as a clinodactyly. Okay, these all features are of Down syndrome. Talking about Klinefelter syndrome, we have XXY condition, numerical abnormality. It is there. Cause is the non-disjunction of XX chromosome during oogenesis. There is non-disjunction of XX chromosome. So this XX chromosome, they express together, XX and Y will come. Okay. So bar bodies will be 2 minus 1 equal to 1. Frequency is 1:500 male births. Genotype is 47XXY. Okay, what are the features? That the patient will show gynecomastia, okay, development of your breast, okay, and small testes and azoospermia, and infertility will set in. Infertility will obviously set in, okay, and individual will be tall, having long arms and legs. Okay, these are clinical features. And hypospadias will be occur. Hypospadias is the abnormal penile openings over the penis. Okay, and talking about the Turner syndrome, so this girl has Turner syndrome. Okay, XO condition is that it is a numerical chromosomal abnormality. Loss of X chromosome has occurred. So genotype is XO, 45XO. Frequency is 2:3000 female births. Okay, clinical features, that is short stature is there. Okay, and webbed neck. You can see the webbed neck present over here, and sealed chest having pinpoint nipples. The chest is sealed like, and the nipples are just pinpoint. Okay, and infertility will occur, and bilateral cubital valgus and amenorrhea. Okay, cubital valgus, okay, and there will be amenorrhea, irregular menses or absent menses. Okay, understood. And genes for X and Y are called as a sex-linked genes. This may be X-linked or Y-linked inheritance. Y-linked only shown in males, like your hairy pinna is only inherited in males. Okay, as it is Y-linked trait. Okay, and X-linked can be X-linked dominant or X-linked recessive. Like X-linked dominant, you can have Rett syndrome, lissencephaly, and hypophosphatemia. Rett syndrome, lissencephaly, and hypophosphatemia. Okay, and in X-linked recessive, you can have a hemophilia bleeders disease, color blindness, or Duchenne muscular dystrophy, DMD. Okay, X-linked recessive conditions, so zigzag inheritance. Okay, talking about abnormal autosomal disorders, it may be autosomal dominant or autosomal recessive. Autosomal dominant is the Marfan syndrome, where this is a clinical, this is a patient of Marfan syndrome. Okay, where the connective tissues are affected. In 25% of cases, there is the mutation FBN1 gene, your fibrillin 1 gene. Okay, there is a mutation FB1N1 gene. In the Marfan's connective tissue is affected. Okay, and what the clinical presentation? The patient will have long extremities within the proportion, slender build, arachnodactyly, that is a first spider-like fingers, crowded teeth, ectopia lentis will set in. The funnel chest, that is a pectus excavatus. You can see the chest, it is funnel shaped. Okay, and aortic dilatation will be there. Okay, and phenylketonuria, that is autosomal recessive trait. It is an inborn error of metabolism. Okay, it is the absence of a phenylalanine hydroxylase enzyme. It is the phenylalanine converting phenyl pyruvate and phenyl lactate, which will produce a mosey order of urine, and expressed only in homozygous state. Okay, it's common in the consanguineous marriages, that marriage between relatives or close family members. Okay, clinical features will be depigmentation, mental retardation will occur, neurological symptoms will occur due to that epinephrine, norepinephrine, decreased production of epinephrine, norepinephrine. Many things are there. Many things are there. Okay, so you can refer to biochemistry for details of phenylketonuria. So that completes your genetics. Your medical genetics is now complete. Okay, and now let's move on to another interesting chapter. Okay, let's move on to another interesting chapter. So let's start the new chapter, that is your lower limb. Okay, talking about the deep fascia of the thigh. Okay, deep fascia of the thigh, it is called as your fascia lata. It is modified into three types, that is your intermuscular septum, saphenous opening and cribriform fascia, and iliotibial band or your iliotibial tract. Talking about intermuscular septum, okay, it divides the thigh into three components: anterior component, posterior compartment, and the medial compartment. Okay, so anterior compartment and all three this septums, this intermuscular septums, okay, these are attached to your linea aspera. These are attached to your linear aspera of the femur. Okay, posterior border of femur is called your linea aspera. Okay. Anterior compartment, all the muscles of anterior compartment are supplied with the femoral nerve, and posterior compartment is also called as the hamstring compartment, and it is supplied by the sciatic nerve. Okay, and medial compartment, it is supplied by the obturator nerve. Some muscles are there like your adductor magnus, which lies middle in the middle of your posterior and medial. Okay, so it is supplied by both your sciatic nerve as well as your obturator nerve. Okay, so adductor magnus supplied by obturator as well as sciatic nerve. Okay, so it is called as your hybrid muscle. Then your pectineus lies in the between your anterior and the medial compartment. Okay, so pectineus is called as supplied by the femoral as well as obturator nerve. Okay, so pectineus and adductor magnus, they are both your hybrid muscles. Talking about the saphenous opening, you have your inguinal ligament like this. Okay, and you have the front of the thigh like this. You have the knee here. Okay, so you can have this cribriform fascia. Okay, this cribriform fascia, which is sieve-like fascia and covers the saphenous opening. This sieve-like fascia and covers the saphenous opening. Okay, and this is the saphenous opening covered by the cribriform fascia, and the content of the saphenous opening is a great saphenous vein. Okay, understood? And we have a lateral margin and a medial margin which lies a bit deep, okay, of the cribriform fascia. Talking about iliotibial band, what are the attachments? It is attached to the tubercle of your iliac crest, okay, and goes to the Gerdy's tubercle, which is present in your tibia. Okay, from the tubercle of iliac crest to the Gerdy's tubercle in the tibia. Okay, and it is also continuous with the capsule of the hip joint. Okay, and two muscles are there in the anterior part. It is your tensor fascia lata muscle, TFL muscle, and in your posterior part you have the gluteus maximus muscle. This is the largest muscle of the body. We'll see the iliotibial band here. Look at this. This is the iliotibial band. Okay, and tensor fascia lata is lying anterior to it, iliotibial band. Okay, and gluteus maximus is lying posterior to the iliotibial band. Okay, understood? And this iliotibial band arises from your tubercle of your iliac crest and goes to the Gerdy's tubercle of the tibia. Okay, understood? And clinical aspect is that in case of iliotibial band contracture, if the iliotibial band is spasmatic paralysis is there or a contracture is there, okay, then what are the effects on the hip joint? You can remember a Faber, a mnemonic called as Faber. Hip joint will be flexed. Okay, abducted, hip joint will be flexed, abducted, and externally rotated. Okay, and knee joint will be flexed, externally rotated, and posterior subluxation of tibia will occur. Okay, external rotation, posterior subluxation of tibia will occur. Okay, so this is your iliotibial band contracture. So let's move on to the next concept. So let's discuss the anterior compartment muscles. Okay, the anterior compartment of the thigh. Okay, we're discussing, note that it is of your thigh, not of your leg or your foot. Okay, so anterior compartment muscles are either hip flexors, they cause flexion of hip. Okay, or either they are knee extensors, hip flexors or your knee extensors. Okay, what are the muscles? Iliacus, psoas major, pectineus, sartorius, and quadriceps femoris. Okay, 5 muscles: iliacus, psoas major, which are often called as the iliopsoas tendon. Okay, pectineus is there, sartorius is there. It is the longest muscle and the most superficial muscle of anterior compartment, and also called as the Taylor's muscle. Okay, And then you have quadriceps femoris, which has 4 parts: rectus femoris, vastus medialis, vastus intermedius, and vastus lateralis. Okay, so you can see the muscles. Okay, you can see the muscle here. Let me point out in red. Okay, so this one. Okay, this muscle which is like longitudinally lying like this. Okay, this muscle is called psoas major. Okay, and this muscle is your iliacus. This muscle is your iliacus. Okay, this psoas major and iliacus, these are crossing a hip joint. Okay, and we have this muscle sartorius. Okay, like crossing from the lateral to the medial side. Sartorius crossing from the lateral to the medial side. Okay, and it crosses both the knee and hip joint, hip and the knee joint. Okay, so it is also called as your it is a hip flexor plus a knee extensor. Okay, it will cause hip flexion as well as knee extension, hip flexion as well as knee extension. So the only muscle which will cause this both actions. Okay, and then we have your pectineus here. Okay, below the psoas major and iliacus, we have the pectineus here, pectineus, and pectineus also crosses the hip joint, so it is a hip flexor only. Okay, and talking about your quadriceps. Okay, your quadriceps femoris. Okay, you have your vastus lateralis in the lateral part, vastus medialis medially. Okay, and your rectus femoris like this, the rectus femoris like this. Okay, and vastus intermedius is not seen in this diagram. Okay, and talking about this vastus medialis and vastus lateralis, this vastus medialis and lateralis. Okay, this cross only knee joint, this cross only knee joint, so they are knee extensors. Okay, and about rectus femoris, it crosses both hip and knee joint, but it only causes your hip flexion. Okay, and vastus intermedius is deep to the rectus femoris, so it is not seen here. Okay, and your attachment of your sartorius is your anterior superior iliac spine. Okay, and it goes to the medial surface of the tibia, Okay, talking about a femoral nerve is the nerve of the anterior compartment of thigh. Okay, the origin is from dorsal division of ventral primary rami of L2 to L4. Okay, if you can't understand this, let's move on to the lumbar plexus and discuss the lumbar plexus first. Okay, and then it will be easy for us to discuss the nerves. Okay, so just see, this is your lumbar plexus. Okay, we had to discuss this in abdomen, but we are discussing it here. Okay, from your lumbar plexus contributed by your L1 to L5. Okay, the L1 to L5. Okay, and from L1 a nerve will come and divide into two branches, that is your iliohypoglossal nerve and your ilioinguinal nerve. Iliohypoglossal and your ilioinguinal nerve. Okay, this will be there, and this ilioinguinal nerve will be the part of your inguinal canal also. We'll see. Okay, your iliohypoglossal and your ilioinguinal nerve. Okay, root values will be L1 and L1 only. Okay, and from L1 and L2 combinedly, we have your genitofemoral nerve. Okay, this is your L1 L2. Okay, and the femoral branch of genitofemoral nerve will be the component of your adductor canal. We'll see in later. Okay, and talking about this from your L2, L3 and L4, from your L2, L3 and L4, we have our femoral nerve. And from L2, L3 and L4, okay, L2, L3 and L4 again is our obturator nerve. But difference is that the femoral nerve is the dorsal division. Okay, the femoral nerve, that is your dorsal division of L2, L3 and L4. Okay, so root value will be L2 and L4, and obturator nerve is your ventral division. This is a ventral division of L2 to L4. Okay, and this femoral nerve will supply anterior compartment. This obturator nerve will supply your medial compartment of your thigh. Okay, and we have an accessory obturator nerve also, which is arising from the L3 and L4. Okay, so root value is L3 and L4 only. Okay, and from L4 and L5 we have our lumbosacral trunk. Okay, and from L2 and L3 again from the dorsal division of L2 to L3. Okay, we have another nerve, that is your lateral cutaneous nerve of thigh. Okay, the root value will be L2, L3. And this if this is compressed deep to the inguinal ligament, it can cause a meralgia paresthetica. Okay, if the lateral cutaneous nerve of thigh is compressed deep to the inguinal ligament. Okay, and this genitofemoral nerve has a genital branch and a femoral branch, which I have talked about. This femoral branch goes via the adductor canal or your Hunter's canal. We will see in a while. Okay, so this are the lumbar plexus. Okay, and now we are ready to discuss your course of the femoral nerve. Okay, So just look in here, femoral nerve, it is originate from the dorsal division of the ventral primary rami of L2 to L4. As I said, all the plexuses arise from your ventral primary rami only, okay, and but the dorsal division of the ventral primary rami of L2 to L4, okay, it arises, and when it goes, okay, before entering this thigh region, okay, it will give two branches, one to the iliacus, and another one to the psoas major, iliacus and the psoas major, and another one is to the pectineus, okay. And just remember the trunk of the femoral nerve, the trunk of the femoral, each nerve is a trunk, okay. So the trunk of the femoral nerve supplies your iliacus and your pectineus, understood. And then it goes deep to your inguinal ligament, okay, goes deep to inguinal ligament, okay. And here you can see the femoral sheath also present. We will discuss the femoral sheath in a while, okay. Then it divides into two branches, an anterior division and a posterior division, okay, anterior and posterior division. This anterior division will give a branch to a sartorius muscle, okay, and then it will divide into two parts, that will be internal cutaneous nerve of thigh, and then middle cutaneous nerve of thigh, okay, ICNT and MCNT. And you saw the lateral cutaneous nerve of thigh, it is not here, okay, because the lateral cutaneous nerve of thigh originates directly from the branches of your femoral nerve, that is from L2 to L3, okay, we saw in the lumbar plexus. Then we have a LCFA, at which this femoral nerve is dividing into two branches, that is your lateral circumflex femoral artery, okay, and here the inguinal nerve is divided into anterior and posterior division, your femoral nerve, okay. And about talking about the posterior division, okay, so it is supplying the rectus femoris, vastus lateralis, vastus medialis, vastus intermedius, okay, all the quadriceps femoris muscles, okay, and it is supplying, okay, and it is also giving a branch to the hip joint, and this is important, okay, because the hip joint pain can be referred to the medial border of leg and foot, okay. The hip joint pain is referred to the medial border of leg and foot, okay, because why? Because this hip joint is supplied by your nerve to your rectus femoris, okay, and then the nerve to your rectus femoris is a part of your femoral nerve which goes down and supplies the skin of the medial side of your leg and foot till the great toe, okay. So this is there. So hip joint pain can be referred to your medial border of leg and foot, okay. Referred pain concept is there. The reason for referred pain concept is your cortical plasticity, as we talked in physiology, okay. Talking about when the femoral nerve reaches your knee part, okay, when it runs along with the saphenous nerve, okay, it is saphenous vein, it is called as a saphenous nerve, okay. And saphenous nerve is the longest cutaneous nerve. It becomes cutaneous from this point and goes on supplying the skin on the medial side of your leg and foot till the great toe, okay. So this completes your anterior compartment and your femoral nerve. Let's move on to the next part. Let's talk about your femoral triangle sheath and your adductor canal, okay. So here you will seeing a femoral triangle, here you will see a femoral triangle, okay. This is a femoral triangle. So what are the borders, okay? What is the base is formed by inguinal ligament, which starts from ASIS and goes to the pubic tubercle. This will form your base of the inguinal triangle, okay. The medial wall is formed by your adductor longus, okay. The medial border of adductor longus will form your medial wall, okay. And the medial border of the sartorius muscle, will form its lateral wall. So this is a lateral wall, this is the medial wall, this is the base, okay. And apex is the joining point between sartorius and the adductor longus, okay. And what are the floor is formed by four muscles, okay. 1, 2, 3 and 4, okay. First one is iliacus, psoas major, pectineus and adductor longus, This adductor longus, this is also contributing to your floor, okay. So this completes your femoral triangle. This is the boundaries and all, okay. Talking about the roof of the femoral triangle, we can have, okay, from the roof we can have superficial epigastric vessels that were supplying the stomach and coming out like this, okay. Superficial epigastric vessels, then superficial external pudendal vessels, superficial circumflex iliac vessels, okay, which are going like this: superficial circumflex iliac, superficial epigastric, superficial external pudendal, okay. And the great saphenous vein is going out like this from the saphenous opening, okay. And some superficial inguinal lymph nodes also are present. Talking about the contents, the lateral cutaneous nerve of thigh, the LCNT will be the content, okay. Do you remember the lateral cutaneous nerve of thigh? Yes. It was arising from the ventral dorsal division of your femoral, when the femoral nerve was arising. Okay, so the root value will be L2 L3. Okay, and another thing that will be femoral nerve will cross your adductor canal. Okay, and your femoral sheath is also present in your femoral triangle. Okay, not adductor canal, femoral triangle. Okay, and this femoral sheath has an anterior wall and a posterior wall. Anterior wall is the extension of a fascia transversalis of the abdomen. Okay, and the posterior wall is the continuation of your extension of the fascia iliaca. Okay, we'll see about when you read abdomen. Okay, and talking about the femoral sheath, what are the contents and all of femoral sheath. Okay, so this is your femoral sheath, this is your femoral sheath. Okay, and here you have a lacunar ligament present, which is sometimes related to a abnormal obturator artery. Okay, and this is not always present. Okay, and your femoral ring is there, this is the femoral ring, and below the femoral ring you have a femoral canal where the lymph node of cloquet is present. Okay, and this lymph node of cloquet drains lymph from the glands or the clitoris, the glands of the penis of your clitoris or your clitoris. Okay, this is the lymph node of cloquet present in your femoral canal. Okay, this is the lateral side. Okay, this is the lateral side and this is the medial side. Okay, so here we have this type of arrangement present. Okay, and this first component will have two parts. You will have your femoral artery and a femoral branch of your genitofemoral nerve, femoral artery and femoral branch of genitofemoral nerve. Okay, it supplies the skin over the femoral triangle. Okay, so remember we talked about the genitofemoral nerve. Yes. Okay, then femoral branch was supplying the skin over the femoral triangle. Okay, and second component will have the femoral vein. Okay, and third is the femoral canal, which contains a lymph node of cloquet. Okay, talking on clinical aspects, this femoral hernia, it is more common in females. It's more common in females due to wider pelvis and narrow vessels. Okay, and what is the direction of femoral hernia? It goes downward from the femoral canal, goes downward. Okay, and via a saphenous opening, it goes forward again via saphenous opening and goes upward. Okay, so what happens is that it goes downward from the femoral canal. Okay, it will go downward like this. Okay, so this is the direction of a femoral hernia. Let's move on to the adductor canal, our next topic, which is also called as the subsartorial canal. Okay, or your Hunter's canal. Okay, talking about the adductor canal, this is formed between these muscles. This canal is formed between these muscles. Okay, between the pectineus, between your sartorius and all. Okay, so first of all, the roof is formed by a sartorius. Okay, the roof is formed by a sartorius. The sartorius is forming the roof like this. Okay, and anterior wall is formed by the vastus medialis. Okay, vastus medialis is forming an anterior wall. Okay, and a posterior wall is formed by the adductor longus. Adductor longus is forming a posterior wall. Okay, so this is about adductor canal. Roof is about formed by a sartorius. Okay, and your anterior wall by vastus medialis and adductor longus is forming a posterior wall. Okay, and below the sartorius we have our subsartorial plexus present. Okay, and the roof is your fibrous septum also, fibrous septum and your sartorius. Okay, this is the forming this fibrous septum is basically forming the roof. Okay, and sartorius is forming the medial wall. Okay, what I am saying, like sartorius is present medially now. Okay, sartorius is forming a medial wall, anterior wall by vastus medialis and posterior wall by adductor longus. Okay, posterior wall by adductor longus. What are the contents? Your femoral artery, femoral vein, nerve to vastus medialis, because you can see the vastus medialis present here. Okay, and your saphenous nerve is there, and the genicular branch of obturator nerve. So we will discuss the genicular branch of obturator nerve in a bit later. Okay, so this is your Hunter's canal or your subsartorial canal. Okay, talking about this, your popliteal artery aneurysm. Okay, in this femoral artery can be ligated in the adductor canal itself. Femoral artery can be ligated in the adductor canal itself. Okay, understood. So popliteal artery can be ligated in the adductor canal itself. Okay, so after this, let's move on to the next concept. Let's discuss about the medial compartment of thigh. Okay, it has the muscles like a pectineus. Pectineus is also present in the anterior compartment. Okay, it is also seen in the medial compartment. Then your gracilis is there, which is the most superficial muscle of a medial compartment. Obturator externus, adductor longus, adductor brevis and adductor magnus. All the adductors Okay, obturator externus, pectineus, and your gracilis. Okay, so talking about the medial compartment. Okay, this is the medial compartment. You can see the muscles here. This is the obturator externus, which inserts to the trochanteric fossa. Okay, and these are your muscles: adductor brevis, adductor longus, and adductor magnus in this sequence. Okay, adductor brevis, adductor longus, and adductor magnus. Adductor magnus is a big muscle. Okay, so you can see, and adductor magnus is a hiatus, has an opening which is called as the adductor hiatus. Okay, and your gracilis, this is a gracilis which is not being shown here. Okay, this is a gracilis, and this gracilis is the most superficial muscle of your medial compartment. Okay, talking about what are the things which are there in adductor magnus. Okay, so let's assume this is your adductor magnus. So, okay, this is your adductor magnus. Okay, this is the adductor magnus. Okay, so it is attached to your femur. Okay, it is attached to your femur, and this has few openings like this. Okay, let's assume a femoral artery is coming down. Okay, it divides and gives it divides into a profunda brachii artery. Okay, divides into a profunda brachii artery and continues downwards. Okay, it gives the profunda brachii artery. This profunda brachii artery will give perforating branches which will pierce the adductor magnus and come out. Okay, the first perforating branch, second perforating branch, third branch, and a fourth branch. Okay, and the second perforating branch just gives way to your nutrient artery to femur. This gives way to the nutrient artery to the femur. Okay, and this femoral artery again comes out of your adductor hiatus. Okay, and adductor hiatus is the components like a femoral artery, femoral vein which will run along with your femoral artery, and a genicular branch of obturator nerve. These are the components of your adductor hiatus. Okay, understood. And remember, we saw the genicular branch of your obturator nerve also in your subsartorial canal or your Hunter's canal. Okay, and here is the adductor tubercle is there. Where the adductor magnus is attaching okay, and here you have tibial collateral ligament and the fibular collateral ligament. Tibial collateral ligament is the degenerated tendon of your adductor magnus. Okay, the fibular collateral ligament is the degenerated tendon of your peroneus longus muscle. We'll discuss about this later. Okay, and adductor brevis is present between the anterior and posterior divisions of your obturator nerve. Okay, so adductor brevis is present between the anterior and posterior divisions of your obturator nerve. Okay, so we have an obturator nerve here like this, just you can see. Okay, this is a obturator nerve, like this, and between the anterior and posterior division we have adductor brevis present. Okay, obturator nerve rises from a ventral division of ventral primary rami of L2 to L4. We saw in the lumbar plexus also. Okay, it starts from L2 to L4. Okay, three parts like this, and goes in front of the ella of the sacrum. Okay, and then descends downwards. Okay, and the ovary is the posterior relation, and it moves. It comes out of the obturator canal. Okay, and divides into anterior and the posterior division. So, and the ella of the sacrum, what are the relations of ella of the sacrum, it is also asked. Okay, so you can remember the mnemonic oils. Okay, from lateral to medial. Okay, first is the lateral most content of your ella, which is obturator nerve. Okay, your iliolumbar artery, obturator nerve, iliolumbar artery, your lumbosacral trunk, obturator nerve, iliolumbar artery, your lumbosacral trunk, and the sympathetic chain. So obturator nerve, iliolumbar arteries, lumbosacral trunk, and the sympathetic chain. Okay, now let's move to the next concept. So talking about the medial aspect of thigh, we will take a sagittal section of the medial aspect of thigh. Okay, so what happens is that your obturator nerve is there. Okay, and divides into anterior and posterior divisions. So these are your anterior division and posterior division. Okay, we are seeing the gluteal region also and the side of the leg. Okay, we are seeing the side of the leg, basically the side of the thigh. Okay, and if anterior division, let's talk about the anterior division. So anterior division is first giving a branch to the pectineus. We also saw that the pectineus is given the branch by the trunk of the femoral nerve also, and the anterior division of obturator nerve is also giving a branch to the pectineus. Okay, one to the adductor longus, one to the adductor brevis. Okay, and it contributes to the subsartorial plexus also. We talked about the subsartorial plexus in the Hunter's canal. Okay, and it gives a branch back to the gracilis. Okay, so pectineus, adductor longus, adductor brevis, and your gracilis, these are supplied to the anterior division. And posterior division, this supplies the obturator externus. Okay, and it supplies the adductor magnus and pierces it to comes out, which is called as the genicular branch of your obturator nerve. Okay, so genicular branch of the obturator nerve, this pierces the adductor magnus. Okay, and comes out. And we have a femoral branch of obturator nerve also. We'll see about that. Okay, the genicular branch pierces your adductor magnus and comes out. and it also supplies the knee joint. Afterwards it comes out and supplies the knee joint. Okay, we have an accessory obturator nerve also from L3 to L4 level. Okay, which descends in front of the superior ramus of the pubis, and it can also supply your pectineus muscle. Okay, and also gives a branch to your hip joint. Okay, so hip joint pain can be referred to knee, and knee joint pain can be referred to the hip due to your obturator nerve. So this is a clinical fact. Okay, so after this, let's move on to the next concept. Okay, so before moving to the next concept, I had a clinical to discuss with you. Okay, which is your effect of your obturator nerve injury. Effect of your obturator nerve injury. Okay, so you know about the obturator nerve now. Okay, you have seen about the obturator nerve. Okay, and if there is injury to obturator nerve, okay, due to your anterior dislocation of hip joint, your anterior dislocation of hip joint, or your radial retropubic prostatectomy. Okay, you can write just prostatectomy. That is a removal of your prostate gland. Okay, this can damage your obturator nerve. And this, due to this damage of the obturator nerve, what will be the effects of the injury is that the adduction is lost. The adduction is lost. Why the adduction is lost? Because the obturator nerve, the anterior division, was supplying the adductor longus and the adductor brevis. Okay, so as adductor brevis and adductor longus are paralyzed, and posterior division, which was supplying the adductor magnus, this is also paralyzed. Okay, these all muscles are paralyzed. Okay, and what will occur? There will be sensory loss on the medial aspect of thigh. Okay, and there will be sensory loss over medial aspect of thigh. Okay, so you can get a question like the patient presents with the loss in adduction and loss in sensory loss over medial aspect of thigh. You can diagnose it with obturator nerve injury. You can write these two causes: anterior dislocation and prostatectomy. Then in the question can ask you the course of your obturator nerve. Okay, you can write the course easily. Okay, and you can also tell about your accessory obturator nerve. So you can easily deal a clinical case question from this. Okay, understood. And let's go on with some other clinicals. If we have some other clinicals also, like your femoral nerve injury. Have I discussed about the femoral nerve injury? If not, let us discuss it now. So in anterior compartment, we had discussed the femoral nerve. Okay, let's now talk about the femoral nerve injury. Okay, let's talk about femoral nerve injury. Femoral nerve injury. Okay, this is also important. In a clinical case, you can get a clinical case, okay, from a femoral nerve injury also. Okay, so if there is femoral nerve is injured, femoral nerve can be injured in three cases. Okay, if there is a gunshot, wound, in case of your gunshot wound, or in case of your pelvic fractures, or your stab injury. Okay, stab injury. This can injure your femoral nerve. Okay, if this femoral nerve is injured, there will be motor loss as well as your sensory loss. There will be motor losses and sensory losses. Let's discuss about the motor losses. Okay, motor loss, and we'll talk about the sensory loss also. Sensory loss. Okay, talking about the motor loss will be, and the femoral nerve supplies the iliacus and the sartorius. Okay, and this iliacus and sartorius are causing a flexion of the thigh. Okay, so there is weakness in thigh flexion. Okay, why? Because there is a paralysis of your iliacus and paralysis of your sartorius. Okay, so there is weakness in your thigh flexion. Okay, and due to your paralysis of the quadriceps femoris, which is also supplied by femoral nerve. Okay, there will be inability to extend the knee. Okay, inability to extend knee. Okay, as we know, this muscles like a quadriceps femoris is your knee extensor. Okay, it crosses your knee joint, so it is your knee extensor. So there will be inability to extend up knee. Okay, due to paralysis to quadriceps femoris muscle. Okay, and let's talk about the sensory losses. What will be the sensory loss? There will be sensory loss over anterior and medial aspects of the thigh. Okay, because there is a involvement of intermediate and medial cutaneous nerve of thigh. Okay, this parts. Okay, these are injured in this femoral nerve injury. Okay, and this was supplying the sensory part. This was supplying the skin over the this both nerves will supplying the skin. This will supplying the skin over the anterior and medial aspects anterior and medial aspects of thigh. Okay, so there will be in sensory loss over anterior and medial aspects of thigh. Okay, and due to this anterior and medial aspects of thigh, what will happen? This will due to the involvement of your ICNT and your MCNT. Okay, and there will be a sensory loss over the medial aspect and the medial border of foot. Okay, up to their great toe. Okay, this nerve was supplying upper skin of the medial side of the leg and foot. Okay, so there will be sensory loss over medial side of leg and foot also, Okay, what will due to involvement of your saphenous nerve. So you can easily get a clinical case question on this also. Okay, and the clinical case question can be formed like a soldier is there who suffers from gunshot wound in his leg, okay, in his thigh region, okay, or a pelvic fracture is caused in a pregnant lady, as pelvic fracture is common there. Okay, so the patient presents with weakness in your thigh flexion, okay, and can't extend the knee, and there is sensory losses involved. Okay, so what nerve might be injured? And the answer is the femoral nerve. And talking about what are the muscles supplied by femoral nerve, they can ask. Okay, they can ask what are the divisions of and course of your femoral nerve. They can ask this course, so you can write what is the origin of the course, you can write easily. Okay, and a concept of referred pain they can ask. Okay, anything they can ask. Okay, and this question you can deal easily. So this is also a clinical case based question. This is also a clinical question. Okay, so this is your effect of a femoral nerve injury. Okay, let's now move ahead and discuss the posterior compartment, that is the gluteal region. Let's now discuss the gluteal region. So we have what muscles? Okay, we have a gluteus maximus, which is removed from here, okay, which forms your buttocks. Okay, and we have a gluteus medius, which is also cut. Okay, this gluteus medius is there, which is cut. Gluteus medius is cut here. Okay, and outline of gluteus maximus, that is also removed. Okay, gluteus maximus was present, which is removed to show the inner structures. Okay, and this we have gluteus minimus. Okay, so gluteus maximus, then gluteus medius, and then gluteus minimus. Okay, in this sequence. And below gluteus minimus we have our piriformis muscle, okay, supplied by the nerve to piriformis. Okay, we'll see in the sacral plexus. Okay, and then the superior gemellus is there, then the inferior gemellus is there, okay, superior gemellus and your inferior gemellus. Okay, and your quadratus femoris, this is not a quadriceps femoris, this is a quadratus femoris, the quadrangular muscle. Okay, quadratus femoris, which is present below the inferior gemellus. Okay, and this piriformis muscle is the content of your greater sciatic notch. Okay, and there is a nerve also, greater sciatic nerve, and another muscle, obturator internus. This is a obturator internus present. Okay, this is a obturator internus present. Okay, so this is a gluteal region. Okay, the posterior view of the gluteal region. Okay, and the piriformis is called as a landmark muscle because it divides the inferior and superior blood vessels and nerves. Okay, so above piriformis you will see arising of a superior blood vessels, superior gluteal blood vessels and nerves. Okay, and below you will see arising the inferior gluteal blood vessels and nerves. Okay, so what are the muscles of gluteal region? This can be asked. Your gluteus maximus, your gluteus medius, your gluteus minimus. Okay, your piriformis, superior gemellus, inferior gemellus, obturator internus, quadratus femoris, and also you can write tensor fascia lata. Okay, so there are about 9 muscles in the gluteal region. Okay, this is another picture showing your superior gluteal vessels and nerves above the piriformis and inferior gluteal nerves and vessels below the piriformis. Okay, and you can see here the sciatic nerve. As the sciatic nerve, this is gluteal region posterior compartment. Okay, it is supplied by a sciatic nerve. Understood? So this is a gluteal region. Okay, and let's talk about this more. Okay, So if this is a sacrum, okay, and you have this greater sciatic notch, okay, and the lesser sciatic notch. So what are the structures that are passing via the greater sciatic notch? We have the superior gluteal muscles and vessels, okay, superior gluteal nerves and vessels. Then your piriformis muscle, okay, then inferior gluteal nerves and vessels, okay, and a sciatic nerve will arise from here, and a posterior cutaneous nerve of thigh. The sciatic nerve and the posterior cutaneous nerve of thigh will go from here, okay, and this structures are your greater sciatic nerve. So piriformis, superior gluteal nerve and vessels, inferior gluteal nerve and vessels, your sciatic nerve, posterior cutaneous nerve of thigh, okay, and pin structures will also be there. Pin structures, these are pin structures which will go like this, okay. Pin structures, what are pin structures? Let's read. Pin structure means your pudendal nerve, okay, your internal pudendal vessels, and your nerve to obturator internus. This will also go via your your greater sciatic nerve. So these are your contents, okay. These are your 8 contents which are contents of your greater sciatic notch, okay. So this is a greater sciatic notch, and there are ligaments like a sacrotuberous ligament, which is attaching to the attaching to this part of your hip bone, okay, and this part of your hip bone, and your lesser sciatic, your sacrospinous ligament, which is separating sacrospinous ligament. This is your separating your greater sciatic notch and your lesser sciatic notch, okay. Understood? So this is your lesser sciatic notch. Now lesser sciatic notch. So what are the structures of your lesser sciatic notch? So you can write easily your obturator internus. You can see your obturator internus being attached here, okay, and you can write your pin structures again, okay. Your greater sciatic notch also pin structures are there, because the pin structures, they originate from a lesser sciatic notch and go towards the greater sciatic notch, okay. And pin structure, pudendal nerve, internal pudendal vessels, and nerve to obturator internus, okay. So you can easily write your greater sciatic notch contents and your lesser sciatic notch contents, okay. And we have a superior gluteal nerve which arises from L4, L5 and S1, okay, which supplies your gluteus medius, gluteus minimus, and your tensor fascial lata. Gluteus medius, gluteus minimus, and your tensor fascial lata. And the inferior gluteal nerve and vessels is arise from L5, S1 and L2, L5, S1 and S2, okay. From these are contributions, there are contributions from your sacral plexus also, okay, and this supplies your gluteus maximus, so superior gluteal nerve and vessel, superior gluteal nerve will supply your gluteus medius, gluteus minimus, and tensor fascial lata. Inferior gluteal nerve and vessels will supply your gluteus maximus, okay, gluteus maximus. So this is there, and your gamellus superior and the obturator internus, this is supplied by the nerve to obturator internus, that arises from L5, S1 and S2, okay. And the gamellus inferior and the quadratus femoris, these are supplied by the nerve to quadratus femoris, that arises from L4, L5 and S1, okay. L4, L5 and S1. Another nerve which was arising from L4, L5 and S1, this is the superior gluteal nerve, okay. Understood? Then we have the actions, okay. So this is a pelvic bone, and this is a femur present, okay. This is your hip bone and the femur present, okay. So gluteus medius, this is present like this, okay. This is present like this, okay, which is connecting the hip bone to your to the trochanteric line, or you can say of your femur, okay. And this gluteus medius is responsible for abduction at the hip joint, okay, hip joint abduction. So if it is contracting, okay, this will go like this, okay. This will help in abduction of your hip joint, okay. Understood? So if your left gluteus medius is not working, if it is not working, right pelvis will drop down. If this is not working, okay, your right pelvis will drop down like this, okay. This is called as your Trendelenburg test, okay, to see whether the abductors are working or not, okay. So Trendelenburg test, this is often asked, okay, and this is related to your gluteus medius, okay. So that was about your Trendelenburg test, okay, to see whether the abductors are working or not, okay. About the posterior compartment of thigh, if you have some clinical, you can discuss like this, okay, that some muscles that are related with the clinicals, like your superior gluteal nerve injury. Okay, if there is the injury to the superior gluteal nerve, if the superior gluteal nerve, this one, okay, the superior gluteal nerve is injured. If the superior gluteal nerve is injured, okay, like in example in poliomyelitis, okay, in poliomyelitis, your superior gluteal nerve is injured. Okay, and what will occur, your superior gluteal nerve was supplying the gluteus medius, minimus and the tensor fascia lata. Okay, so there will be inability to pull the pelvis down. Okay, and there will be inability to pull the pelvis down. There will be abduction of your thigh. The abduction of the thigh is lost. Okay, this abduction, thigh abduction will be lost. Thigh abduction will be lost. Okay, thigh abduction will be lost. Okay, and why thigh abduction will be lost? Because there is paralysis of your gluteus medius and your gluteus minimus. Okay, so there will be abduction, the thigh abduction will be lost. Okay, and this is called as a gluteus medius limb. Okay, this is called as a gluteus medius. Okay, limb, limb, gluteus medius limb. Okay, and if your inferior gluteal nerve is injured, okay, you can write this also. If your inferior gluteal nerve is injured, if this is injured, okay, okay, during a posterior dislocation of hip joint or your poliomyelitis only, okay, in the same poliomyelitis case, if it is injured, okay, so what will it lead to? The patient will not be able to rise from a sitting position, okay, or climb stairs or jump. Okay, the gluteus maximus is paralyzed. Okay, it is paralyzed. So what will be the effects? That the patient cannot rise. The patient can't rise from a sitting position. The patient can't rise from a sitting position. The patient cannot rise from a sitting position. Okay, and or the patient will not be able to climb stairs. Patient can't climb stairs. Okay, the patient can't climb stairs. Okay, patient can't climb stairs, and to compensate the loss of function of your gluteus maximus, okay, the patient will walk with the trunk leaned backwards. Okay, the trunk will be leaned backwards. So backward leaned trunk. Okay, so this clinical features are of your inferior gluteal nerve injury. So they can ask you, and which muscle is affected? Your gluteus maximus is affected. Okay, so these were your clinical cases questions. Okay, and let's now go into a posterior compartment without much delay. Okay, we can like discuss many more clinicals that are affected with this, and many things which are given, but due to lack of time, and we are we are discussing each and every clinical that is important for your props. Okay, which can be framed into a clinical case question. Okay, it can be framed in a clinical case question. We are explaining all this. Okay, so we have to discuss the sciatic nerve also. Okay, and we'll discuss the sciatic nerve in a bit detail also, because clinically it is very important. Okay, sciatica is very common now. First, let's discuss the posterior compartment of thigh, which is called as a hamstring compartment of thigh. Okay, hamstring compartment or posterior compartment of thigh. It has four muscles: a semitendinosus, a semimembranosus, your biceps femoris, long head and a short head, and your adductor magnus. Okay, so if this is your ischial tuberosity, okay, and this is your tibia is there and the fibula is there. Okay, so first, what muscle is there? Your long head of biceps femoris will attach to this. Okay, long head of biceps femoris will arise from your ischial tuberosity. Okay, and go towards the fibula, and go towards the insert to the fibula. The short head of biceps femoris is also arising from the femur itself and going towards the fibula. Okay, so there is two muscles attachment. The biceps femoris is attached to your fibula. Okay, not your tibia. And which muscles are attached to your tibia? Okay, so your adductor magnus is running from your ischial tuberosity and attaching to the femur itself, and your semitendinosus and semimembranosus, these are attaching to your tibia. Okay, your semitendinosus is there, okay, and your semimembranosus is there, which is attaching to the tibia. Okay, understood? So this were your attachments of your posterior compartment muscles. Okay, understood? And the muscles which originate from a ischial tuberosity, Okay, the muscles which are originating from the ischial tuberosity, that is supplied by a sciatic nerve, that is the tibial component of sciatic nerve. Sciatic nerve has two components, the common peroneal part and the tibial part. Okay, so these muscles are supplied by the tibial component, but this short head of biceps femoris, okay, this is arising from the femur itself, so it is not supplied by the tibial component, it is supplied by the common peroneal component, supplied by the common peroneal component of your sciatic nerve. Understood? So this is a thing. Okay, and you can see the muscles here, this is the posterior side. Okay, here this is the gluteal region. Okay, and here you can see the thigh. Okay, here you can see the posterior compartment of thigh, where what muscles are there? The semitendinosus is there. Okay, and the semimembranosus, which has is membranous tendon. Okay, your tendinosus, this has a long tendon. You can just identify the muscle semitendinosus by the tendon presence. Okay, semimembranosus is just like membranous like thing. Okay, and if this is the semitendinosus, semimembranosus is lying a bit laterally. Okay, and this go towards the tibial condyle. Okay, and this is the ischial tuberosity, from this they are originating. Your biceps femoris, there is a long head of biceps femoris like this, long head of biceps femoris. This is also having a long head, will have a tendon like origin, your insertion, tendinous insertion, and a short head will originate just below. Okay, and it is present just deep to your long head of biceps femoris. Okay, so we talked about all these four muscles, and this is a popliteal fossa, which we'll discuss a bit later. Okay, and talking about another clinical thing which is called as Nellatens line. Nellatens line. Okay, Nellatens line is the line drawn from anterior superior iliac spine to the ischial tuberosity. We saw the ischial tuberosity here. Okay, so it is drawn from your anterior superior in iliac spine. This is a ASIS present over here. This part, let me mark it with another color. This is a ASIS here. Okay, this is a ASIS. Okay, and it is inserting to the passing via the greater trochanter and is inserting to the ischial tuberosity. Okay, and it passes over the near the top of the greater trochanter also. Okay, so trochanter can be felt superior to this line in a person in which dislocated hip or fractured femoral neck is there. Okay, you can feel the trochanter in this patient. Okay, just above the line. Okay, so greater trochanter, greater trochanter usually lies above the line. This Nellatens line lies usually above the greater trochanter. Okay, if it lies below the greater trochanter, you will see the shortening of head or the neck of femur. Okay, and this shortening or head or neck of the femur, this can occur due to your fractures. Okay, so it can indicate your fractures also. Okay, so this was a Nellatens line. This was about your Nellatens line. Let's move on to the next part. So we are talking about the popliteal fossa. Popliteal fossa is a fossa which is present in the posterior part. Okay, it's a diamond or prism shaped fossa. Okay, bounded by it has borders which are called as superior medial border. Superior medial borders is bounded by semitendinosus and your semimembranosus. You can draw the semitendinosus and the semimembranosus in the like superior medial part, and laterally by biceps femoris. This is the superior lateral border. Okay, biceps femoris will form its superior lateral border. Okay, and then we'll see another muscle, that is a plantaris, which will be lying in the floor. Okay, and the medial head of gastrocnemius, okay, and this lateral head of gastrocnemius, these two heads, okay, will be forming its inferior border. Okay, so this is a diamond shaped fossa. Talking about the floor. Okay, what is the floor of your femoral triangle? Sorry, not a femoral triangle, popliteal fossa. Okay, so if there is a popliteal fossa is there. Okay, your popliteal surface of the femur, your capsule of the knee joint. Okay, your popliteus muscle and its fascia, and oblique popliteal ligament also, the femur and your patella, these all are forming a floor. Okay, you can just imagine here must be somewhere your popliteal fossa. Okay, popliteal fossa. So you can just write all these things which are forming the floor. Okay, and about the roof is formed by your posterior cutaneous nerve of thigh, which will come out of this popliteal fossa. Okay, posterior cutaneous nerve of thigh, and a lateral cutaneous nerve of thigh, which also passes via this popliteal fossa. Okay, lateral cutaneous nerve of your thigh. Okay, and the roof is also formed by skin, superficial fascia, and popliteal fascia also. Okay, and the posterior division of medial cutaneous nerve of thigh also, posterior division of MCNT, in medial cutaneous nerve of thigh, and a small saphenous veins, small saphenous, not the great saphenous, a small saphenous vein. Okay, these are forming a roof. Your posterior cutaneous nerve of thigh, your lateral cutaneous nerve of calf. Okay, and posterior division of MCNT, medial cutaneous nerve of thigh. Okay, skin, superficial fascia, and popliteal fascia. These are forming a roof. These are forming your roof. Okay, so this is your popliteal fossa. Okay, this is about a popliteal fossa. And if we discuss the contents, if you want to know the contents, okay, then there are some contents of popliteal fossa. Okay, like a sciatic nerve. Here in popliteal fossa, a sciatic nerve divides, okay, divides into a common peroneal part and into a tibial part. Okay, the sciatic nerve divides into a tibial part and the common peroneal part in the popliteal fossa. Okay, then you can have a popliteal artery and its branches. Okay, you can have your popliteal vein and its tributaries, popliteal artery, popliteal vein. Okay, your popliteal lymph nodes. Okay, popliteal lymph nodes, your common peroneal nerve, and your tibial nerve. Okay, and other components are there, like a popliteal fat is there. Posterior cutaneous nerve of thigh was the content before piercing the popliteal fossa. Okay, it was a content of the popliteal fossa. You can write posterior cutaneous nerve of thigh also. Okay, and small saphenous vein also, which was the content before piercing. Okay, so this roof part, in this roof part also, your PCNT, posterior cutaneous nerve of thigh, and a small saphenous vein, this can act as the content of your popliteal triangle, of your popliteal fossa. Okay, understood. And this popliteal fossa, this clinical significance is that its structures will provide a clue to the pathological conditions. Okay, it will provide a clue to the pathological conditions, like if that is the anatomical structure, like skin, soft tissues are like pathologized. Okay, then it can indicate your lipoma or your sarcoma and all. Okay, and in your femoral artery you can have an aneurysm of femoral artery. Not special things are there. Okay, these are like easy things which are there in the popliteal fossa. Okay, these are there in the popliteal fossa. Let's say we have completed the popliteal fossa. Okay, and after completing the popliteal fossa, let's move on to the next concept. After this, before going to the next component. Okay, before going to the next part of this chapter, let's discuss some clinicals of your posterior compartment only. Let's discuss some clinicals of there. Okay, remember we talked about in Nelaton's line. This was a clinical of this compartment. Okay, and we know about the your Trendelenburg sign. Okay, and there is a clinical which is called as a Weaver's bottom. Okay, Weaver's bottom. Okay, so what is this Weaver's bottom? Is that it is the inflammation of bursa. Okay, which lies between gluteus maximus and the ischial tuberosity. Okay, you can say inflammation of bursa. Okay, of your gluteus maximus muscle, in patient, in your person who are sitting for long. Okay, which occupation requires long period of sitting. Okay, or your less movement, or the sedentary lifestyle is there, like weavers, they keep on weaving the threads. Okay, and sit for the long time. Okay, in patients who sit for long times, who sit for a long time, this Weaver's bottom is seen. Okay, this Weaver's bottom is seen. And another thing which I want to discuss about this your gluteal region. Okay, like another thing which you can know. Okay, is about your hamstringing. Okay, hamstringing. Okay, it was common for soldiers. Okay, to slash the tendons of posterior thigh muscles. Okay, posterior to the knees. Okay, so that their opponents cannot run. Okay, this is called as a hamstringing, which is a historical practice. Okay, hamstringing. Okay, so what is hamstringing? Hamstringing was that the four muscles were called as hamstring muscles. The hamstring muscles, you know, this is hemitendinosus, this is hemimembranosus. Okay, your biceps femoris, as well as and the part of it adductor magnus also. Okay, these are called as the hamstring muscles, part of adductor magnus also. Okay, these are called as hamstring muscles. Okay, and this hams means a buttock and the back of the thigh. Okay, and these have a common origin from the ischial tuberosity and inserted into leg bones. Okay, so if there is the cutting, the hamstring was the slashing of posterior thigh muscles, posterior thigh muscles. Okay, in case of your soldiers, by soldiers of earlier times, okay, and this will prevent the opponent to run. So opponent cannot run. So opponent can't run. Okay, the opponent can't run, and this will cause your this in ancient times this the slash the legs of the opponents. Okay, and they will win the war. Okay, so this is there. Okay, and due to short hamstrings, some when a person tries to touch his toes with his knees kept straight, okay, the hamstrings muscle are stressed. Okay, the length of hamstring muscle varies. Okay, so some people can touch their knees and some people can't touch their toes with their knees straight. Okay, there is an exercise, okay, the person will bend like this and touch the ground. Okay, touch the ground with his hands, with his hands. Okay, and touch the toes specifically, or the ground with his hands. Okay, and this depends upon the length of the hamstring muscle. This is not much clinical. Okay, this is there. Okay, then afterwards let's move on to the next part. Let's discuss about your leg compartments. You have anterior compartment, which are dorsiflexors. Okay, posterior compartment, which are plantar flexors, and lateral compartment, which are everters of foot. Okay, everters of foot. Everter is the outward turning of the foot. Okay, anterior compartment, you have muscles like your tibialis anterior, your extensor hallucis longus. Just remember, your anterior compartments have dorsiflexors and extensor muscles. Okay, all are dorsiflexors. Your extensor muscles are there, like your extensor hallucis longus, extensor digitorum longus, and your peroneus tertius. Okay, peroneus tertius, and peroneus tertius is a detached tendon of your extensor digitorum longus only. Okay, this EDL, detached tendon of your EDL, forms your peroneus tertius. Okay, so this is your anterior compartment. Posterior compartment will have plantar flexors. Okay, we have a superficial group and a deep group. Okay, we have your gastrocnemius, we have a soleus and plantaris in the superficial group. Okay, GSP you can remember, gastrocnemius, your soleus and the plantaris, and the deep group you can remember your popliteus is there, your flexor hallucis longus, flexor digitorum longus, and your tibialis posterior. Okay, popliteus, FSL, FTL, and your tibialis posterior. And in lateral component, which comprises of everters, you can have your peroneus longus and your peroneus brevis. Okay, which can be also called as the fibularis longus and fibularis brevis respectively. Okay, so if you just want to see, you can see this is a tibialis anterior muscle, this is tibialis anterior. Okay, and this is going towards the great toe. Okay, and we have the extensor digitorum longus here, okay, which is dividing into four leg tendons. Okay, and you have extensor hallucis longus, which is present just posterior, and extensor hallucis longus also goes to the great toe. Okay, this gastrocnemius and soleus, this combined together, this is called as the triceps of the calf. Triceps of the calf is formed by your gastrocnemius and your soleus, which is also called as the triceps suri. So triceps suri is formed by your gastrocnemius and your soleus. Why this calf, the soleus is called as a peripheral heart. Okay, you can call the soleus as a peripheral heart. Okay, let's discuss this point also. Okay, so we are discussing why the soleus is called as a peripheral heart. Okay, this soleus is called as a peripheral heart. Okay, why it is called so? It is called as a peripheral heart, or your calf pump, or it is called as your calf pump. Okay, why it is called so? Because this soleus muscle has a rich plexus of vein. This has a rich plexus of valvulus veins. Okay, this contains valvulus veins. Okay, valvulus veins. Okay, and these veins are often termed as a soleal sinuses. Okay, this we call as a soleal sinuses. Okay, soleal sinuses, and the superficial veins like a saphenous veins. Okay, this saphenous veins, this drain into your soleal sinuses. They will drain into your soleal sinuses. Okay, this SS. Okay, and through perforating veins. Okay, and soleal sinuses will empty into a deep veins of the leg. Okay, this soleal sinuses will empty into a deep veins of leg, like your posterior tibial and peroneal veins. Okay, so on standing, the venous return of blood, the venous return of blood depends largely upon muscular activity, especially of the soleus muscle. Okay, when the soleus muscle contracts, Okay, when it contracts, then what happens is that when the soleus contracts, the blood is pumped superiorly. Okay, so the blood is pumped superiorly into the deep veins. Okay, superiorly in the deep veins, okay, in deep veins. Okay, and for this region the soleus is called as a peripheral heart, or your heart of the leg. Okay, peripheral heart, or the half of the leg, or your calf pump. Okay, so soleus, it is an important statement about the soleus. Okay, so we discussed about your soleal sinuses and your your peripheral heart, why it is called as a peripheral heart. Okay, and this is your clinical case. Okay, so we have discussed your clinical things also. Okay, and now we are going to your uh, retinacula of the foot. Okay, the retinaculums of the foot. Okay, in foot we have three retinaculums. We have our flexor retinaculum, we have our extensor retinaculum and a peroneal retinaculum. Okay, what are the retinaculum? Your flexor, okay, your extensor retinaculum and your peroneal retinaculum. Okay, so we are now into the foot. After the leg, we did all the leg compartments. Okay, we talked about this. Okay, let's talk about the foot also. Okay, so you can see if this is your foot, this is surface anatomy of the foot. You can just look like. Okay, and if this is that, then you have your superior extensor retinaculum. This is the superior extensor retinaculum. Okay, extensor retinaculum. Okay, and your inferior extensor retinaculum is shown in this diagram. Your inferior extensor retinaculum is shown in this diagram. Okay, so this is your this whole part is your extensor retinaculum. Okay, and talking about a flexor retinaculum, it connects the medial malleolus, from the medial malleolus to the calcaneal tuberosity. Okay, the medial malleolus of the foot to the calcaneal tuberosity, it extends. Okay, and what are the structures passing deep to the flexor retinaculum from medial to lateral side? Okay, you have this is a medial side. You can say your medial malleolus from the lateral and to the lateral side, from the to the calcaneal tuberosity, towards the calcaneal tuberosity. From medial to lateral side, you can have this parts like your tibialis posterior tendons, your flexor digitorum longus tendons. Okay, posterior tibial artery, your tibial nerve, your flexor hallucis longus tendons, and okay, these structures are passing deep to the flexor retinaculum. What are they? You can remember Tom, Dick and Harry. Okay, you can remember Tom is your tibialis posterior, Dick is your flexor digitorum longus. Okay, and from A is for artery. Which artery? Posterior tibial artery. N is for the nerve. Which nerve? Your posterior, your tibial nerve. Okay, and Harry is for the flexor hallucis longus. Okay, and we have the tarsal tunnel syndrome. As you have your carpal tunnel syndrome we discussed today. Okay, your tarsal tunnel syndrome is the compression of your tibial nerve deep to the flexor retinaculum. Okay, as you see, your tibial nerve is there. Tibial nerve is passing deep to the your flexor retinaculum. Okay, of the foot. Okay, so if there is compression of tibial nerve deep to the flexor retinaculum, you can have your tarsal tunnel syndrome. Okay, talking about extensor retinaculum. So extensor retinaculum has superior extensor retinaculum. Okay, and the stem of the extensor retinaculum. Okay, which is divided into your upper band and your lower band. Okay, and this upper band will go towards the anterior border of medial malleolus, and the lower band will be merging with the fascia of the sole. Okay, we have the fascia sole. Okay, the lower band will merge with the fascia of the sole. Okay, understood? So you can draw this like this. You can draw the foot like this, and this is a superior extensor retinaculum, two parts, superior and inferior extensor retinaculum. Okay, which have your upper band and a lower band. This upper band will be attached to the anterior border of medial malleolus. Okay, and this lower band will be attached to your deep fascia of the sole. Okay, and this superior extensor retinaculum, what will be the extent from the anterior border of fibula. Okay, here the fibula will be present in the lateral side, the anterior border of the fibula, okay, to the anterior border of your tibia. Okay, just remember, your superior extensor retinaculum is from your anterior border of fibula to the anterior border of the tibia. Okay, and about the inferior extensor retinaculum. Okay, so upper you have the attachments of your superior extensor retinaculum from anterior border of fibula to anterior border of tibia, and the inferior extensor retinaculum. Okay, which starts from the non-articular part of superior surface of calcaneum, and the upper band attaches to the anterior border of medial malleolus and lower band to the deep fascia of the sole. Okay. Understood? What are the contents from medial to lateral side? From medial to the lateral. Okay. What are the components from the medial to the lateral side? That is from medial to lateral. Sorry, I pointed out the wrong direction. Okay. So we have your first one, that is your tibialis anterior. Okay. First one is your tibialis anterior. Okay. Tibialis anterior muscle. Okay. Tendon of the tibialis anterior. Then the Himalayas are not dry places. This is a mnemonic. Okay, Himalayas is for EHL, extensor hallucis longus. A is for anterior tibial artery, anterior tibial artery. Not is for your nerve, deep peroneal nerve, and a dry is for extensor digitorum longus. Can places is for peroneus tertius. Okay, so what is that? You can see. Okay, the first one, the Himalayas. The T is your tibialis posterior, tendon of the tibialis posterior. Okay, the Himalayas. Okay, extensor hallucis longus. R means anterior tibial artery. Okay, your anterior tibial artery. Okay, the Himalayas are not is a nerve. Which nerve? You have your deep peroneal nerve. Okay, deep peroneal nerve. Okay, and then we have the extensor digitorum longus, EDL. Okay, dry is for EDL. This 4 tendons. Okay, and your places is your peroneus tertius. Understood? So these are the components from the medial to the lateral end. Okay, so this completes your retinaculum, so your extensor retinaculum and the flexor retinaculum. Okay, extensor retinaculum, flexor retinaculum. Now let's move on to the next part. Let's now discuss about the foot, the sole of the foot. Okay, sole of the foot has 4 layers. Okay, and like this tibial nerve, okay, it goes below the flexor retinaculum. We have seen the elements that are passing deep to the flexor retinaculum. Okay, passing deep to the flexor retinaculum by the mnemonic, that is your Tom, Dick and Harry. Okay, so your tibial nerve will be passing deep to it. Okay, and it is your that lateralmost content. Okay, this tibial nerve will divide into medial plantar nerve and your lateral plantar nerve. Okay, lateral plantar nerve is the dominant nerve of your foot. Okay, foot has 4 layers. Your first layer is your plantar aponeurosis and 3 muscles. Okay, your plantar aponeurosis and 3 muscles. Okay, if this is the foot, if this is the sole of the foot. Okay, so what 3 muscles you have? So let's see. You have your abductor digiti minimi, which will be going towards the little finger, your abductor hallucis, which will be going towards the thumb. Okay, and flexor digitorum brevis, okay, FDB. Okay, this is your upper layer, the most superficial layer of the foot. Okay, this abductor digiti minimi is present on the lateral side, so it will supply the lateral plantar nerve. This abductor hallucis and flexor digitorum brevis, this both on the medial side, so it is supplied by your medial plantar nerve. Okay, what is the dominant nerve? Your dominant nerve is a lateral plantar nerve. Okay, we'll see how. Second layer has 2 tendons, 2 muscles. Okay, 2 tendons, 2 muscles and the lumbricals. Okay, so what are the tendons? 2 tendons. We have the FHL and FDL tendons. Okay, and 2 muscles. 2 muscles are there, like a flexor digitorum accessorius. Okay, and your flexor hallucis longus. Okay, and the flexor digitorum longus. Okay, and this flexor digitorum accessorius is also present. Okay, so what are this? Let's discuss. So first of all, you have an FHL tendon, flexor hallucis longus tendon, FHL tendon. It will be going towards the thumb. Okay, the flexor digitorum longus, it starts medially. Okay, it goes like this. And goes towards the L4 lumbrical. So your little toe. Okay, and these are giving branches to all the 4 toes. Okay, all the 4 toes. Okay, this is a flexor digitorum longus. It has 4 tendons. Okay, to which your 4 lumbricals are attached. Okay, your 4 lumbricals are attached, where your L1 lumbrical is unipinnate. Your L1 lumbrical, this is a unipinnate lumbrical. Okay, which is going into the this L1 lumbrical is going into the space between the thumb and your great toe. Okay, and your the second toe. Okay, the L1 lumbrical is unipinnate and L2 lumbrical is bipinnate, which will arise and go between these 2 toes. Okay, between these 2 toes. L3 lumbrical will go between this 2 toes. Okay, between these 2 toes. And L4 lumbrical between these 2 toes, last space. Okay, so L1 is a unipinnate and L2, L3, L4 are your bipinnate lumbricals. Okay, in your toes. Okay, in your sole of the feet. Okay, and this lumbricals were like unipinnate and bipinnate lumbricals were also present in your hand. Okay, the muscles of the intrinsic muscles of the hand. Okay, so you just go and revise there. So this unipinnate, this L1 lumbrical, this will be supplied, this is the medial side, this is the medial side. So L1 lumbrical will be supplied by medial plantar nerve. Okay, L2, L3, L4 will be is bipinnate, and it is supplied by the lateral plantar nerve. This will be L2, L3, L4 will be supplied by the lateral plantar nerve. Okay, and this flexor digitorum accessorius muscle is there like this, arising like this. Okay, which is also called as the quadratus plantae. Okay, so this whole part, you can say this whole part is supplied by the lateral plantar nerve. This whole part will be supplied by the lateral plantar nerve. Okay, then L1 lumbrical, FHL and FDL. Okay, this is supplied by the lateral plantar nerve. Okay, understood. And this your L1 lumbrical, this L1 lumbrical will be supplied by only your medial plantar nerve. Okay, and this FHL, FDL, this and your flexor digitorum accessorius, these are lateral plantar nerve supplies. Okay, then the third layer we will have your flexor hallucis brevis, okay, and flexor digiti minimi, and your abductor hallucis, flexor hallucis brevis, flexor digiti minimi, and your abductor hallucis. This is the third layer. This flexor digiti minimi and abductor hallucis, not your abductor, is the adductor hallucis, sorry. Okay, so this part is supplied by your lateral plantar nerve. Okay, and the flexor hallucis brevis, this is supplied by your medial plantar nerve. Understood? And the fourth layer is there. Fourth layer is called as a layer of interossei, where interossei muscles are present. We have 3 plantar interossei which are unipinnate, and 4 dorsal interossei which are bipinnate. Okay, 3 plantar and 4 dorsal interossei which are supplied by the lateral plantar nerve. Okay, all this interossei are supplied by the lateral plantar nerve. Okay, so just see, you have your dorsal interossei 1, 2, 3 and 4 dorsal interossei. Okay, 4 dorsal interossei which are bipinnate, and your plantar interossei are attached to your third, fourth and fifth, P1, P2 and P3. Okay, there are no attachments to the first and the second. Okay, and the second that tarsal, okay, or metatarsal is called as axis. Okay, this is the axis. So first layer, let's see it pictorially. Okay, the first layer this, okay, we will see your adductor hallucis, abductor hallucis here, abductor digiti minimi. Okay, and the flexor digitorum brevis, which will divide into 4 tendons. Okay, this is your first layer. And the second layer I told, where lumbricals are also present. Okay, the lumbricals are present in the second layer. Okay, we will have your flexor hallucis longus, which will divide into 4 tendons, flexor hallucis longus. Okay, your flexor digitorum longus, and the flexor hallucis longus will be there, which will be going towards the great toe, hallux. Okay, and we have your quadratus plantae, or your flexor digitorum accessorius like this, arising like this. Okay, this is your second layer. And your lumbricals, L1 lumbrical supplied by medial plantar nerve, L2, L3, L4 is supplied by the lateral plantar nerve. Then your layer 3 is there, which is your transverse and oblique head of your adductor hallucis. Also in adductor hallucis, in your hand also there was an adductor brevis. Okay, your adductor longus. Okay, adductor longus, and this adductor longus had also transverse head and oblique head. So here also transverse and oblique head. Okay, and then you have the flexor digiti minimi and flexor hallucis brevis, and flexor digiti minimi. Flexor digiti minimi is supplied by your lateral plantar nerve. Okay, which is the lateral side, and the medial side is the flexor hallucis brevis, supplied by the medial plantar nerve. Okay, and this adductor hallucis, this is also supplied by your lateral plantar nerve. Okay, talking about layer 4, your interossei, just see what are the interossei. These are your dorsal interossei, D1, D2, D3 and D4. Okay, which are your bipinnate, and plantar interossei P2, P3, P1, P2, P3, which are unipinnate and attached to your third, fourth and fifth bones. Okay, so dorsal and the plantar interossei. So this completes our foot. Let's move on to the next. So you have a very important part, that is a sciatic nerve. Sciatic nerve arises from L4 to S3. Okay, L4 to S3, and this goes down and supplies the piriformis. Okay, this passes deep to the piriformis muscle. passes deep to the piriformis muscle, but it doesn't supply it. Okay, piriformis supplied by your nerve to the piriformis. Okay, and it goes down in the gluteal region. Then your hamstring region is there, it goes down in the hamstring region, supplies the hamstring muscles, your semitendinosus, semimembranosus, long head of biceps femoris, your adductor magnus. Okay, and the short head of biceps femoris also. Okay, and then it descends down in the popliteal fossa. It splits into a tibial nerve, okay, and your common peroneal nerve. So what are the components of a tibial nerve? Okay, so this is a tibial nerve which is going down. So tibial nerve, it gives branches in the popliteal fossa to the medial head of gastrocnemius, okay, to the knee joint, okay, to the plantaris, to the lateral head of gastrocnemius, and to the popliteus. Okay, it gives branches. Okay, and this nerve to popliteus, this also gives up a branch to the superior tibiofibular joint also. Okay, and then you give a then another branch of this tibial nerve is a sural nerve, and the sural nerve supplies the posterior side of the skin of the calf, Okay, so this is supplied by a sural nerve. Okay, and then descends down and supplies the soleus muscle, okay, which is the only superficial muscle of calf supplied by the tibial nerve. Okay, soleus muscle is the peripheral heart. Okay, and then supplies your FDL, FHL, and your tibialis posterior. Okay, you just remember the muscles, the FDL, FHL, and your tibialis posterior. Okay, which were of your that posterior compartment of the leg. Okay, the muscles of the posterior compartment of the leg. Passes deep to the flexor retinaculum. We said that if there is compression of the tibial nerve inside the flexor retinaculum, here if there is compression here, you can write it here, if there is compression, okay, at this part, so it will lead to a tarsal tunnel syndrome. Okay, if there is compression here. Okay, and talking about this your flexor retinaculum, okay, then it divides into a medial pectoral and lateral pectoral nerve. Okay, medial pectoral nerve supplies the muscles like your first layer, second layer, and third layer. Which muscles are there? The abductor hallucis. Just remember, the abductor hallucis is the first layer muscle. Okay, and the flexor digitorum brevis also, which is also of your first layer. Your abductor hallucis and flexor digitorum brevis. Okay, which were of your first layers. In the second layer muscle, only the L1 lumbricus, the L2, L3, and L4 is supplied by the lateral pectoral nerve. Okay, and of the third layer, it supplies one muscle, that is the flexor hallucis brevis. Okay, so you have your abductor hallucis, okay, flexor digitorum brevis, flexor hallucis brevis, L1 lumbrical, which is supplied on the medial pectoral nerve, medial plantar nerve, not pectoral. Okay, and the lateral pectoral nerve supplies all the rest muscle of your leg and foot, Okay. So this is the course of a tibial nerve. Let's discuss the common peroneal nerve. Okay, so one branch was the tibial nerve, another branch was the common peroneal nerve. Okay, common peroneal nerve gives up a branch which is called as a lateral sural nerve. This lateral sural nerve is gonna supply the this part, the lateral part of the skin of the calf. Okay, this is supplied by the lateral sural nerve. Okay, this supplies the lateral part of a calf. Okay, it also gives a branch to the knee joint and superior tibiofibular joint. Okay, it wounds around the neck of the fibula and divides into two parts, that is the deep peroneal part, the superficial peroneal part, deep peroneal nerve and superficial peroneal nerve. This deep peroneal nerve is going to supply all the dorsiflexus, the anterior compartment, okay, of your leg, that is the tibialis anterior, your EHL, EDL, and your peroneus tertius. Okay, and it also gives a branch to your ankle joint. And the superficial peroneal nerve, it gives a branch to peroneus longus and your peroneus brevis. Peroneus longus and peroneus brevis, these are your everters of the foot. Okay, do you remember the third compartment, that was the everters of the foot. Okay, peroneus longus and peroneus brevis, or fibularis longus or fibularis brevis, these are supplied by your this nerve. Okay, superficial peroneal nerve. Okay, and this deep peroneal nerve, this also supplies the first web space, and the superficial peroneal nerve, this supplies the dorsum of the foot. Okay, this supplies the dorsum of the foot. Understood? After this, if the tibial nerve is injured, you will have dorsiflex position of foot. The foot will be dorsiflexed. Okay, because the dorsiflexors are paralyzed. Okay, and the patient walk on heels, which is called as a calcaneal gait. Okay, calcaneal gait occurs due to tibial nerve injury. Okay, and if there is fracture of the neck of the fibula, if the neck of the fibula fractures here in this point, if the neck of the fibula fractures here in this point, okay, there will be damage to your SPN and your DPN also. Your common peroneal nerve is injured, okay, and your deep peroneal, superficial peroneal will be injured. Your superficial peroneal nerve, okay, just supplying all the everters of the foot. Okay, just see these were the everters of the foot. Okay, so if there is injury to the superficial peroneal nerve, there will be inverted foot. Okay, and if there is injury to the deep peroneal nerve, okay, there will be deep peroneal nerve supplying all the dorsiflexors. Okay, so if there is injury, you will have a plantar flexed foot. Okay, inverted plantar flexed foot, which is called as the foot drop. And the gait is called as a high steppage gait. Okay, this is due to your common peroneal nerve injury. Okay, and about the blood vessels of the lower limb. Okay, blood vessels of the lower limb, you have to see that from the abdominal aorta. Okay, from the abdominal aorta, your it is divided into a common iliac artery. Okay, common iliac artery divides into external iliac and internal iliac, and this external iliac and this iliac artery, okay, this external iliac artery continues as the TA. Okay, what is the TA? It is a FA, that is a femoral artery. Talking about this, okay, this external iliac artery is continuing as the femoral artery. You can see in this diagram also. And talking about the femoral artery and the anastomosis at the back of the thigh. Okay, at the back of the thigh we have also an anastomosis, as we had the scapular anastomosis or your elbow anastomosis. At the back of the thigh we have an anastomosis forming by your femoral artery, and which contains your anastomosis between perforators, your cruciate anastomosis, and your trochanteric anastomosis. So circulation in limb is not affected if the femoral artery is blocked due to chronic arterial occlusive disorders. Circulation is not affected due to this anastomosis. Okay, talking about the anastomosis, let's say here is the femoral artery is there. It will give you a profunda femoris artery. Which artery? Profunda femoris. Okay, like a profunda brachii artery, you have a profunda femoris artery, and this profunda femoris artery will again give a branch which is called as your lateral circumflex femoral artery. Remember this lateral circumflex femoral artery? Yes, this was the point at which the femoral nerve was dividing into its anterior and posterior compartments. Okay, components. Talking about this, your LCFA is there, and which will go back. And in this neck of the femur, okay, it is called as a medial circumflex femoral artery, and this anastomosis, okay, then your femoral artery which comes down, that is the profunda femoris artery, gives 4 perforating branches. First perforating branch, second, third and fourth. Okay, this first perforating branch divides into 2 other branches. Okay, so it is the ascending branch of first perforating artery. Okay, and there is a descending branch. So ascending branch of second and descending branch third and the fourth. So this have your descending branches as well as your ascending branches. Okay, and this fourth perforating branch, okay, it will anastomose with the muscular branch of your popliteal artery also, and the descending branch of one artery and the ascending branch of one artery, these are anastomosing. And this ascending branch of second perforating is again anastomosing with a descending branch of a first perforating artery. After this, we have our superior gluteal artery that is coming to this region. And your inferior gluteal artery, which is dividing into 2 other branches like this and this. Okay, so the inferior gluteal artery, your middle circumflex femoral artery, your lateral circumflex femoral artery, okay, and your this 3 arteries, and the ascending branch of first perforating artery also, these are anastomosing together. Okay, and this anastomosis is called as a cruciate anastomosis. Okay, so ascending branch of first perforating, your middle circumflex femoral, lateral circumflex femoral, and the branch of your inferior gluteal artery. And this anastomosis, okay, which is occurring in front of your trochanter, in superior side of your trochanter. Okay, this is formed by so your superior gluteal artery, okay, and the branch of your inferior gluteal artery, and another two branches of your lateral circumflex femoral and a branch of your medial circumflex femoral artery, which is backside, okay, present backside. So these four arteries are fusing, forming a trochanteric anastomosis, and this small anastomosis are called as your anastomosis between perforators, anastomosis between perforators. So this was the femoral anastomosis, okay. And talking about the popliteal artery, okay, the popliteal artery comes where your adductor hiatus, okay, the hiatus in your adductor magnus, that is the adductor hiatus, and divides into two branches, that is the superior medial geniculate artery and the superior lateral geniculate artery, okay. And this is your tibia and this is the fibula, okay, as you can note, okay. And this is the lower end of your femur. So superior medial geniculate artery and your superior lateral geniculate artery, okay, genicular artery, and it is going down and giving another branch which is called the middle genicular artery, okay. Not geniculate, just note I told geniculate, but it's not geniculate, it's genicular. And then it is coming down as the posterior tibial artery, giving another two branches, your inferior medial geniculate artery and your inferior lateral geniculate artery, okay. And this is also giving another branch which is the anterior tibial artery and your peroneal artery, anterior tibial artery and your peroneal artery, okay. So these are the superior medial genicular, your superior lateral genicular, middle genicular, inferior medial genicular artery, posterior tibial artery, inferior lateral genicular artery and anterior tibial artery. These are the branches of your popliteal artery. Note that this peroneal artery is not considered a branch, okay. And popliteal artery is more prone to aneurysm than any other artery in a human body, okay. Just note it is more prone to aneurysm than any other arteries, okay. Then a continuation of anterior tibial artery, okay. Let's say this is your anterior tibial artery, okay. So anterior tibial artery continues, okay, and forms a dorsalis pedis artery, which is formed between the tendons of EHL and EDL, okay. And this dorsalis pedis artery comes down in your foot region, okay, and divides into lateral tarsal branch and your medial tarsal branch at the level of your lateral and the medial malleoli, okay. And then it comes down again, forming your arcuate arteries which are supplying your toes, okay. Okay. And this is going through the first intermetatarsal space. This is going inside in the first intermetatarsal phase, okay. And this is called as your first dorsal metatarsal arteries, okay. And these all are your arcuate arteries. This is your arcuate artery which is giving branches, okay. So this was about your blood vessels of the lower limb, okay. Let's move ahead. Let's talk about your hip joint, which can come as a long question, not more likely, but it can come, okay. So it is a ball and socket type multi-axial joint, and the articular surfaces are the head of femur, which forms more than half of a spear, and it is covered by an articular cartilage except on the fovea capitis, okay. This fovea capitis is not covered by your articular cartilage, okay. And it is from the acetabulum, lunate surface of the acetabulum, your acetabular notch, your acetabular fossa, okay. And the capsule is attached superiorly to the acetabular margin of the hip bone, okay. Acetabular margin of the hip bone, and inferior anteriorly to the intertrochanteric line, and inferior posteriorly to 1 cm medial to your intertrochanteric crest, okay. And what are the types of fibers in the capsule? So outer fibers, these are longitudinal fibers called as a retinacula, while inner fibers are circular fibers called as a zona orbicularis, okay. Talking about a synovial membrane, it lines the inner surface of the fibrous capsule, intercapsular portion of neck of femur, acetabular labrum, transverse ligament, and fat in acetabular fossa. This acetabulum labrum, like we had a glenoidal labrum, it deepens your acetabular cavity, okay. So you must have seen your acetabulum. Here we have your things, okay, which I will show you. So don't worry about if you're not understanding this all, okay. And your iliofemoral ligament, what are the ligaments? So you have your iliofemoral ligament, your pubofemoral ligament, and your ischiofemoral ligament, okay. And your ligamentum teres, that is your round ligament, and your transverse acetabular ligament. So you have 5 ligaments: your iliofemoral, your pubofemoral, ischiofemoral, okay, and the ligamentum teres, that is a round ligament, and the transverse acetabular ligament, okay. So iliofemoral ligament, it is the Y-shaped ligament, it is the strongest ligament, and it is connected to the anterior inferior iliac spine to the intertrochanteric line. Talking about this, so if it is visible, let me show you iliofemoral. Yes, you can see this. This is your iliofemoral ligament that is highlighted in your yellow color. Okay, this is your iliofemoral ligament. It's the strongest ligament of the human body. Okay, just remember, it is the strongest ligament of the human body if it is asked. So it is your iliofemoral ligament. Understood? And you have iliofemoral ligament is connecting the AIIS, okay, AIIS to the trochanteric line. Okay, so this is your iliofemoral ligament, anterior inferior iliac spine to your intertrochanteric line, and prevents the backward falling of the hip joint. Okay, and then you have pubofemoral ligament, which extends from the iliopubic eminence to the inferior part of capsule. Okay, iliopubic eminence to the inferior part of capsule. Okay, this is your iliopubic eminence, and inferior part of capsule is this. Okay, so this is a pubofemoral ligament. This green one is a pubofemoral ligament. Okay, you understood? After this, another ligament, let's talk about it. It is called as a ischiofemoral ligament, okay, which extends from the posterior inferior surface of acetabulum, okay, of your acetabulum to the posterior part of neck of femur, okay. So this is the ischiofemoral ligament, okay, which is the weakest ligament of the hip joint, okay, and this extends from the inner part of capsule, okay, the inner part of the capsule to your posterior neck, the posterior inferior surface of acetabulum to your posterior part of neck of femur. Okay, so ischiofemoral femoral ligament extends from your posterior inferior surface of your acetabulum. You can see here, this is a posterior inferior surface of the acetabulum, posterior inferiorly. It is present posterior inferiorly. Okay, and it goes to the posterior part of the neck of the femur, Okay, so it is the posterior part of the neck of the femur. So it is your this is which ligament? It is your ischiofemoral ligament. Okay, and just remember this iliofemoral ligament, it is also called as the ligament of Bigelow. Okay, ligament of Bigelow, Bigelow, ligament of Bigelow. Okay, after this, let's discuss about the ligament of head of femur, which is called as a ligamentum teres. Okay, or your round ligament, ligamentum teres or your round ligament. So it is a flat and triangular ligament, and apex is attached to your fovea centralis of your femur, and base is attached to the transverse acetabular ligament. Okay, this one, the transverse acetabular ligament. So round ligament, it is attached to the transverse acetabular ligament. Okay, apex to the fovea centralis and base to the transverse acetabular ligament. Okay, so if we have our picture, let's discuss our picture. If we have okay, we have a picture of ischiofemoral, pubofemoral, iliopubic eminence. Okay, so we don't have picture maybe. Yes, here in this diagram, this line diagram. Okay, in this line diagram, you can see your ligamentum teres or your round ligament being present here. Okay, between what it is present? It is present between the fovea cavities. Okay, this is a fovea cavities of the femur, apex, and base to the transverse acetabular ligament. Okay, the base of a ligamentum teres is attached to a transverse acetabular ligament. Okay, which is not visible here. You just see that 3D diagram if it's possible. Okay, and then you can appreciate the things. Okay, talking about, yes, here it is visible. You can see this is a ligament of the head of femur. Okay, this is a ligament of the head of femur. This one. Okay, it is attached to your fovea cavities, and the lower part goes to your posterior surface of the head of the femur. Okay, and the posterior part goes to transverse acetabular ligament, that is the base is attached to transverse acetabular ligament. And about transverse acetabular ligament, it bridges the margin of your acetabular notch. Okay, so transverse acetabular ligament, this one, transverse acetabular ligament, this is a transverse ligament. Okay, which binds to the margin of your acetabular cavity. Okay, binds to the margin of your acetabular cavity. Understood? So these are all your ligaments. Okay, if you didn't understood, you can check out the actant anatomy videos or something like a 3D anatomy for understanding. But you can just for your exams, you have to just remember these 5 ligaments. Okay, and about the blood supply, what is the blood supply? Obturator arterial supply, which is the division of your internal iliac artery, the medial circumflex femoral and the lateral circumflex femoral artery. Okay, MCNT and LCNT, these both arteries are gonna supply your hip joint. Okay, And the lateral circumflex femoral artery, it's the main artery supplying the head of femur up to till the age of 5 or 6. Okay, after the age of 6, the MCFA is the main artery. Okay, so it was the main artery when the age was about 5 or 6. Okay, but after the age of 6, your medial circumflex femoral artery is the main artery. Understood? About the nerve supply, what is the nerve supply of the hip joint? It is supplied to the accessory obturator nerve. We have discussed about this accessory obturator nerve that arises from your that L3 to L4 segments. Okay, and your sciatic nerve, and your nerve to rectus femoris, your obturator nerve, and your nerve to quadratus femoris. This all will supply your hip joint. Okay, so just remember how do you determine the nerve supply? You don't have to mug up this. Okay, the muscles which are present in the hip joint, okay, you can just remember which muscles are crossing your hip joint. Okay, about the relations, your gluteus maximus, piriformis, gamellar superior, obturator, these are muscles of the posterior compartment. Okay, so posterior compartment, which nerve is supplying? Your sciatic nerve, of course, and some muscles are there of your medial compartment of thigh. Okay, that is your medial compartment muscles are there, of course. Okay, and due to this medial compartment muscles, which is the nerve supplying, that is your obturator nerve. Okay, and your rectus femoris, that they are also forming your this part. Okay, like your rectus femoris is there. Okay, and your iliopsoas tendon is also a relation, pectinus is also a relation. So the muscles which are crossing your hip joint must also give the nerve supply to the hip joint also. Okay, this is called as a Hilton's law. What is Hilton's law? Hilton's law states that, Hilton's law, if you have read in your general anatomy, it states that the muscle that will cross a joint, okay, that will be supplied by the same nerves that is supplying the muscles. Okay, this is called as a Hilton's law. Understood? So after this, let's discuss something else. Okay, these are your diagram of the ligaments. If these are schematic diagrams, you can practice the schematic diagrams so as to draw in your exam. Okay, then talking about the relations of the hip joints. So this, let's consider this as the hip joint. Okay, so what are the relations? The posterior, interior, inferior, and the superior and the inferior relations. Okay, so let's talk about this relation. This diagram is important if hip joint comes in your exam, which is very unlikely, so that it will come. Okay, so what are the relations? Just remember, here is the capsule of the hip joint. Okay, let's say it is the capsule. Okay, so what will be the superior relations? So superiorly, you have a rectus femoris, your gluteus, your gluteus minimus, your gluteus medius, and covered by your gluteus maximus, is a big muscle here. Okay, which is covering the hip joint from posteriorly. Okay, so just like we are seeing from this diagram. Okay, here is a leg. Okay, and your knee is there in this part. Okay, so this, we are looking at the hip joint from this view. And are you understanding which section we have taken? Yes. So you can easily write, you can easily see your rectus femoris here, your gluteus medius, your gluteus minimus present over here, and your gluteus maximus is covering this buttock region in the maximus. Okay, talking about the posterior relations, you can also write your gluteus maximus. Okay, and then your piriformis, you can write your gamellar superior, your obturator internus, gamellus inferior, and your quadratus femoris, not quadriceps, quadratus femoris. Okay, so all the muscles we see in the gluteal region, you have to write this in the posterior relation, and you have your sciatic nerve that is supplying this posterior muscles. Okay, so sciatic nerve is also forming a posterior relation. You can easily write your superior relation and posterior relations. Okay, and about the anterior relation is formed by a rectus femoris. Okay, rectus femoris was in your superior as well as in posterior relation. Your anterior relation, rectus femoris is there, your iliopsoas tendon is there, and the pectinus is also there. Okay, so anterior compartment muscles you can easily write, and the femoral artery and nerve also you can write. Okay, so these are forming an anterior relation of the hip joint. Very easy it is. Okay, and your inferior relations. Okay, so remember that was the nerve, there was a muscle called the obturator externus also, which was lying here. Okay, and the nerve was like crossing the obturator internus, the obturator nerve was crossing like this. Okay, and this obturator internus, and below it is the medial circumflex femoral artery which will be lying. Okay, so you can write in inferior relations, you can write your obturator externus and medial circumflex femoral artery. Okay, so these are your relations of the shoulder joint. You have done it. Okay, about the movements, what are the movements? So the flexion, what are the hip joint flexors? Okay, think about the muscles which are running in the front, that is the anterior compartment muscles, that is the psoas major, rectus femoris, iliacus, pectinus. Okay, this causes your flexion of hip joint. Talk about extension. Extension, what muscles will do? Your that muscles which are present in your backside. Okay, like a gluteus maximus. It is your stair climbing muscle. Just remember, it is your stair climbing muscle. The person, if there is a clinical case in which the thing is that a person is unable to climb the stairs, as I told earlier in your clinicals. Okay, so gluteus maximus must be involved in it. Okay, which is the main extensor, of your hip joint. Okay, and your hamstring compartment muscles, all your like adductor magnus, okay, and ischial head of adductor magnus, the biceps femoris, semitendinosus, semimembranosus, all of this will help in extension. Talking about adduction, okay, all the adductors you can write: adductor magnus, adductor longus, adductor brevis, very easy. Talking about abduction. Remember your gluteus medius, the test was Trendelenburg test. Okay, so as to check if all the abductors are working well or not. So gluteus medius and gluteus minimus, these are your abductors. Okay, and then for your medial rotation, think of muscles which are like present in your that part which can rotate your hip joint to the medial side, towards the body axis. Okay, these are your gluteus minimus and your tensor fascia lata. And external rotation, just think of muscles which are horizontally running. Okay, horizontally running gluteal muscles which can do your external rotation. Okay, so gluteus maximus, your obturator internus, your superior gemelli, inferior gemelli, piriformis, and quadratus femoris. All these are muscles of your gluteal region. Okay, so this will cause your lateral rotation. And adduction is called adductor magnus, adductor longus, adductor brevis. This all. Okay. The clinical correlation, congenital dislocation is more common in hip joint than in any other joint, and hip joint pain is also referred to the knee joint. Okay, most common dislocation is the posterior dislocation. The posterior dislocation, like a dashboard injuries are there. Okay, so the hip joint is like a jerk is there, so the hip joint dislocates posteriorly. And weak position is a flexed and laterally rotated position. This is the weak position of a hip joint. Okay, flexed and laterally rotated position. Here will not change the center of gravity, will be there, like that. You can have a tendency of falling. Okay, talking about a Perthes disease. Okay, which is called as a pseudocoxalgia. You can see the radiograph of Perthes disease. This is a flattening of the head of femur. Okay, which will increase the joint space, like the head of femur flattens. Okay, and causing an increased joint space. The joint will take more space. Okay, this is your Perthes disease or your pseudocoxalgia. Talking about a line which is called as sentence line. Okay, sentence line. This is formed. Just see this line. This line is your sentence line. Which line is? This is your sentence. SHENTON, sentence line. So what is sentence line? It is formed by, okay, it is of clinical importance. It is formed by the inferior margin of the neck of the femur. You can just well note your femur here. Okay, and you can note the neck of the femur is forming its inferior margin of neck of the femur is forming a part 50%, and another 50% from the superior margin of your obturator foramen. So you can see your obturator foramen here, and superior margin is forming another part. Okay, so the distortion of sentence line indicates the fracture of the neck of femur or your hip dislocation. This indicates your hip dislocation or your fracture of the neck of the femur. Understood? So this was about a sentence line, and we have discussed the two clinicals, that are sentence line and Perthes disease. Okay, and you can also write this congenital dislocation, and this you have to write. Okay, 4 points you can easily write, and posterior dislocation you can write. Okay, 5 points clinical are just more than sufficient for your exams. Okay, and what to write if it comes in, first given introduction to ball and socket type joint, you can write your articular surfaces, that is the head of femur. Okay, and covered by articular cartilage except on the fovea cavities. Okay, you can skip these parts. You can talk about capsular attachment superiorly, where it is attached to the margin of the hip bone, and inferior attachment you can write to the intertrochanteric line. Intertrochanteric line and the crest you can write this this type. Okay, and types of fibers you can write your retinacula fibers and your zona orbicularis fibers. Okay, talking about synovial membrane, where it lines, you can write this. Okay, and just make sure to write about the ligaments, your iliofemoral ligament. Okay, talking about iliofemoral ligament. Okay, this iliofemoral ligament. Okay, and this was a iliofemoral ligament. Just let me show you. This is the iliofemoral ligament. Okay, and just remember that the iliofemoral ligament also is called as a ligament of your Bagelu. Okay, and this was there. Okay, and about, okay, about your other ligaments like your pubofemoral, your ischiofemoral, and ligaments of head of femur, that is your ligamentum teres and transverse acetabular ligament. You can just enumerate the ligaments, like name the ligaments present, okay. And if you note some special points, so they're well and good, okay, and you can just write it. You should write your blood supply, like obturator artery, medial circumflex femoral, lateral circumflex femoral. You can write the statement also, this is important. And you can write your nerve supply, all 5 nerves you can enumerate. Your accessory obturator nerve, your sciatic nerve, obturator nerve, nerve to rectus femoris, and nerve to quadratus femoris. All the nerves to femoris are supplying your hip joint, and sciatic nerve, obturator nerve, and your accessory obturator nerve also, if it is present, okay. And you can just show the diagram of the capsule here. You can show the diagram of the capsule present, okay. It is not much necessary, but make sure this is most important, okay. Just make sure to write about the relations of your hip joint, just it is very easy. You can just practice the diagram once or twice, and so like practice it 4 or 5 times, I would say, so that it becomes a reflex for you to draw the diagram of the hip joint of showing the relations, okay. If you just mug up the relations, it will not help. Just understand how the relations are there. Movements you can easily write: your flexion, extension, adduction, abduction. Medial rotation is done. Medial rotation is special here, okay, which is done by your gluteus minimus and the tensor fascial artery. Just remember. And lateral, in the lateral rotation, write all your muscles of your gluteal muscles, okay, all your gluteal muscles, all muscles of gluteal region. And in clinical correlations, you have 5 points to write, as we discussed, okay. You can write about your sentence line and all, okay. So this completes your hip joint. Let's move on to another important joint, which is a knee joint, okay. So let's talk about the knee joint. Knee joint is a complex joint, a condylar joint, a saddle shaped joint, okay, and it's a modified hinge joint, okay. These all names are of your hinge joint. It is called as a complex joint because it is divided by menisci. So there are meniscus we will see in your in your knee joint, okay. And it is a condylar joint, that is between the medial and lateral condyles of a femur and tibia, okay. And it is a saddle shaped joint between the femur and patella also, okay. It is involving a femur, tibia, patella, all this. It's a modified hip joint because modified hinge joint because flexion, extension, and certain degree of axial rotation is also possible, okay. So just remember that the knee joint, just know that the knee joint is a very important long question which is of your lower limb. So talking about the capsule of the knee joint, it is attached to the peripheral margin of articular surface of lower end of the femur, okay, attached to the peripheral margin of articular surface of the lower end of the femur, okay. It excludes the articulating area for patella and the popliteal tendon. It excludes articulating area of patella and your popliteal tendon, okay. And it is attached 1 cm distal to the articular margin of your tibia, 1 cm distal to the articular margin of the tibia, okay. And hence in acute osteomyelitis, okay, clinical is there. Hence in acute osteomyelitis which occurs in the metaphysis, okay, like attach 1 cm distal to the articulating margin of your tibia, okay. So it is proximal to your epiphyseal line, okay. So in acute osteomyelitis which occurs in the metaphysis generally, okay, a knee joint is not involved because the capsule finishes in the epiphyseal line itself, okay. And this excludes the margin of a tibial tuberosity, okay. This excludes the margin of a tibial tuberosity. So what is the articular surfaces of the capsule? To the peripheral margin of articular surface of lower end of femur to 1 cm distal to the articular margin of your tibia, okay. And it excludes the articulating area for patella, popliteal tendon, and the margin of tibial tuberosity, okay. Understood? So to write this, so this is the knee joint, okay. Talking about the ligaments, there are many ligaments in the knee joint. First one, the most important, is the cruciate ligament. Cruciate ligament, we have the anterior cruciate and the posterior cruciate ligaments. So I was telling that in the cruciate ligament, which is very important as your knee joint is concerned, okay. Ligaments are very important in your knee joint. So cruciate ligament is an anterior cruciate and the posterior cruciate ligament. This anterior cruciate ligament, the posterior cruciate ligament, we have to write short notes on this. If we have to write short notes on this, so you can write all these 4 points of anterior and the posterior cruciate ligaments. So anterior cruciate, it is attached anterior part of upper surface of tibia to the lateral condyle of femur, okay. And posterior cruciate from posterior part of upper surface of tibia to the medial condyle of femur, okay. So it is very easy, okay. It is very easy. You can see your anterior cruciate ligament like this, okay. If this is your patella here and you are seeing the femur, okay, the tibia and the fibula are there, okay. So this is your anterior cruciate ligament, it is attached like this, and the posterior cruciate ligament may not attached here, okay. Posteriorly it is present, okay. And this are your posterior cruciate ligament that will be present in the posterior side. Okay, so you have this cruciate ligament going up like this beneath the patella. Okay, so it is attached to the anterior part of upper surface of tibia, anterior part of the upper surface. This is the anterior part of upper surface of tibia, and is going to the lateral condyle of the femur. It's going to the lateral condyle of the femur. Okay, lateral condyle of the femur. And about the posterior cruciate ligament, that is the posterior part of upper surface of tibia. Okay, it will be present like posteriorly, which is not visible in this diagram. Okay, is it visible here? Here also you can't see it. Okay, yes, we are seeing now in posterior side. Okay, this is the posterior view, so you can well appreciate your posterior cruciate ligament here. This is the posterior cruciate ligament, and the anterior view you can well appreciate your anterior cruciate ligament. Okay, this and a posterior cruciate ligament, this is connecting your posterior surface of the lower end of your like femur. Okay, and it is going to the upper and the posterior side of your tibia. Okay, medial the posterior surface or upper surface of tibia, the medial condyle of the femur. You can see this is the medial condyle, okay, of the femur, and like this is the medial condyle of the femur, and this is the lateral condyle. Okay, and this is the lateral condyle. To lateral condyle, which ligament is attached? Your anterior cruciate ligament is anterior cruciate ligament must be like this, must be like in this shape. Okay, anteriorly. Okay, it is not visible in this diagram. Okay, so talking about this ligaments, okay, anterior cruciate is less stronger, while posterior cruciate ligament is more stronger ligament, and anterior cruciate ligament will prevent the backward sliding of femur on the tibia, while the posterior cruciate ligament will prevent the forward sliding of femur on the tibia. Okay, let's talk about the menisci. We have two menisci, your lateral meniscus and the medial meniscus. Okay, so lateral meniscus and the medial meniscus. So how can you visualize this? These are just some things like these menisci are semilunar in shape. Okay, and you have the fibrocartilage rings. They are semilunar fibrocartilage rings, and each have anterior and posterior horns. Okay, this medial meniscus is attached to the tibial collateral ligament. Like we are seeing this joint. Okay, we are taking the sagittal. We are taking a transverse section of this part. Okay, and are seeing here. Okay. So first of all, you will there is a patella is present. This is the anterior side. This is the posterior side. The patella is present, and ligamentum patelli will be there. Okay, and in this medial part, you have your medial meniscus. This is the medial meniscus. Okay, and the lateral part, you have your lateral meniscus. You can see the medial meniscus a bit up than the lateral meniscus. Okay, understood. So this is this, and your coronary ligament will be present in this manner. Okay, so fact is that the tendon of the popliteus muscle tendon separates the lateral meniscus and the lateral collateral ligament. Okay, so you have two ligaments, the medial collateral ligament and the lateral collateral ligament. Okay, so your medial meniscus is attached to the medial collateral ligament. Okay, medial meniscus is attached. This is the medial collateral ligament. Okay, so medial meniscus must be attached to this like this. Okay, this is the medial meniscus, so it must be attached to it like this. Okay, to the medial collateral ligament, but the lateral meniscus is not attached to a lateral collateral ligament because there is a tendon. There is a tendon of your popliteus muscle which will separate the lateral meniscus and the lateral collateral ligament. Okay, so medial meniscus is attached to the medial collateral ligament, the tibial collateral ligament. Okay, and your lateral meniscus is, but it is not attached to the lateral collateral ligament. Okay, talking about your meniscofemoral ligaments. Okay, so you have your posterior meniscofemoral ligaments. So we'll discuss. Okay, and your anterior meniscofemoral ligaments. Okay, and this posterior and meniscofemoral ligaments are like connecting. Okay, attachment is to the lateral surface of medial femoral condyle. Lateral surface of the medial femoral. This is medial femoral condyle, and this is the lateral surface of medial femoral condyle. Okay. From this, it is running towards the posterior horn of a lateral meniscus. This is a lateral meniscus. This is attaching to the posterior horn of this lateral meniscus. This part of this lateral meniscus. Okay, this is called as your meniscofemoral ligament, which is a posterior meniscofemoral ligament, which we have discussed. Understood. And we have another ligament, that is oblique popliteal ligament. Oblique popliteal ligament, okay, which reinforces the knee joint from the posterior side, okay. And this oblique popliteal ligament, it is the extension of the tendon of your semimembranosus muscle. It's the extension of tendon of your semimembranosus. You know about the semimembranosus, which was forming the boundary of your popliteal fossa, okay. It is the extension of the tendon of the semimembranous muscle, okay. This is a oblique popliteal ligament here present like this, oblique popliteal ligament present like this, okay. And it is also pierced by the middle genicular branch vessels, okay, middle genicular vessels, and your nerve and your genicular branch of your posterior division of opturator nerve, okay. So it is also pierced by the genicular branch of the opturator nerve, which will pierce your oblique popliteal ligament also. Then about transverse ligament. Transverse ligament is attached to the anterior horn of medial meniscus to the anterior margin of the lateral meniscus. So you can see this is a medial meniscus again, and this is a lateral meniscus. We have discussed this section. So it is attaching to the anterior horn of medial meniscus, to the anterior margin of a lateral meniscus, okay. And it is present in about 40% of individuals, not present in all. Then we have our coronary ligaments. Coronary ligaments attach margins of medial and lateral menisci, okay. Coronary ligament basically attaching to the margins of your medial and lateral menisci, which are holding the menisci in the place, okay. And arcuate ligament is a Y-shaped ligament, okay. Arcuate ligament is a Y-shaped ligament. Have we shown the arcuate ligament here? Is it visible here? Yes. Look at this. It is a Y-shaped type of ligament. Just let me make the highlighter shorter. Okay, this one is a arcuate ligament or a arcuate popliteal ligament. This is a Y-shaped ligament present over here, okay. And the importance of this arcuate ligament is that the arcuate ligament is a Y-shaped ligament, and it is attached to the styloid process of fibula, and the stem is attached to the styloid process of fibula. You can just note this is attached. This you can write here, okay. This arcuate popliteal ligament, this part is called as the stem part. I'm talking about this ligament, okay. This part is called as the stem. And stem is attached to the styloid process. Styloid process of your fibula, okay. Stem is attached to the styloid process of fibula, and we have our bands, okay. Two bands of arcuate popliteal ligament or the arcuate ligament, okay. Anterior band and posterior band. Anterior band is attached to the femur and posterior band to the tibia, okay. So this is your anterior band, which is attached to the femur, okay. This mark this as the anterior band, which is attaching it to the femur, okay. And your posterior band, this is the posterior band, and it is attaching it to the tibia. Okay, understood. So this is all about your the Y-shaped ligament, that is your arcuate ligament, okay. So here we are discussing our arcuate ligament. Okay, so then afterwards we have our collateral ligaments. These are also your ligaments. So basically we are seeing that in knee joint your ligaments are very often asked, okay. So I have talked about all the ligaments in detail, okay. And we'll also discuss a diagram that will like diagrammatically show the attachments of the ligaments, okay. And talking about bursa, we'll talk about bursa, the movements, and your applied anatomy also, okay. And relations are not important in your knee joint relations are not important. And we'll talk about the movements also, and locking and unlocking is, we'll talk about this. And some applied anatomy of knee joint. You can write a host of things, and we'll also discuss some other clinicals also. Okay, so talking about this collateral ligaments, we have a medial collateral ligament and the lateral collateral ligament, okay. So medial collateral ligament is attached to the medial femoral epicondyle to the shaft of the tibia, and lateral collateral ligament is attached to the lateral femoral epicondyle to the head of the fibula, okay. Medial femoral epicondyle to the shaft of the tibia, and lateral femoral epicondyle to the head of the fibula, okay. And medial collateral ligament is broad and fan shaped, while the lateral collateral ligament is narrow and cord like, okay. You can just see here if collateral ligaments are visible, okay. Here you have a fibular collateral ligament, okay, or a lateral collateral ligament, and the tibial collateral ligament, or superior part and the deep part, Okay, so the fibular collateral ligament, okay, or your lateral collateral ligament, and a tibial collateral ligament is also called as a medial collateral ligament. Okay, then what is the shape? Shape of medial collateral ligament is broad and fan shaped, while lateral collateral ligament is narrow and cord like. Functions prevent excessive abduction, and lateral collateral ligament prevents excessive adduction. Okay. Then phylogenetically, the fibers of adductor magnus are forming a medial collateral ligament. Adductor magnus, MM, you can remember M for M. Okay, magnus for medial collateral ligament, and the fibers of a peroneus tertius is forming a lateral collateral ligament. Peroneus tertius is forming a lateral collateral ligament. Okay, and attachment is it is attached to the meniscus. Medial collateral ligament is attached to the meniscus. Okay, the menisci, and your lateral collateral ligament is not attached to the meniscus. We have talked about this also. Okay, so if you want to see in the diagram, this is the medial collateral ligament, this is the medial collateral ligament. Okay, and you can see here the lateral collateral ligament here, Okay, so you can see the medial collateral ligament is attached to the lower part of your femur. Okay, and it's attaching to the shaft of the tibia, Okay, and the lateral collateral ligament, which is attaching from the lower end of the it is originating from the lower end and is attaching to the head of the fibula, Okay, and we also talked about this, that the medial collateral ligament is broad and fan shaped, while the lateral collateral ligament is narrow and cord like. Okay, so you can see here also it is like bit thick. Okay, it is fan like and broad, and this lateral collateral ligament is very cord like. Okay, cord like and thin. Okay, you can just draw a diagram like this. You can just make a like the lower end of the femur, you can draw the menisci here. You can draw the menisci, your medial menisci and the lateral menisci. Okay, then sorry, this is a medial meniscus and this is a lateral meniscus. Okay, lateral meniscus, just see, it is not attached to the fibular collateral ligament or the capsular ligament. It is attached to the tendon of the popliteus. Okay, so tendon of popliteus is separating the lateral menisci to the from the fibular collateral ligament or your lateral collateral ligament. Okay, and this is your lateral menisci. You can have your tibia here. Okay, tibia here, which is present medially, and your fibula is present laterally. Understood? You can draw this diagram to show your ligaments. Okay, and we can be asked some question like the tendon of popliteus, your anterior cruciate ligament, the posterior cruciate ligament, and the meniscofemoral ligament, that posterior meniscofemoral ligament. Okay, these ligaments are intracapsular. Okay, these are intracapsular but are not included in the synovial covering. So the intracapsular but extra synovial. Just remember which components are intracapsular but extra synovial. So you can write tendon of popliteus, ACL, PCL, and your meniscofemoral ligament. Okay. Talking about the bursa of the knee joint, so there are about 4 bursa that are present in the knee joint. Okay, so if you say this is your femur, okay, we are seeing from the side. So this must be the posterior part. This is the posterior part. This is the lateral part which you are visualizing, and this is the anterior part. So you can see the patella here, and we have a suprapatellar bursa. Okay, the patella is present over like this. Patella is present. So I have a bursa above the patella, which is called a suprapatellar bursa, and a bursa which is just below. Okay, and is your deep infrapatellar bursa. Okay, so suprapatellar bursa, which is present above the patella. Okay, and prepatellar bursa, which is present before the patella. Okay, and the inflammation of the prepatellar bursa causes a condition which is called as your housemaid's knee. Must have observed the housemaids which are sitting on the knees and wiping up the floor. Okay, it is called as a housemaid's knee. It is an important clinical. And the deep infrapatellar bursa has 2 parts. That is a deep infrapatellar bursa, the superficial infrapatellar bursa. So deep infrapatellar and superficial infrapatellar. Okay, so the patella which is present just posterior, to patella, it is called as which is present deep to the patella. Okay, it is called as a deep infrapatellar bursa, and which is present superficial to the your patella. This is called as a superficial interpatellar bursa. Okay, and the inflammation of the superficial interpatellar bursa causes a clergyman's knee. Okay, so you know about the housemaid's knee and the clergyman's knee. Okay, the clergymen are generally the people who are praying in the church. Okay, so they are just sitting a long time for in their knees. Okay, and it is causing the inflammation, bursitis. Okay, and it is the inflammation of a superficial infrapatellar bursa. Relations of knee joint are not important, as I said. The movements: flexion, extension, locking, and unlocking. Okay, flexion. What will be the flexors of knee joint? Okay, all the muscles which are in the anterior compartment, okay, which are in the medial compartment, are your flexor muscles. Okay, so we have some muscles which are called as the gyropes. Gyropes. Okay, gyropes. Sorry. So gyropes, what are the gyropes? Your sartorius, gracilis, and all your hamstring muscles, like your semitendinosus, semimembranosus, and your biceps femoris. These are your hamstring muscles, you know. Okay, and your sartorius and your gracilis. These all muscles are called as a gyropes muscle. Okay, and this extension is done by the quadriceps femoris, and your tensor fascial lata. Quadriceps femoris and your tensor fascial lata. Remember, we read about the knee, your hip flexors or the knee extensors. Okay, we read in your anterior compartment. Okay, so in extensors we have a quadriceps femoris and a tensor fascial lata. Okay, in the locking part, what is locking? Locking is the medial rotation of femur on the tibia. Okay, at 30 degree of extension, which is called as a locking of your knee. Okay, medial rotation of your femur on the tibia at 30 degree of extension of knee, it is called as a locking. Okay, so locking is done by quadriceps femoris. It is your same muscle as which you are doing the extension. Okay, and unlocking is done by popliteus. Okay, locking quadriceps femoris and unlocking is done by popliteus. This popliteus causes lateral rotation of femur on tibia to initiate the flexion of knee. It is called as the unlocking movement. Talking about the applied anatomy. Okay, so knee joint has increased chances of your osteoarthritis. Medial meniscus is more prone to injury. What is the cause? Because it is attached to the tibial collateral ligament. Okay, and lateral meniscus is just independent. Okay, not attached to any ligament, which attached to any collateral ligaments like your fibular collateral ligament or so. So it is not very prone to injury. Anterior cruciate ligament injuries are more than a posterior cruciate ligament injuries. Okay, then we have an unhappy triad of your knee joint. Okay, unhappy triad of your knee joint. Okay, which is the combination of injury of your tibial collateral ligament, your medial meniscus, which is attached to the tibial collateral ligament, and the anterior cruciate ligament. Tibial collateral, medial meniscus, and your anterior cruciate ligament. Okay, this unhappy triad of this knee joint is also called as a triad. It is also called as a terrible triad of O'Donoghue. Okay, terrible triad of O'Donoghue. Okay, this is also called, just try to relate. Okay, this unhappy triad is also called as your terrible triad of O'Donoghue. Okay, so it is a combination of your tibial collateral ligament, your medial meniscus, okay, and your anterior cruciate ligament. Then we have the extensor apparatus of the knee joint, okay, which is formed by the tendon of quadriceps, your patella. This is the tendon of quadriceps and the patella, and okay, and your ligamentum patelli. Okay, this is a ligamentum patelli. I have not written the complete thing. Ligamentum patelli. Okay, and a tibial tubercle, which is attached to the tibial tubercle. Okay, so violent contractions of quadriceps muscle can avulse the tibial tubercle. Okay, if there's violent contractions in the quadriceps, in the tendon of quadriceps, there are violent contractions. Okay, this can cause the avulsion of your tibial tubercle. Okay, this is important clinically. This is called as extensor apparatus. Extensor apparatus contains extensor apparatus. It is the continuation of your tendon of quadriceps, your patella, and your ligamentum patelli. Okay, this 1 plus 2 plus 3, this forms your extensor apparatus. Talking about Q angle is the quadriceps angle or a Q angle. Okay, so Q angle is formed. This is the angle between the line of the pull of your quadriceps femoris muscle, line of pull of quadriceps femoris to that of ligamentum patelli. Okay, so it is a line of pull between the quadriceps femoris, okay, to the action of a ligamentum patelli. This is the action of the ligamentum patelli, which is straight, okay, and is crossing the placenta and the center of the placenta, your patella, not placenta, sorry. And your pull of your quadriceps femoris is like from the ASIS, it is going to the center of the patella. Okay, so an angle is formed here. Look at the angle. This is a small angle is formed here. Okay, this is called as a Q angle. In men it is about 10 degree, in women it is about 15 degree. Why females have a more pronounced Q angle? Because they have a wider pelvis, okay, and greater lateral division of femur from the long axis of the leg. Okay, so it is the long axis of the leg which is representing your pull of your ligamentum patelli muscle, okay, and the line of pull of your quadriceps femoris, line of pull of the quadriceps femoris is it is like this, okay. So Q angle more than 15 degree, if that is Q angle more than 15, it can cause a patellar subluxation, or this patella, it may dislocate. If there is more than Q angle more than 15 degree, more than 15 degree will cause your patellar dislocation, okay. And talking about this is called as a genu valgum, okay, look at the knees, this is called as a genu valgum or your knock knee deformity, okay. This occurs in a genu valgum like this, okay. This leg is affected by a genu valgum here in this patient. The left leg is genu valgumized, okay. And about the patella, important clinicals are there, like a patella has a tendency to dislocate laterally. It has a tendency to dislocate laterally due to tightness in the extensor mechanism, okay. It is present in an extensor apparatus, okay. So the patella, it can dislocate, the patella can dislocate, and which common dislocation is there? The lateral dislocation. The lateral dislocation of patella is very common, okay. This line of pull of your quadriceps, this line of pull of your quadriceps and the line of pull of your ligamentum patelli, okay. This both components, okay, these are your just your vector addition as you do in physics, okay. This is a line of pull of your quadriceps, okay, and this is a line of pull of your ligamentum patelli. This can generate a force like this can generate a force like this, okay. And if patella is present, it can dislocate laterally, it can dislocate lateral dislocation, okay. It can dislocate your laterally, okay. And dislocation is prevented due to forward projection of a lateral condylar femur. Your lateral condylar femur is like present, okay, and is projected forward, due to which it holds the your patella in place, and attachment to the vastus medialis, okay. The vastus medialis is also attached, due to which the dislocation is prevented. But if there is more tightness in extensor mechanism, of course the patella has a tendency to dislocate. And recurrent dislocation of patella, it is due to your smaller high placed patella, which is called as a patella alta, okay, or underdeveloped lateral condyle, due to which the lateral condylar femur is not now projecting, okay. There is weakness and ligamentous laxity, okay, the ligaments are not working well, and increased Q angle will cause patellar dislocation. And talking about some abnormal patellae, okay, so we have a patella that is called as a bipartite patella. Look at this, patella is of two fragments, okay. This is called as a bipartite patella, okay. And we have many types, like a superior lateral bipartite or lateral bipartite, superior lateral tripartite patella may be present in some individuals, and a superior lateral tripartite type, okay. So these are your tripartite and bipartite patella. Talking about another disorder, which is runner's knee. Runner's knee is also called as a chondromalacia patelli, and it is the soreness and itching deep around and deep to the patella. Okay, if there is soreness deep to the patella, due to prolonged running, the patella will glide up and down due to repeated friction of this patella. Okay, there is the irritation of the articular cartilage, which can inflame and cause a chondromalacia patelli, which is also called as a runner's knee. Mostly in athletes it occurs, okay. And talking about anatomical angle of knee joint, there is an anatomical angle of knee joint, okay, which is the valgus angle of knee joint, which is called as the valgus angle of knee joint. It is about 170 to 175 degree, okay, and less than 165 degree will cause a genu valgum or a knock knee disorder, and more than 180 degree will cause a genu varum or a bow knee, okay. This knock knee and bow knee, these two things are there. It is less than 165, your knock knee, and it is more than 180, it is called as bow knee. It's called as genu varum, okay. And long run, this genu valgum and genu varum will cause your osteoarthritis. Understood? Okay. Then we have the anterior drawer sign and the posterior drawer sign. Let's see what are they. Anterior drawer sign and the posterior drawer sign. Let's discuss about them. So anterior drawer sign, this is the tearing of an anterior cruciate ligament, and posterior drawer sign is the tearing of a posterior cruciate ligament. Okay, this you know the action of the cruciate ligaments. Due to ruptured anterior cruciate ligament, the tibia can be pulled excessively forward. Okay, there is no restriction now for the tibia to glide excessively forward. Okay, so tibia can be pulled excessively forward on the femur, which is called as the anterior drawer sign. And if there is rupture of posterior cruciate ligament, the tibia can be pulled excessively backward on the femur, due to no restrictions. This is called as your posterior drawer sign. Okay, so this completes the clinicals of the knee joint. Okay, so now let's discuss some clinical anatomy, okay, which I might have left from the BD Chaurasia. Okay, so we are discussing the clinical anatomy of your lower limb from the BD Chaurasia. So let's discuss. Okay, so femoral nerve, how to test the femoral nerve? Femoral nerve can be clinically tested, okay, by doing the patellar jerk. Okay, patellar jerk. So patellar jerk is for your femoral nerve injuries. Okay, and here the ligamentum patellae, okay, is hit by the hammer and contraction of the quadriceps is felt. Okay, this is patellar jerk is for your testing of your femoral nerve. Understood? After that, your there is a problem that obturator nerve supplies both the hip and knee joints, so pain may be referred. Okay, I have told about this. Okay, and about your Trendelenburg sign we have known. Okay, and there is a syndrome called as sleeping foot. Sometimes it happens that one is awake but the foot sleep. Okay, foot is not literally like the foot is not sensitive. Okay, because the sciatic nerve that lies between quadratus femoris and adductor magnus. Okay, and if the nerve get pressed between the femur and the hard edge of the table, chair or bed, okay, there is numbness of the lower limb till the foot is hit against the ground. Okay, and then only the sensations come back. So sleeping foot is the loss of sensations of the foot. Okay, and why it happens? Due to the sciatic nerve, and because the sciatic nerve get pressed between the femur and the hard edge of the table, chair or bed upon which you are sleeping. Okay, and you know about the foot drop we had known. Okay, and sciatica is the radiating pain in the back of the lower limb due to slip disc. Okay, your IV discs are present, okay, between the vertebrae. Okay, let's say this is a vertebrae and this is the vertebrae. Okay, so I have the IV discs present, intervertebral discs. So these are your IV discs, and this IV disc has two components. Okay, this IV disc has two components like this. The fibrocartilaginous disc has two components, and this part is called as a nucleus pulposus. Okay, nucleus pulposus. So this is a pulpy part, and if it gets slipped, okay, the IV disc can be displaced like this. Okay, and due to the slip disc, there is the damage to your sciatic nerve, causing your sciatica. Okay, sciatica. And yes, a important statement that the common peroneal nerve is the most commonest nerve to be paralyzed. Okay, due to fracture of neck of fibula. Okay, and lathi injury on the lateral side of knee joint or to plaster of leg. If there is a strong plaster, okay, or the cast is there on the leg. Okay, so it can compress your it can cause your fracture of the neck of fibula. Okay, as fibula is a feeble bone. Okay, it is not much strong, and due to this you can suffer from your common peroneal nerve injury. Okay, we have learnt about all the things that are in the common peroneal nerve injury, the foot drop and all. Okay, these are there. After this we have the arterial occlusive disease of the lower limb. Okay, occlusive diseases causes ischemia of the muscles, ischemia of the muscles of the lower limb leading to cramp like pain. Okay, and this condition is known as intermittent claudication. Is the cramp like pain which disappears with rest, okay, but comes back with activity. Okay, it's the cramp like pain of your lower limb muscles. Okay, understood? After this we have few other clinicals like your which is important. Yes, excessive fluid from the knee joint can be aspirated by putting a needle in the joint cavity from the lateral side. Okay, this is the knee joint is aspirated from its lateral side, putting a needle in the joint cavity. This is there. And from clinical terms, your policeman heel is that there is plantar fasciitis. There is plantar fasciitis of the plantar aponeurosis of the plantar aponeurosis, if there is fasciitis, the fascia is inflamed. Okay, like the policeman has to stand for long hours, they can often suffer from your policeman's heels due to the plantar fasciitis. Okay, and dipping gait is the gait if the muscles get paralyzed, like gluteus medius and the gluteus minimus. Okay, gluteus medius and gluteus minimus, these muscles are, if they are paralyzed on the right side, okay, left limb becomes difficult and it dips down when you try to lift it. Okay, this is called as a dipping gait. We have talked about your weaver's bottom and meralgia paresthetica. We have talked about this, and we have talked about the housemaid's knee and the clergyman's knee also. Inflammation of the prepatellar bursa causes a housemaid's knee, and inflammation of the subcutaneous infrapatellar bursa causes a clergyman's knee. Okay, and after that we have our closed back position of ankle joint when there is dorsiflexed ankle joint. Okay, when there is dorsiflexion of ankle joint. Okay, and your talus fits into the lower end of your tibia, which is called as a closed back position of your ankle joint. Okay, and then your Fresser's syndrome, just see another syndrome is there, that is a Fresser's syndrome. What is Fresser's syndrome? Fresser, you know, which come to the college for the first time, like they have to stand upon the like they have to stand for longer periods of time due to interaction and all. Okay, they are compelled to run by the stronger students, your senior students, or they have to stand for longer periods of time. Okay, so Fresser's syndrome may occur in them, like an overextension of the muscles of anterior compartment of leg causes edema of leg. Okay, and this results in the pain of leg. Okay, so there is overextension of the muscles of the anterior compartment of leg. Okay, which causes an edema of your leg. Understood? And site of intramuscular injection, you know, it's the upper lateral quadrant of gluteal region. The muscle pierced, it is a gluteus medius. Gluteus medius is pierced in your intramuscular injection. This is an important fact. Understood? And site of pulse palpation in the lower limb. Okay, what are the sites of pulse palpations? How can you palpate the pulse? In the femoral artery and popliteal artery, posterior tibial, dorsalis pedis. Okay, and this popliteal artery is used for auscultation to measure blood pressure in the lower limb. Okay, then we talked about the tarsal tunnel syndrome. We talked about this. We talked about injury to medial meniscus. We talked about the cruciate ligaments. Okay, and there is a term which is called as a pes planus. Pes planus is also called as a flat foot. Okay, it is also called as a flat foot. This is the absence or the collapse of the arches of the foot. Okay, absence or collapse of the arches of the foot, which leads to pes planus. Okay, there another thing, have we discussed the arches of the foot? I guess we left out that part. Okay, so let's discuss the arches of the foot. I have left out that part. Okay, let's discuss it first. So here I had left a concept, that is arches of the foot. First we will to discuss about the skeleton of the foot. How is the foot made? Okay, so I have a bone which is called as your talus. This is your talus bone. Okay, this is this whole part. Let's take some other color like this. Okay, this whole part is the talus. Okay, and this bone is a big bone which is your cuneiform. Okay, cuneiform, and we have a cuboid here. Okay, and your all three cuneiforms are there. Okay, and your navicular bone is there, your cuboid bone, and your cuneiforms. There are three cuneiforms. Okay, and your navicular and talus and your calcaneum. Okay, and there is the point between the navicular, talus, and your calcaneum. This is called as a TCN joint. Okay, or navicular calcaneal joint. Okay, and that is your TCN joint. Okay, and your CC joint is there. CC joint is between cuboid and your cuneiform. Okay, and this two phalanges. Okay, this two, sorry, not phalanges, these are your bones of your lower limb. So this, you can't call this phalanges. You can of course call it phalanges, but it's not like absolute, it's the absolute term. You can call it the digits of the foot. Okay, so this two digits, there's this two, so this two phalanges and sorry, digits of the foot, and the cuboid bone, and this calcaneum bone, a part of calcaneum which is forming a lateral longitudinal arch, and your medial longitudinal arch is formed by this all. Okay, so these are formed by 9 bones and these are formed by 4 bones. Lateral arch by 4 bones, the medial arch by 9 bones. Understood? After this, what are the factors which are affecting the arches? Like we have wedge shaped bones. Okay, wedge shaped bones Okay, the bones are shaped like wedges, okay, which are helpful to form their arches. Okay, and intersegmental tires, we have some staples or intersegmental tires like this. These are your intersegmental tires, okay, which are present between the bones, and this act as slings. And we have tie beams. This is the tie beam which is holding together these bones in this arch like shape. Okay, and then we have slings and suspensions which act as inverters or everters of foot. Okay, so you can see here, you can see these bones here. Okay, these are the calcaneum, this is a talus and your navicular bone. Okay, and there is a spring ligament which is present between your sustentacular notch of a calcaneum, to the navicular bone, which is called as a spring ligament, and it supports the head of the talus. It supports this talus is present like this. It supports the head of the talus. Okay, and we have this calcaneum cuboid and this type of that digit of your foot. Okay, and we're seeing the sagittal section from the side. Okay, so we have your SPL, that is a short plantar ligament. Okay, and LPL, that is a long plantar ligament. Okay, and also the ligament of peroneus tertius, which are supporting this arch. Okay, so talking about this medial longitudinal arch and lateral longitudinal arch, so this is a table which you must make in your exam. So the summit of the arch is formed by the superior surface of the body of talus. Okay, medial longitudinal arch was formed by the superior surface of the body of the talus. Okay, so you can just see like this. Okay, you can just appreciate the talus is forming the summit. Okay, and here in the lateral longitudinal arch, and the calcaneum, that is forming a summit. Okay, this calcaneum is forming the summit. Okay, this calcaneum is present like this. Okay, and so this is your medial longitudinal arch. So in medial longitudinal arch, this is the lateral longitudinal arch. What is a joint? You have your TCN joint. Okay, which is a ball and socket type of joint, and in lateral longitudinal arch you have the CC joint, that is a calcaneocuboidal joint. Okay, which is a saddle joint. Calcaneocuboidal joint is a saddle joint. Okay, and TCN joint is a ball and socket joint. Just note this. Then you have intersegmental tires. In the place of intersegmental tires, which ligaments are acting like the intersegmental tires. In medial longitudinal arch, we saw there is a spring ligament here. There is a spring ligament which is forming the intersegmental tire for the medial longitudinal arch. This is also called as the plantar calcaneonavicular ligament. Okay, so joint is a talocalcaneonavicular joint. Okay, and the ligament is your plantar talocalcaneonavicular ligament, which is also called as a spring ligament. And for lateral arch, we have your short and long plantar ligaments. We have your short and long plantar ligament, SPL and LPL. Tie beam, what are the tie beams? Tie beams are formed by the plantar aponeurosis. The plantar aponeurosis is forming the tie beam, tendons of FHL and medial half of FDB. Okay, these are forming the tie beams. Okay, these are forming the tie beams. These are the tie beams. Okay, these are your tie beams. So this is formed by your plantar aponeurosis, your tendon of FHL, flexus hallucis longus, and the medial half of FDB. And here in lateral longitudinal arch, the tie beam is formed by, again, your plantar aponeurosis, your lateral half of FDB, and your abductor digiti minimi, which will form your tie beam. Okay, and slings, about the slings are here the inverters. Okay, and here the slings are your everters. Okay, so the main sling of the medial longitudinal arch, that is your tibialis posterior. Is the main sling. Okay, and the peroneus longus. Okay, this is the main sling, or the fibularis longus is the main sling of your lateral longitudinal arch. So inverters are the main slings of your medial longitudinal arch, and everters are the main sling of your lateral longitudinal arch. And if there is a defect in the ligaments or the tie beams or the slings, okay, like if this is not working, this tie beam will not work. Okay, then the bones will be just flat. Like this, and this is called as a flat foot. Loss of arches is called as flat foot. Okay, flat foot. Okay, and this we told that it is also called as a pes planus. Understood? So this completes your foot. This completes your foot, and as a whole we completed our lower limb. Okay, so in this video we generally talked about your upper limb. Okay, so this is a video mainly of your extremities of your upper limb. Okay, upper limb, lower limb. Okay, and we also talked about not your embryology, we talked about the anatomy, we talked about the medical anatomy. Okay, and not your anatomy, that's your genetics, what I'm writing, genetics. Okay, we talked about your genetics, that's a medical genetics. So upper limb, lower limb and genetics, this we made the first video of your anatomy marathon, because anatomy is very huge. Okay, and it is already very late. Okay, so in the first part we are making the video of upper limb, lower limb and genetics. Of course, we are, as you can see, we are covering each and every fact, each and every point, and many of your clinicals. Okay, you have a sufficient clinical to write, and we are explaining each and every concept. So this is done, and in the next video, we'll discuss about the another chapters of anatomy. Okay, so that's all for today, that's all for today's video. Okay, thank you and have a great day ahead, and good night. Okay, bye.